Assalamu alaikum wa rahmatullahi wa barakatuh. Would like to welcome everyone back to day 2 from Emirates Oncology Society 5th edition, and would like to start with our most exciting part, which is GI oncology. Would like to welcome Dr. Faq Jamali, who's a consultant surgeon specialized in colorectal at Cleveland Clinic, and also our friend and colleague Dr. Majid Al-Ghamdi, who's a consultant radiation oncologist at Burjeel Cancer Institute. And we'll start the session with a very interesting debate with Dr. Ibrahim Abu Ghida, who will be debating with Dr. Hampeek Khoury about rectal cancer TNT upfront RT versus upfront chemo. What should we do for this patient? Who wants to go first? Dr. Ibrahim? Hampeek? Okay, so we'll start with Dr. Hampeek, who is a hematology oncology department, assistant professor, faculty, St. Joseph University. He was actually planned to be here in person, but unfortunately didn't happen. So welcome, Dr. Hampeek, and he will be talking about upfront chemotherapy, better than upfront radiation in rectal cancer. Let's listen and then we'll decide. Do we have voting or we don't have voting? We should have voting before. Yeah, so let's do the voting first. So we'll assume it's locally advanced rectal cancer indicated for neoadjuvant treatment. And the question is, will you go for upfront chemotherapy versus upfront radiation followed by the other modality? People still asleep, so only 8 responses so far. Okay, so we'll just maybe another 5-10 seconds. 50-50. Interesting. Okay, so 21 votes, 57 versus 43. Can we take a screenshot for this? Okay, so let's say, no, it's coming. More medical oncologists joining, I guess. Okay, so let's hold and let's start with the talk. So 60, make it easier, 60, come on, keep changing. Okay, 60-40. 60 favoring chemotherapy over upfront radiation. Dr. Hampeek, the mic is yours.
So when we see the overview in the last 25 years in the management of rectal cancer, we can see that we have a lot of advances. Things changed mainly in the 2020 after 15 years of standard of care of long course chemoradiation therapy. And we can see that in 2020 with Rapido and Prodige trial, we have a change in the treatment of rectal cancer with the approvals of TNT. What is important to mention that we will discuss during this debate, the MSS rectal cancer, since we know that the MSI high today are being treated with immunotherapy upfront, and the immunotherapy is clearly sufficient to omit all other treatment modalities. And also in 2023, another interesting trial, the Prospect trial, tried to omit the radiation therapy and its side effects. And we can see clearly that the FOLFOX in certain patients, T2 and plus T3 patients, may be beneficial for patients with rectal cancer. So this was for 15 years, the standard of care, many meta-analysis. We didn't have an overall survival advantage with chemoradiation therapy, but we have a control of local recurrence. So we need more advances in the management of rectal cancer. In starting 2020, the concept of total neoadjuvant therapy in rectal cancer become one of the standard of care. So when we talk about TNT, we have two pivotal trials, the Rapido and the Prodige 23. The Rapido trial mainly is focusing on upfront short course radiation therapy, followed by chemotherapy in the experimental arm, followed by surgery. We have different patient characteristics in two trials. In the Prodige 23, we had an induction chemotherapy, upfront chemotherapy with FOLFIRINOX, the French regimen, followed by standard course chemoradiation therapy, followed by surgery, plus or minus chemotherapy in the adjuvant setting. And this was the second experimental arm. So when we see the Rapido trial design, we have major advantage by using the TNT. We have a pathological complete response of 28% versus 15% in the standard long course chemoradiation therapy. And also in the Prodige 23, we had also an advantage using the upfront chemotherapy with pathological complete response of 28% versus 12% for the standard of care at that time. So is upfront chemotherapy superior to upfront radiotherapy in TNT rectal cancer? Let's check first the NCCN guidelines. In the NCCN guidelines, we don't have any preference for upfront chemo or upfront radiation therapy. So both methodologies are accepted. What is an important point, and this is interesting argument to be discussed, that Prodige 23 with upfront chemotherapy, the FOLFIRINOX, the 7-year outcome showed for the first time, and it's the only trial showing significant improved DFS and OS with induction chemotherapy prior to preoperative chemoradiation therapy compared with standard of care. And this is an interesting point because what is our main objective in treating rectal cancer? Is it the PCR or we are aiming for better overall survival? We have two important trials comparing head-to-head the induction and consolidation chemotherapy. The first one is the FOCUS trial, trying to compare induction chemotherapy followed by chemoradiation therapy, then surgery, versus induction chemotherapy followed by chemoradiation. And the second one is the OPRA trial, trying to compare with primary endpoint is organ preservation, also trying to compare the induction versus consolidation chemotherapy. So in this FOCUS trial, we have very remarkable higher pathological response in the arm where we are starting with chemoradiation therapy followed by chemotherapy. So we have more pathological complete response in the induction radiation therapy or upfront radiation therapy. So is consolidation therapy truly superior to induction therapy? This is an important question. The PCR is higher. However, there is no difference in 3-year disease-free survival and no difference in 3-year incidence of metastasis. But the most important point is the key confounding factor between the upfront radiation therapy and the upfront chemotherapy. Why? Because in the first arm where we have the induction chemotherapy, the duration from the end of chemoradiation to surgery is only 45 days versus in the second arm where we are starting with chemoradiation therapy, the duration is 90 days. So we have double time from CRT to surgery in the consolidation group versus induction. So we have an impact of extended interval possibly greater than sequence itself. So we are not here able to compare the sequence only. Here, the confounding factor is really important to be mentioned, and longer interval allows for greater tumor shrinkage, favoring the consolidation in this case. So need for equal timing to eliminate confounding factor and ensure clear comparison. So we have better PCR, but is it an artifact or it's a real advantage by starting chemorad? This is the important question. Second important point also to be commented in this trial is that induction chemotherapy before chemorad allows adjustment of treatment intensity based on clinical response. So once we start with chemotherapy, then we can decide if we have a very good response, maybe to decrease the radiation dose, or if we don't have response, to use higher radiation dose. And also the Prospect trial, who was a game changer in 2023, also is adopting these strategies of starting with the chemotherapy and based on the response to see if we will go for chemoradiation therapy or maybe directly to the surgery. So adopting based on induction chemotherapy, the next step is becoming one of the new modalities. So also starting with chemo in this case will be more beneficial. We have a lot of radiation therapies mentioning that if we don't start with radiation therapy, probably we will have more local progression and the chemotherapy will not be sufficient. And in this trial, also by FOCUS, we can see clearly that we have minimal tumor progression with induction chemotherapy and strong disease control. Let's move to the second trial, OPERA trial, also comparing induction versus consolidation chemotherapy. For sure, we have better TME-free survival, and this also can be related for the duration between the end of chemoradiation therapy and the evaluation, but we don't have any disease-free survival difference, any overall survival difference, and any metastasis-free survival difference. What is also interesting that the compliance will differ based if we are starting with induction chemotherapy or chemoradiation therapy. You can see that in patients where we are starting induction chemotherapy, the compliance to chemotherapy is 99% versus the chemotherapy consolidation compliance is only 94% when we are starting with chemoradiation therapy. So patients who will benefit from chemotherapy more, those patients who have tendency to have more systemic disease, the N2 patient, lymphovascular invasion, maybe the chemotherapy with the higher compliance will be more beneficial in the induction than in the consolidation phase. So this was a very interesting summary from Leuven Rectal Cancer Protocol 2023, where they chose in every circumstance, if we have risk factor for systemic recurrence, to start with the modified Rapido. If risk factor for local recurrence, maybe discuss the OPERA, and if we have risk factor for both systemic and local recurrence, to go to Prodige. So it's really case-by-case discussion to see which one to adopt. As a comparison between upfront chemoradiation versus upfront chemotherapy, the PCR is higher in upfront chemoradiation therapy, and this will be mentioned for sure by our colleague, Dr. Abu Hida. However, we should mention with it that the time from the end of radiation therapy to surgery is longer, so we will have more shrinkage in the tumor. We have similar disease-free survival and metastasis-free survival. Regarding the overall survival, only in Prodige 23, we have an advantage in overall survival using the upfront chemotherapy. The symptoms control is similar in both modalities. Tumor progression is unremarkable in both under upfront chemorad or upfront chemotherapy. The TME-free survival is higher in upfront chemoradiation therapy. Regarding the better disease control, we have maybe local control with upfront chemoradiation therapy and more systemic control with upfront chemotherapy. And this is related to the compliance to chemotherapy, which is better with upfront chemotherapy compared to chemoradiation therapy. So my take-home message, no clear preference for induction or consolidation in current guidelines. We have an improved overall survival only in PRODIGE 23, maybe favoring induction chemotherapy, comparable disease-free survival, overall survival, and metastasis-free survival between both arms, but higher PCR in the consolidation arm, likely due to longer interval between radiotherapy and surgery, and this is in FOCUS and OPERA trial. We have flexibility in radiation therapy sequencing after induction chemotherapy, and this is inspired also in PROSPECT trial. Similar local progression rate in both induction and consolidation arm in the FOCUS trial, higher TME-free survival in the OPERA trial in the consolidation arm, and finally, greater chemotherapy compliance during induction chemotherapy, providing probably better systemic control. Finally, it's very interesting, all we talk about, but the interdisciplinary management remains essential in all cases of rectal cancer treatment. That's why together, medical oncologists, radiation therapists, and other tumor board members should discuss every rectal cancer case to offer the best for our patient. Thank you.
So good morning, everyone. Good to be here. Sabah al-khair. Congratulations, Dr. Hamid and the entire EOS committee for this very successful event and very scientific content. And thank you so much, Dr. Hampeek, for your very enriching talk. We wish that you were here with us in person, inshallah, next year. And we send you all our prayers and regards from Abu Dhabi. So today, the purpose of this debate, because every time, as Dr. Hampeek, I'm going to start where Dr. Hampeek ended. In our multidisciplinary tumor boards, whenever we see a rectal cancer case, we start thinking, should we start with chemo? Should we start with radiation? Should we omit radiation? Should we omit surgery? So I'm not going to be talking about surgical omission, and I will be talking, or radiation emission, obviously, but I will be talking about this. This is the outline of my presentation. Just brief discussion about the role of radiation in rectal cancer, the emphasis on the duration between radiotherapy and the response rate, the pathological response and outcome correlation, utilizing the gap with chemotherapy, and the highest chance of avoiding surgery. And finally, I will end with the 2024 guidelines. So this is the same slide that was shared. Again, this is the NCCN guidelines discussing the same patient population. I will not be talking about the third, omitting radiation. Technically, our debate today is between these two, starting with long course chemoradiotherapy, followed by chemotherapy versus chemotherapy followed by long course, followed by, obviously surgery if needed. So we know that the more time between the radiation, the higher the pathological complete response. And this is based on multiple trials. This is a very nice multi-central, non-randomized phase 2 prospective trial that showed that the more time we wait, the higher the pathological response rate after chemoradiation. So does pathological complete response improve the outcome? So we all know that the answer is most likely no. However, it's interesting to see that in this meta-analysis that included 12 studies with up to almost 6,000 patients, we can see that pathological complete response might affect the outcome of the patient. And this really shows, and it clearly shows that all patients who have pathological complete response are a higher chance of progression-free survival and potentially overall survival as well. So again, thanks to my colleague, Dr. Jamali, who helped me actually with this slide. So the other question is that overall treatment time. We all know that when patients get diagnosed with cancer, we want to try to treat them effectively, efficiently, with the least amount period of time needed. So again, if you look at between arm A and arm B, when we start with radiation, and go to chemo, we don't need to wait 2 months to go for surgery. We can go in 1 month after chemotherapy with restaging and surgery. While when we start with chemotherapy and then we start with chemoradiation, we need to give time for the chemoradiation to be effective. So we wait 2 months. So that's additional months where the patient is not being treated. We're not sure what's happening with him, the anxiety, the delays, etc. So this is also very important to keep in mind when we're talking to our patients and counseling our patients. So the overall treatment time is shorter with upfront concurrent chemoradiotherapy, despite that we're using the same duration of chemotherapy and radiation, but the waiting time is less in arm A than in arm B. So again, why do we need to, debate something that has been already discussed or presented in a phase 2 trial? And this is the same trial, the German trial that Dr. Hampik discussed. And this shows that the pathological complete response was higher in the upfront chemoradiotherapy arm and better compliance as well than chemotherapy followed by chemoradiotherapy. So it makes sense that this is our option. Also similar to that, this is the highest chance of organ preservation is when we start with chemoradiotherapy followed by, and this is really shown in the OPERA trial where the TMA-free survival was highest when we start with upfront chemoradiotherapy. Of course, there was no difference with local regional recurrence or distant metastasis. So finally, when we look at the guidelines, ASCO has recently published 2024 guideline, and this is kind of the big schema, but I just zoomed in these patients that we're looking for. So when we say TNT should be offered, it's very clear, based on the evidence that I just presented, that long course chemoradiotherapy followed by chemotherapy is preferred. So this really, tells us why, based on the evidence that I've just showed, why this is probably the safest and the best option for the patients who meets these criteria, specifically T4, EMVI, etc. And I'll mention those next. And moreover, if you want to look at what is the current practice, what's the future in rectal cancer? So the Janus trial right now is currently a very hot trial, accruing a lot of patients in the US and North America and probably in Europe. And in this trial, you see that it's a discussion of the type of chemotherapy, but upfront chemoradiotherapy is the first line in both arms. So it is the standard approved for these patients. And the primary endpoint is pathological response and the organ preservation, time, disease-free survival, overall survival, and they're also experimenting circulating tumor cell DNA in this trial. So to conclude, locally advanced rectal cancer, I'm talking about T3, T4 node-positive disease, after full radiological and pathological investigation, is managed in a multidisciplinary tumor board, but for low rectal tumors, T4, EMVI, or solid tumor deposit, threatened mesorectal margin or intersphincteric plane, we strongly believe that upfront radiation with chemotherapy, long course, is a winner by evidence, logic, and expert consensus. With that, I would like to thank you all for this, and hope you guys have some time to visit us in Burj Medical City in Abu Dhabi, and to visit our newest and the most comprehensive cancer institute, Burj Cancer Institute, which I'm very happy and privileged to be part of. Thank you so much.
Thank you, Dr. Ibrahim. Thank you, Dr. Hamping, for this very interesting talks and debate. So I think we should go for the voting first and then discussion. So before we open the floor for discussion, which will be primarily moderated by Dr. Faik, my take out of these two presentation, if you wish, is actually when you start with long course chemoradiation, you are having better pathological complete response, and the waiting time from the diagnosis to surgery is less. So that's all what you need, as long as you think that the surgery is the definitive treatment for these cancers. So we should not delay definitive treatment, and you have a bonus of having better pathological complete response. So, Dr. Faik, discussion?
I think we should hear from.
So he was saying we should hear from the surgeon to hear the surgery perspective, because the surgery perspective wasn't really presented in those talks. And I think that's very true. So my perspective as a surgeon is rectal cancer surgery carries a lot of impact on the patients in terms of quality of life. Removing a patient's rectum, particularly for low rectal cancer, is not something that we take very lightly. I'm not talking about the immediate complications of the surgery, because I think these days we can do that safely, robotically, with good outcomes. But I am talking about the long-term impact, functional impact, quality of life impact. And when you keep that in mind and you factor that into the equation of everything that we are talking about, I think it plays a very important role in the decision-making. And so I will ask a question to each of the moderators, to each of the presenters, and see how they would approach. So in a patient who does not have any of the criteria, Dr. Brahim, any of the criteria you listed, which is a low rectal cancer, it's not a low rectal cancer, there is no threatened radial margin, and there is no EVMI. The tumor is potentially a prospect patient. And this is a patient in whom potentially you could, it's an upper rectal cancer, meaning that watch and wait is not likely, and that this patient may actually do well with just chemotherapy alone without radiation. Would you still insist on an upfront chemoradiation TNT approach?
No.
So my next question is to Dr. Hampik, which is the other way around. When you have a patient that has a low rectal cancer with possible invasion to the sphincters, and where sphincter preservation is important, do you still feel that induction chemotherapy is the way to go?
My answer is no, for sure. There is a place of radiation therapy.
And so I think the debate is excellent. It highlights a lot of issues that we talk about every day in our multidisciplinary. But I'm very happy that Dr. Humaid has me here, because I think the surgical, for me as a surgeon, I can try to give you in 2 words my surgical thoughts about this. First of all, if I can avoid radiation therapy in any patient, I will try to do that. And the reason is that the radiation therapy has a significant impact on LARS and on patient outcomes. And when the problem that we see with a lot of those trials is that we base our recurrence data and our outcomes, surgical outcomes data, on data that is now 30 years old. And nowadays, in modern rectal cancer surgery using modern approaches, the local recurrence rate is extremely low. It's less than 2 to 3%, even without radiation. I know our colleagues in radiation therapy don't like to hear that, but that is the reality. If we don't have a threatened margin or risk factors, surgery alone is very, very effective in controlling local recurrence. And that's where I think chemotherapy plays a more important role. Now, when you are dealing with a low rectal cancer, where you have to remove all of the rectum, then the first thing in my mind is functional outcome, long-term outcome, and that's what the patient also wants. And in that situation, I would be looking for any treatment available that might avoid surgery altogether. So
Thank you. Just to add a couple of things. So I really like the way you phrase the questions, and I really respect that you acknowledge that the outcome after surgery, quality of life, is really devastating. So trying to preserve an organ is usually our number 1, 2, and 3 target in those patients, with an excellent oncological outcome. That being said, the techniques of radiotherapy and the ways that we're doing radiation has also really significantly improved over time. But the most important part, in my opinion, our kind of difficulty is the MRI, the quality of the MRI that we base these decisions on. Because a lot of, sometimes these EMVI, threatened margin, early T4, these cases are unfortunately sometimes missed unless the surgeon themselves are reviewing those MRIs, or you have an expert pelvic radiologist who's reading those for you, and we ended up needing to give adjuvant, and this is the worst of the worst. This is our nightmare. So we always try to, as Dr. Hampik ended, is in those tumor boards to really make sure that a radiation oncologist, a surgeon, as well as a dedicated pelvic radiologist is reviewing those images for you, because the last thing you want to do is you want to operate and you end up with a positive margin, right, in these cases, because these tumors can be sneaky, these tumors sometimes you can be missed, and then you end up needing to give adjuvant radiation, which is extremely more toxic, as we need to give a higher dose to account for the hypoxia induced by surgery. So my take in this is that please don't, the role of the radiation oncologist in these tumor board is as important as the role of the surgeon, because at the end, this is a local recurrence in rectal cancer. We all know it's one of the worst recurrences of all cancers. So, but I really like the way how you phrased the question. I just want to add one thing regarding the overall survival, long-term outcome in the PRODIGE trial. Again, just to keep people in mind, PRODIGE compared the standard of care, which is long-course chemoradiation followed by surgery followed by chemo. So it's not TNT versus TNT. So we need to keep in mind the overall survival is not favoring upfront chemotherapy. That's number one. Number two is there is a study from France, the OPERA trial, where we actually give interstitial or brachytherapy after external beam radiation therapy in a very select, I agree, very select group patients of rectal patients. And the organ preservation was more than 90%. And with powerful, localized, advanced radiotherapy techniques, we can really spare patient surgery.
Just a comment regarding the PRODIGE 23 and the advantage in overall survival. For sure, we are not comparing two TNTs, but and I put the question mark on this point. Is this induction chemotherapy will affect the survival at the long term? This is a very important question, because we should think about it and see that the other trials didn't show any advantage of overall survival. So this was a hypothesis that should be confirmed with the next studies.
So I would like to highlight 2 points. I think Dr. Fayed's point is there is no one size fits all is the correct answer. Most likely, I mean, I think this is the way we should think about it. We cannot just apply one protocol to all patients, and I think we should discuss an MDT, which we all do all the time, and we disagree. I think the problem is there is no clear pathways for all different types of or different locations. That's where the confusion always happens. That's number one. Number two, I think there is a growing interest in non-operative management for rectal cancer. And I just want to mention the study, which was no-cut study in ESMO, which was presented just a few weeks ago. It was a single-arm study looking at the non-operative management, chemotherapy followed by chemoradiation, single-arm, no comparison here. But the conclusion was 26% of the patient, which we see in reality that they can become complete response, and these patients they can be followed without any surgical management. But again, this is still ongoing, and we need to discuss with the patient, and if the patient is willing to adhere with a very strict follow-up. We'll just take a few questions. Except Dr. Hassan, anyone else? No? One question, Dr. Hassan. One question only.
Okay, I'm going to talk about chemotherapy actually. I want to caution that there is a lot of use of FOLFIRINOX, unproven that it is better than FOLFOX, and it is much more toxic. So there is actually ongoing trial that's going to also answer that question. But I think the rush to use irinotecan is plus minus, because it is not an easy regimen to take, and you need growth factor support. And it was an arm study against the traditional long-course chemo. And I want to stress what Dr. Fayed said, there is nothing better than not doing surgery. So I think if our aim is to try to preserve the rectum, or especially in the low rectal tumors, there is nothing more than that for the quality of life of the patient long term. So that should be our aim. And because of that, I think that's why PCR would matter there, because only if you have PCR, you will end up with surgery. And another point is the waiting time. We have seen cases where they came to me as second opinion. They still have, small ulcer, but nothing definitive. MRI much better. And a month later, complete healing, 10 biopsies, no disease. So please give them time to have full effect.
So regarding the FOLFIRINOX, I may disagree with you. I will still use FOLFIRINOX in younger patients. We are using FOLFIRINOX in patients who are 60s and 70s, pancreatic cancer. So for patients younger, I will still push the envelope with FOLFIRINOX. No, there is a study. There is
I mean,
I know, but until we have more data, I will keep pushing the envelope for more response for this patient. Maybe I will change my mind. I don't know what other
the trial I presented, the one ongoing, the Janus trial. So, and the Janus trial, the two arms starts with chemoradiation, and this is exactly what they're asking: is FOLFOX versus FOLFIRINOX. So as of now, but the nice thing about this trial, both arms start with chemoradiotherapy. So radiation is. And again, because we know the more time, and we can use this time to give the chemotherapy, whatever you want to give. So just to give a chance of complete response. I know for lower rectal we always emphasize this, and I know the morbidity is lower for upper rectal. But what if we can also omit surgery for upper rectal? You know, that's the question that. So from your experience, Dr. Jamali, you know, I know upper rectal surgery is easier, the complication rate is lower, and the patients will recover faster. But if you have the chance for your patients to omit surgery or to do a surgery, which one would you pick?
I would apply, I mean, rectal cancer is rectal cancer, regardless of the location where it happens. And I think it's reasonable to apply the same principles. The problem is that all of the trials of non-operative therapy had those criteria where you had to have the lesion palpable within reach of the finger as one of the criteria in the follow-up. So when you put the patients on a watch and wait follow-up, there are 3 things that you have to do every 3 months. You have to do an MRI, you have to do a flexible sigmoidoscopy, and you have to do a digital rectal examination. And so because of these criteria that were set forth by the watch and wait data that's available to us, we've restricted our watch and wait approach to tumors that are within reach of the examining finger, so 7 to 8 centimeters. Tumors that are higher than that are not within reach, typically have been sort of in a gray zone. Nobody really knows what to do with them. From the biological standpoint, it makes sense. You know, a rectal cancer is a rectal cancer. If it's in the upper and the lower and it achieves a complete response, achieves a complete response. Surgery is a little bit less morbid, but still has functional impact. And here the patient are more confused, and we have more of a difficulty in making a decision. But theoretically, it should be the same.
Assalamu alaikum. Zaid al-Rubai, radiation oncologist, Baghdad. My question to Dr. Ibrahim, thank you for your nice presentation. What about patient with rectal cancer and oligometastatic disease? Let's say single liver lesion, single bony lesion. Do you still prefer to go for concurrent chemoradiation up front?
Yeah, that's a great question. Thank you, doctor. For these cases, usually we start with chemotherapy, and then we give short course so that we don't delay the surgery. So in the setting of oligometastatic, resectable oligometastatic liver lesion, we really want to get the patient to surgery. So we start with the systemic therapy, of course. So the role for us will be significantly less. And in these criteria, we're just doing the 1 week, 5 fractions.
Okay, so let's vote now.
I will argue that you would start with the short course and then give the systemic chemotherapy.
You should have been a radiation oncologist.
Okay, so
if the patient is potentially surgical, it's oligometastatic.
So for the sake of time, let's just vote again. It was 60-40 favoring chemotherapy. The third option depends on the case. So I think the debate goes to. Let's say it's almost split, but a little bit more for. ما أعرف أنا.
مية واثنين في شيء غلط بالإحصاءات.
50-50 50-50 خلاص أيوة هيك. Dr. Hampeek, thank you so much for joining us, and you're more than welcome to stay with us, inshallah, for the next session. Thank you to Ibrahim. Well done. You changed 10%?
Yeah, 20.
20?
20 from 60-40 favoring chemo to 50-50. So
ممتاز.
20 لو في 10 هون و 10 هون.
ممتاز. So thank you, and we'll move now to the next session, moderated by Dr. Fathi Azribi, who is a consultant oncologist at the American Hospital in Dubai. Dr. Fathi, he's a consultant oncologist and he trained in UK. He was previously the head of department at Tawam Hospital, and he's currently practicing in the American Hospital in Dubai.
Can you share it?
Welcome, Dr. Fathi.
شكرا جزيلا.
عندك البايو؟
Congratulations.
تبع الدكتور؟
نعم؟
عندك البايو؟
لا والله ما عندي. خلاص يتصير. Thanks, Professor Ahmed. Thanks for the organizing committee and scientific committee for inviting me, and it's my pleasure to be with you here today. It was a lovely morning with the colorectal cancer. We'll continue with the GI, but now we'll shift the gear into the upper GIs, which gastro and gastroesophageal cancers, where again I think the debate probably will continue about the role of radiotherapy, chemoradiotherapy, and so on. It's my pleasure to introduce Professor Salahuddin Al-Batran. He's a well-known medical oncologist. He's the director of the Institute of Clinical Cancer Research and GI Oncology at Frankfurt. It's a long German name, but it's Frankfurt. That's how I know it. He's a hematologist and oncologist. He specializes in esophageal and stomach cancers. Yes, yeah. He founded the FLOT gastric cancer, as Professor Ahmed just said. Without any further ado, I will introduce my colleague, Professor Salahuddin Al-Batran, to give us his thoughts about the advances in gastric and esophageal cancers, and with emphasis on his own research and his institute long track research on this field. Thank you.
Yeah, thank you very much. Thank you, Dr. Fathi, for the introduction. And I would like also to thank Professor Humaid for the invitation. Unfortunately, I could not join you in Dubai personally. I hope the next time, but it is a big honor for me to talk today on my favorite subject in front of all of you. And yes, so I hope you see my screen well. My talk will be on gastric and esophageal cancer, highlighting also our trials at IKF. And I will focus my talk on the adenocarcinoma subtype of this disease, just because of time. And let us start with the locally advanced operable stage. We know that the outcome of gastric cancer and also esophageal adenocarcinoma, of course, is poor. So as for patients having, for example, ET1 disease, survival is probably around 90 and 80% at 5 years. But as soon as a patient has ET2 tumor or ET3 or T4, survival drops strongly, with patients having ET3 tumor having survival of 20% at 5 years only. this in case in overall looking at all patients irrespective of the nodal status. So this has prompted many investigators in the last decades to test the use of chemotherapy either as a neoadjuvant treatment or as a perioperative treatment before and after surgery to improve the survival of these patients. And probably the first large trial to show improvement by the use of chemotherapy was the UK OE202 trial, in which patients with squamous and adenocarcinoma of the esophagus were treated with 2 cycles of cisplatin and 5-FU before surgery or were operated upfront. And over 800 patients were enrolled into this esophageal cancer trial. And this trial showed for the first time an improvement of survival from 17% to 23% at 5 years. This trial was followed by the well-known MAGIC trial, in which ECF was used before and after operation for gastric and gastroesophageal adenocarcinoma, and a similar French trial, the FFCD, which was, however, smaller, using CF, and confirmed these results. Then the FLOT4 trial that I have conducted with my research group at IKF was the first trial to further improve the survival of these patients compared with ECF, and this improving survival further from 36 to 45% at 5 years, however, as an accumulating improvement. So looking at all of these trials, we can say today that pivotal trials with more than 2,000 patients have shown an improvement of survival in patients with adenocarcinoma of the gastric, of the stomach or gastroesophageal junction by the use of chemotherapy, and specifically for FLOT, there is an accumulated benefit. So again, the FLOT4 trial improved with the use of FLOT versus ECF, the R0 resection rate, and the downsizing of tumors, resulting in an improvement of survival by 9% at 3 and 5 years, improving 3-year overall survival from 48 to 57%. So, however, also as mentioned by Dr. Fathi, chemoradiation is an option for these patients, and there were, however, few positive phase 3 trials on chemoradiation. Only 2 trials. One of them is the COLGB 9781 trial with 56 patients only. However, the CROSS trial was a clearly positive trial that enrolled squamous and adenocarcinoma of the esophagus and gastroesophageal junction and used carboplatin and paclitaxel plus radiation therapy versus surgery alone, resulting in a clear improvement of overall survival. So this has led to a long-standing debate on whether to treat patients with FLOT or with CROSS or with chemo or with chemoradiation, specifically those with gastroesophageal junction adenocarcinoma. And this debate, in my opinion, has come to a sudden, I would say, end by the publication of the ESOPEC trial at ASCO this year, in which that has shown that FLOT is superior to CROSS for patients with adenocarcinoma of esophagogastric junction and esophagus. And the trial, in fact, reproduced very well the 3-year survival rate with FLOT. However, CROSS was not as effective. I expected these results because FLOT was better than ECF, but CROSS was not. And another very important trial looking at radiation in this disease is the Top Gear trial that has been presented at ESMO this year. And the Top Gear added radiation to chemotherapy in the perioperative setting in patients with gastroesophageal junction and gastric cancer. This is important. And it showed as expected an improvement in pathological response rates, but survival was the same. And in the subgroup analysis, patients with gastroesophageal junction adenocarcinoma seem to derive benefit, but we have to be careful because it's a subgroup analysis, and probably we have to wait for the RACE trial to answer this question. So the next step in the treatment of this disease is the use of immunotherapy. This is clear, and from my group, the DANTE trial was the first large randomized trial to test the use of checkpoint inhibitors, in this case atezolizumab, in the treatment of patients with gastric and gastroesophageal junction cancer in the perioperative setting. And we published the phase 2 part of the DANTE trial at last year ASCO and in JCO by Sylvie Lorentzen, and we showed that the complete path response could be clearly improved from the 15% we know from FLOT in the German trials to 23%. And also, and more importantly, the N0 stage could be clearly improved from 54% to 69%, which is, in my opinion, even more important than path response. And when we look at the subgroup analysis by the PD-L1 CPS in the DANTE trial, we see a clear increase in the path response rate by the PD-L1 CPS, and we can see that in patients having PD-L1 of CPS of equal to or greater than 10, the complete path response in the DANTE trial was a striking 30% with atezolizumab versus the normal rate known from FLOT in this group, and also MSI derived, of course, a high benefit. So there are, in addition to DANTE, 2 large trials conducted by pharma, the Keynote 585 and the Matterhorn trials, and these trials delivered some results. The Keynote delivered final results. So what we know today is that from all 3 trials, that the addition of immunotherapy improves PCR and downstaging and downsizing. However, in the Keynote trial, survival could not be improved, and there was a small trend in event-free survival, whereas the survival data from DANTE and Matterhorn are still not available. So, some slides on organ preservation. The question would be, do we need surgery at all in the future? This is, of course, a very interesting question that has to be followed by answered by clinical trials. However, what we know today is that we can achieve significant path response rates that has remarkably improved from only 0 to 2% with the doublet chemotherapy like CF to 13 to 20% with FLOT, or even 30% with FLOT plus durvalumab. For example, the German cohort in the Matterhorn trial, or at least the 30% I showed you in the CPS, in the PDL high expressors. So we know that PCR depends on stage, histology, location of the tumor, the intensity of the treatment, and many other factors, but we can achieve significant rates. And this has prompted us to evaluate organ preservation in adenocarcinoma by the PRESTO trial. It's an IKF trial that is ongoing, looking at using a maximum treatment approach by durvalumab plus FLOT as immunotherapy and chemotherapy, followed by FOLFOX and radiation. And then the patients will, if they have a clinical path response, they proceed for surveillance and receive salvage chemotherapy, salvage surgery if needed. And probably, I believe that this will be a key factor in the future research, specifically in esophageal cancer. And the next slides will be on oligometastatic disease. And the first large trial to highlight oligometastatic disease came from Japan. It was the Regatta trial, in which patients with metastatic gastric cancer that is limited to one organ were randomized to chemotherapy, which is the standard of care, or gastrectomy followed by chemotherapy. Importantly, there was no removal of metastatic disease, and predominantly the population of this study consisted of patients with peritoneal metastasis. This trial did not show any improvement of survival by the use of surgery, with a small trend for chemotherapy alone in survival. This year at ASCO, I presented the IKF Renaissance trial. And in the Renaissance trial, we used an induction chemotherapy compared to the Regatta trial, consisting of 4 cycles of FLOT that could be expanded to 6 cycles. And also, we had another definition of oligometastatic disease that has been defined as lymph node metastasis only, or a maximum of one organ involved. Our trial showed crossing survival curves where the use of chemotherapy alone was better until month 24, and then there was a small benefit for on the long run for patients who were operated. So the trial was negative, but the subgroup analysis for predefined subgroups showed interesting results. So for example, patients with liver metastasis did not benefit and had similar survival with or without operation. In patients with peritoneal disease seemed to have a detrimental effect by the use or by operating if patients were operated after 4 cycles of FLOT, whereas in the opposite, patients with the retroperitoneal lymph node metastasis only seemed to derive a benefit with a interesting 5-year survival rate ranging in the range of 40%. So these are patients with M1 disease. So I think that future trials should focus on prolonging the preoperative chemotherapy in these patients and focusing probably on subgroups that may benefit, like patients with lymph node metastasis only. So now proceeding to metastatic disease, this is the current ESMO treatment algorithm for metastatic gastric and gastroesophageal junction cancer. And now I think we have made a clear progress in gastric cancer within the last 5 years in terms of biomarkers. So currently the treatment of patients with gastric cancer, metastatic gastric cancer, is divided into 3 biomarker targeted treatments for the HER2 positive group, the HER2 negative but PD-L1 positive group, or MSI high group, and the third group is the HER2 negative and PD-L negative group. For the HER2 positive group, patients would receive in first line platinum fluoropyrimidine doublet plus trastuzumab, and if they have a PD-L1 CPS of equal to or greater than 1, pembrolizumab must be added, which is associated with improved survival and response rates, as we have seen in this year's ESMO presentation on an update on survival. So the HER2 negative PDL positive group would preferably also receive a doublet consisting of fluoropyrimidine and platinum, where I believe also a triplet like FLOT is possible for some patients, and I think this will be also changed in the future in the ESMO guidelines. And if in case of PDL expression of greater than equal to or greater than 5, nivolumab can be added, or pembrolizumab even in CPS1 or higher. However, in fact, we feel that efficacy of immunotherapy here is limited to patients with PDL high expressions like 5 or even 10. The negative group, PDL and HER2 negative group, receive chemotherapy only. In the second line, trastuzumab deruxtecan for the HER2 positive group is an option. For the HER2 negative groups, paclitaxel, ramucirumab with paclitaxel or ramucirumab monotherapy is the standard of care, but patients can also receive taxanes or irinotecan. And in case of MSI high tumors, the use of pembrolizumab is a standard of care starting from second line. And in the third line, patients would receive the treatment that has not been received in the second line setting, but also trifluridine tirparacil as an oral treatment is an option. So there are many new treatments on the horizon, and specifically tumor antigens and RTKs are important. The most advanced treatment is targeting Claudin 18.2, but also if FGFR2b is an interesting molecule. We will see in the future also other immune checkpoint inhibitors like TIGIT or LAG3. Combinations are interesting, specifically the combination of anti-angiogenic treatments with immune checkpoint inhibitors. We know very well about the strong synergism between these two drugs or treatments, and also technologies. For example, ADCs, antibody drug conjugates are very important, and bispecific antibodies are also on the horizon. This could be also an antibody, for example, targeting VEGFR and checkpoints, as we have seen on ESMO this year. And I will show only two of these new developments. First, the HER2 targeting ADC trastuzumab deruxtecan. So it's the first ADC to be approved in the treatment of gastric cancer. It's an antibody targeting trastuzumab loaded with a chemotherapeutic drug, which is exatecan, using a drug linker. And the approval, the drug is indicated in Europe as a monotherapy for the treatment of adult patients with advanced HER2-positive gastric and gastroesophageal junction adenocarcinoma who have received prior trastuzumab. And this is based on the Destiny Gastric 01 trial, where patients were randomized to receive trastuzumab deruxtecan or a physician choice of chemotherapy, and in patients who were pre-treated with chemotherapy and trastuzumab and were HER2 positive. And in this trial, the response rate was improved from 14 to 51% by the use of the ADC, and also survival improved from 8.4 to 12.5 months, leading to the approval, and trials are ongoing in first-line setting with this interesting drug, and also in the perioperative setting as a smaller trial at our institution. So the next upcoming star in the treatment of gastric cancer and esophageal adenocarcinoma is Claudin 18.2. Claudin 18.2 is a tight junction protein, and therefore relatively specific for the gastric mucosa, and is important as to build the barrier against acid in the gastric mucosa. And this, in fact, biomarker is a showcase of development for a biomarker. It's a model for the progress in oncology. And I'm also very honored to have participated in the development of this drug together with Ogo Shahin and Islam Turici, and presented at ASCO 2016 the first randomized trial on zolbetuximab targeting Claudin 18.2, and this has it has taken 7 additional years until or 5 additional years until Kohei, or no, 7 2023, Kohei Shitara presented the Spotlight trial, the phase 3 leading to the approval of zolbetuximab in the treatment of gastric cancer. So now we have 2 phase 3 trials that have shown, it's the Spotlight and the Glow, in the first-line treatment of metastatic gastric and gastroesophageal junction adenocarcinoma, that have shown an improvement of overall survival by the use of the Claudin 18.2 antibody zolbetuximab with chemotherapy, either with FOLFOX in the Spotlight or CAPOX in the Glow trials. And in both trials, patients, in fact, also in the control arm, had remarkably good overall survival, showing some selection of patients here by the biomarker, but this improved clearly with the use of the antibody, but the response rates did not improve, which is typical for such an immune therapy. So now, finally, I think that in the very near future, we will have a more sophisticated stratification of this disease by biomarkers, and we will have the HER2 positive group, the HER2 negative group, the MSI high group, the Claudin 18.2 positive and negative groups, and at the end we will, and the PDL positive group. And we will have the so-called triple negative group. And based on all of these biomarkers, the treatment will be different. So some words to IKF. IKF is a clinical research institution and a study group at the Northwest Hospital and University Cancer Center Frankfurt. I founded the IKF many years ago to be focused on investigator-initiated and industry-academia collaborative cancer research with the aim to boost and improve academia-based research to a next level. And in the meanwhile, since 2018, we have enrolled 1,600, we have conducted more than 90 academic clinical trials, and enroll 1,600 patients every year in clinical trials. And I wanted to show you our IKF gastric cancer study program. So for perioperative setting, we try to and this is a specific factor for investigator-initiated trials, we try to address every niche and every need in the treatment of this cancer. So we look at the very early stage, like T1 and T2, and try to treat these with a TNT approach without surgery via the IKF Presto trial. We look for the T3N plus disease within the Dante trial, for the HER2 positive disease in the FAIRFLOT, or the FGFR2 positive disease in the Neobima trial. And also we have a trial to treat peritoneal, as an adjuvant treatment to prevent peritoneal carcinomatosis in the diffuse and mixed type gastric cancer by the use of HIPEC, which is the FLOT9 trial. And we also are still running the RACE that has completed enrollment, but we do need maybe 1 year to report results. The RACE is a large phase 3 trial looking at the use of preoperative radiation within the FLOT regimen, different from the Top Gear, in which we enrolled only gastroesophageal junction cancers. And we hope this is the perioperative program. This is the metastatic program. I will not go into the details. And thank you very much for your attention.
Thank you so much, Professor Salahuddin. That was really very interesting overview. I'm not sure if we are allowed for 1 or 2 questions. I'll ask one question before you, Hassan, sorry. It's just about the recent data and about the game changer, actually, about float versus cross. So in your center now, are you using chemoradiotherapy at all, or you changed your practice based on these data? That's number one. I have a small question, just for the MSI high. I know they are a small group of patients. In the colorectal, we moved early to use the checkpoint inhibitors because we know that they will not benefit from chemotherapy anyway. But in upper GI, I think even in the NCCN guidelines, they still put them in the second line. So I find it sometimes, you know, a little bit difficult to cope with that, to expose them to the chemotherapy when I know from day one they are MSI high, if I want to follow the guidelines. So these are my 2 questions. Then Dr. Hassan Ghazali can ask more.
Yes, I think the first question, honestly, before the ESOPIC trial, I did not use radiation for the gastroesophageal junction because I was convinced that float is better than chemoradiation. Of course, we could use float plus radiation, but this is a hard treatment for patients. So with the ESOPIC trial, radiation is no longer standard for the perioperative treatment of gastroesophageal junction or esophageal adenocarcinoma. However, it's still the standard of care for squamous cell carcinoma. And as you have seen also, if you would like to go for an organ preservation approach, radiation is also the option. And however, I think we have to wait for the study to look if for the specific group of gastroesophageal junction cancer, radiation could have an added benefit. But at the moment, I only use it for patients who still after chemotherapy still inoperable, or for patients with R1 resection where we could use radiation. Not in everyone we could use radiation, and for organ preservation.
And how about
for the next question? Yeah,
sorry.
I absolutely understand. I think chemotherapy is effective. So you could start with chemotherapy, but monitor the patient very tightly. And if you are not very happy about the response, start with the checkpoint inhibition. But I think in some cases you could start with checkpoint inhibition only, or combine, but this is outside the guidelines, but it is a treatment that you can support by evidence. I absolutely agree, and it's also, of course, a question of the insurances and the reimbursement and payment, because checkpoint inhibitors are still expensive.
Sure, we have a couple of questions. Sorry, Dr. Hassan, and then you. Go ahead, Hassan, but
okay.
Please, short.
Thank you, inshallah. So just one comment. I think, as you mentioned, radiation is kind of on hold right now until we see the further studies that you presented, you know, especially FLOT plus radiation or FLOT with immunotherapy. So there's still room there, I think, for improvement. So I don't think radiation is dead completely yet. My question is on the HER2 positive disease. Why do you think so far in the neoadjuvant setting, it has not shown that much improvement like in the metastatic setting? I know you mentioned there are ongoing trials, but why do you think so far we haven't seen that effect in the perioperative setting, which, I mean, it makes sense in other diseases with HER2 positive, it had big impact like breast cancer.
No, I think it has an impact. The problem is that pharmaceutical companies did not perform the trials because of the life cycle of their drugs. So Roche just stopped developing the drug suddenly, and I'm sure if you would do a phase 3 trial with trastuzumab in HER2 positive disease, this trial will be clearly positive. We have done one randomized trial. It was a phase 2, and everything was better, and we had a very clear trend in favor of event-free survival, in favor of FLOT plus trastuzumab and pertuzumab. So no question, the trials has not been performed.
Yeah, I mean, like you mentioned, there were some phase 2 trial that did not show big improvement, but like you said, we need to do the phase 3 trial, absolutely. The Pembro, you mentioned more than 1%, but correct me if I'm wrong, the FDA label, it should be over 10%, and the NCCN, or the other way around, I'm sorry, FDA is more than 1, where NCCN, this is the first time NCCN is more restricted to the over 10% on the CPS score. So what do you know, how do you treat your patient if you have to add a checkpoint inhibitor?
For all comers.
If in the HER2 positive?
No, HER2 negative. We're talking about just metastatic setting first line.
Yeah,
chemo plus IO.
Yes, at least the patient has, in the first line, the patient has to have a PDL, to be PDL1 positive. This is the minimum. But at my institution, I require a PDL1 of greater 2 or equal to 5, and the other patients are treated with other treatments within clinical trials.
Okay, I think we have, we have 2 more questions. Same question? Okay.
Thank you, Professor, for the excellent presentation. So 2 questions, if I may. One question, intrigued by the data on peritoneal metastasis, which shows that they clearly do worse. However, in the NCCN guidelines, there has been a change this year, which introduced for a low PCI less than 10, neoadjuvant therapy followed by surgery with cytoreduction and HIPEC as one of the options for those patients. And this is not based on randomized trial, but based on retrospective data. But so I was wondering about your thoughts about patients with peritoneal metastasis with gastric cancer. How should they be treated today? And my second question is, in the event of a complete response with neoadjuvant chemoimmunotherapy, will there ever be a consideration for non-operative therapy in those patients? Thank you.
I would be very, very careful with operating patients with peritoneal disease. In fact, you have mentioned it. All of the evidence we have are retrospective or at least non-randomized cohorts. And all of us know the appreciated colleagues from surgery who showed us cohorts of patients surviving 20, having with a median survival of 20 and 30 months after operation. And all of us thought that this must be the surgery, the effect of surgery. But if you look at the Renaissance trial, the median survivals, even with FLOT alone, were in the range of 25 months. So this is patient selection, and I would normally would not operate a patient with peritoneal disease because of the data of the Renaissance trial. But it remains a very highly individual approach. If you have a patient with very small involvement of the peritoneal disease around the stomach, of course, you will make a gastrectomy and remove the disease and make adjuvant treatment. But otherwise, not. Yeah.
Yeah, final more question. Yeah, thanks so much.
Just using your time here, Dr. Salah, thank you so much, and great to have you, and wish to have you, inshallah, next time here in person. Any experience with PIPIC? Because our next talk is going to be about PIPIC, and I just want to get your insight about PIPIC and selective patient of gastric cancer with metastasis.
Yes, we have done it many times, and but again, the problem is the lack of randomized trials. We have I think this is a very frustrating situation where patients have peritoneal disease and less options. But again, I'm also very critical. I think we do need the randomized trials, and we have to do them. And if we don't have them, this is also a signal that probably the treatment is not active enough.
Well, thank you so much, Professor Salah. There are so many questions, controversies, and debates in upper GI cancers, and this is obviously an unmet need for more research. Thank you for having you today, and we wish we see you in person next time. Thank you.
Thank
Have
you
a good
very
day.
much.
Thank you.
Thank you. Thank you to all of you. Thank you. Bye. Have a nice day.
So next session will be with Dr. Hassan Ghazal, who doesn't really need much introduction. So he's American board certified, and he has extensive experience in the US before moving to the UAE. He's currently practicing at one of the hospitals, King's College Hospital in Dubai. Welcome, Dr. Hassan. And for this session, you are not allowed to ask questions.
All right, thank you for the introduction, and thanks for allowing me to speak a little bit other than asking questions. So we're going to move gears a little bit, going to HCC, and it's my pleasure to introduce Dr. Basil Shawa. He's currently in Arizona, Tucson, in USA, University of Arizona, and he will be speaking to us on the latest development in HCC. Dr. Basil, I think he's here.
Good morning. Thank you so much for having me today. It's an honor to be with you. Thanks, Dr. Hassan, for the introduction, and Professor Hamid for the invitation. It's truly an honor. So today we're going to be talking about the new era of management in hepatocellular carcinoma and the new advancement in this disease that is actually right now is a hot topic in medical oncology. So, how do I move the slides? How do I move the slides? So as we all know, hepatocellular carcinoma mortality has been increasing globally. Liver cancer as of now is rated as one of the top 3 cancer deaths globally. The incidence of liver cancer has been increasing lately, and it's expected to keep increasing, mostly due to non-viral etiology like NASH or muscle, as it's taught right now. So over the last 2 decades, there has been significant improvement in the management of hepatocellular carcinoma. It started in 2007 with the approval of sorafenib as a first-line treatment based on the SHARP trial. Then after that, it followed by significant approval like regorafenib, lenvatinib, all up 2020, where we had the landmark study of EMBRAVE 150, which granted the approval for atezolizumab with bevacizumab as the first-line treatment for unresectable hepatocellular carcinoma. In 2022, we had the first approval for the dual immunotherapy as a first-line treatment based on Himalaya trial, which found that combining durvalumab with single-dose tremelimumab significantly improved survival. So what is the current landscape treatment for patients with unresectable hepatocellular carcinoma? So as of now, first-line treatment include dual immunotherapy as a category 1 with durvalumab, and atezobev as a category 1 as well. And there is the option to use sorafenib and lenvatinib. Second-line treatment will depend a lot on what did we use in the first line. So it could be a TKI like cabozantinib, regorafenib, ramucirumab, or single agent or dual agent immunotherapy. For third line, we have cabozantinib, and median overall survival has been ranging between 25 to 30 months. So let's talk a little bit about the EMBRAVE 150 trial, which was published in 2020, granted the approval for the atezobev as a first-line treatment for unresectable metastatic or locally advanced hepatocellular carcinoma. On this trial, we had a 2-arm investigation arm of atezobev versus the control arm of sorafenib. And the trial was positive. Atezobev significantly improved survival in patients with unresectable hepatocellular carcinoma. Median overall survival was 19 months with a hazard ratio of 0.66, so about 35% reduction in risk of death using this regimen. Progression-free survival as well was positive with a hazard ratio of 0.65. I would note that this study stopped the follow-up at 18 months, so we don't have data beyond 18 months, and all participants in the study were required to have an EGD within 6 months from starting the trial. Response rate was noted to be around 30% as well. How about the safety data on Embrave 150? Well, atezobev did very well comparing with sorafenib. The two most important things to keep in mind when using this regimen is the risk of hypertension and the risk of bleeding. In fact, all grade bleeding reported to be about 25%, with grade 3 and 4 to be around 8%. That's why having an EGD is very important prior to having this study. And one of the main exclusion criteria for this study was high risk of bleeding or uncontrolled hypertension. As we know with atezo as an immunotherapy, there is a risk for immune-mediated adverse event. The most serious one that we need to watch for is immune-mediated hepatitis. There was also a risk for rash, colitis, and hypothyroidism. Versus bevacizumab, the main risk were uncontrolled hypertension and high risk of bleeding. So how about dual immunotherapy for the first line? Metastatic, unresectable, or locally advanced hepatocellular. So we have study 22, which is a phase 2 study, evaluated the efficacy and safety of durvalumab and tremelimumab in this setting. This study had 4 arms. Arm 1 was its single priming dose of tremelimumab with durvalumab versus tremi, or repeating doses with tremelimumab up to 4 cycles with durvalumab. What did the study show clearly that was single priming dose of tremelimumab was enough and production of and priming of T cell CD4 and CD8, so significant increase in the number of the T cells and sustained benefits of T cell. At the same time, there was a significant favorable outcome related to toxicity. Single agent priming dose of tremelimumab was significantly safer than repeating doses. And that's laid the foundation for the Himalaya trial, which is a phase 3 study, open label randomized trial. Inclusion criteria included patients with unresectable hepatocellular carcinoma. It's included patients with child view A. And the main thing to note here, EGD was not required, and patients with main portal vein thrombosis were excluded. So on the trial, there was 3 arms, single agent or single priming dose of tremelimumab with durvalumab, followed by durvalumab alone Q4 weeks, versus sorafenib, and there was a 3rd arm of single agent durvalumab. But I would note that the durvalumab single agent arm was looked as non-inferior to sorafenib, and it was not compared to the durvatremi. So, and now we have a 5-year overall survival with the data recently reported at ESMO a couple weeks ago. And we have an impressive landmark analysis on this study. At 60 months, basically at 5 years, 1 in 5 patients who received the tried regimen are alive. So about 20% of the patients who received durvatremi were alive at 5 years. And I would note here, if you look at the left slide, the hazard ratio is holding steady and nicely. And there is a plateau in the curves, which we know now that patients who respond to immunotherapy tend to respond for a prolonged period of time. The hazard ratio is 0.76, so impressive 25% reduction in the risk of death. So the next question comes is, who are these patients who are contributing to the overall survival? Is it only complete response? Well, the study showed that if you are actually able to achieve stable disease, you will predict overall survival benefits. So the idea of having only stable disease can predict overall survival. If we look at the left slide, the highest curve here is a stride disease control, and these patients included with complete response, partial response, and stable disease, and did significantly better than sorafenib disease control with an impressive hazard ratio. There is other first-line phase 3 trials that has been testing the idea of combining TKI and immunotherapy, as you can note here on this slide. How about Checkmate 9DW? the biggest elephant in the room. This study was presented a couple weeks ago at ESMO, and it took a lot of attention in the oncology world and the social media also. This study is a randomized, open-label, multi-center study. It included patients with unresectable hepatocellular carcinoma, child BUA, and I would note that there was no main portal vein thrombosis, similar to the Himalaya inclusion criteria. The investigation arm was single nivolumab 1 milligram per kilogram with ipilimumab 3 milligram per kilogram up to 4 cycles. It's very important to note the dosing and the number of cycles here to compare it with other regimen versus a dealer's choice of lenvatinib or sorafenib, though the majority of the patient received lenvatinib. Primary endpoint was overall survival. Secondary endpoint was objective response rate. And the study was positive. Median overall survival reported to be 23 versus 20 months on the control arm with a hazard ratio of 0.79, so about 20% reduction in risk of death. But if you can look at this curve under the microscope, you can clearly see that for the first 12 months, there was no significant benefit noted. Actually, the lines were crossing. And initially, actually, sorafenib arm was doing much better than the ipi-nivo arm. So this is something to note, and we can talk about this and discuss it also during the question session. At 36 months, survival was 38% versus 24%. So how about treatment-related adverse event? We are all aware of immune-mediated adverse event. I think we all did use CTLA-4 inhibitors. We are aware how effective is this regimen, but it's pretty toxic as well, especially with repeated doses. And this study also confirmed what we know. There is a significant immune-mediated adverse event. So serious treatment-related adverse event, grade 3 and 4, was about 25%. And treatment-related leading to discontinuation was about 13%. If we go back here, yeah, so for one thing to note, immune-mediated adverse event, grade 3 and 4 were 30%. And the need to use steroid for a prolonged period of time was 30% as well. So these numbers are very important, we need to keep in mind. Hepatitis, immune-mediated hepatitis was on grade 3 and 4 about 15%, significantly high as well. So how do we compare this to the Himalaya regimen? So on Himalaya, the grade 3 and 4 immune-mediated adverse event were 20% as grade 3 and 4. And the need to use steroid is about 20% as well. And the risk of hepatitis, look at this, it was about 6%. So there was a significant difference in the toxicity profile between the two trials. So it's very important when we are choosing the regimen. And that tested the idea that single priming dose of CTLA-4 may be more than enough to produce efficacy and better safety. Based on NCCN guideline, as of now, we have category 1 preferred regimen listed as atezobev and durva-tremi. But very important to know, you need an EGD for any patient who will be receiving atezobev. So we are all aware of the BCLC staging. Nowadays, there is a hot topic for the intermediate stage disease, which truly require a multidisciplinary approach. It's a key factor on finding the optimal treatment for patients with HCC. As some patients with intermediate stage might be treated as local regional therapy, and other patients might be required to use systemic therapy as advanced stage. So there are currently ongoing trials regarding adjuvant treatment in the setting of HCC patients. There is a trial looking at Pembro with the Keynote versus Emerald trial with Durva Avastin, and we have the Embrave 50 as well with atezobev in the adjuvant setting. So let's look at the Embrave 50 study. On this study, it's included patients with hepatocellular carcinoma who undergone surgical resection with a curative intent. It didn't include patients with VB1 and VB3 and BV4. It's very important to note that too. So the trial looked at two arms. The investigation arm was atezobev in the adjuvant setting versus active surveillance. And primary endpoint was relapse-free survival, and secondary endpoint was overall survival. Initially, we all got very excited about this study. There was significant improvement in the relapse-free survival, as you can see here on the slide. But over time, the benefit has been lost. And this trial was found to be a negative, actually, with no OS benefits. The lines are like almost identical. So the trial was negative, and there was no benefit of adding atezolizumab in the adjuvant setting. So how about combining RT and systemic therapy for intermediate stage HCC? Very important and hot topic nowadays. The rationale for doing that, not all intermediate stage BCLCB are the same. It's a heterogeneous disease with a lot of variability, depending on the tumor burden, number of tumor, and underlying liver function. We know that systemic therapy is proven to be a first line, level 1 evidence of improving survival. And sometimes we're doing local regional therapy for intermediate stage. We might miss the opportunity to use a systemic treatment which is proven to be effective and improve survival. So based on all this, there are multiple trials that has been looking at these questions. There is a trial looked at TACE, combining that with a TKI. I would highlight the TACTIC-2 trial, which looked at TACE with sorafenib. On this trial, there was no OS benefits. Even though we did see initially significant improvement in progression-free survival, the OS benefit was not there. So let's talk now about EMERALD-1 trial. EMERALD-1 is a phase 3 randomized trial, placebo-controlled study of combining TACE with durvalumab with without Avastin in patients with unresectable hepatocellular carcinoma who is a candidate for embolization. On this study, it's included patients with HCC non-amenable for curative treatment, and it did exclude patients with VB3 and VB4 thrombosis. So arm one of the study included durvalumab with TACE, followed by durvalumab alone, versus on arm B, durvalumab with TACE, followed by durvalumab and Avastin, bevacizumab, and arm C was TACE alone. And arm B, which is TACE with durvalumab and Avastin, was a significantly improving progression-free survival. Almost doubled the progression-free survival, 15 months versus 8.2 months, with an impressive hazard ratio of 0.77. So about 27% reduction in the risk of progression using the EMERALD-1 regimen. Now let's talk about LEAP-012 study, which recently also presented at ESMO a couple weeks ago. It has similar inclusion criteria to EMERALD. It randomized the patient to pembro with lenvatinib plus TACE versus TACE alone. And this study was positive as well, reported improvement in progression-free survival, 14.6 months versus 10 months. So about 4 months improvement in the BFS with a hazard ratio of 0.66. 34% reduction in risk of progression. OS benefits are not there yet, but it's trending in the right direction. But I would note on this study the grade 3 and 4 adverse event reported to be 70%, very high number. So there are other clinical trial currently ongoing trying to combine the radiation treatment with dual immunotherapy, single immunotherapy, or trying to use immunotherapy with VEGF inhibitors as noted on this slide. So EMERALD-1 study with durva-bev showed improvement in progression-free survival when we combine it with TACE, and similar apply to the LEAP-012 study where pembro and lenvatinib also combining with TACE improved progression-free survival. Now, the most important issue which we are still dealing with, we don't have an effective proven biomarker that can predict which patient will benefit from certain treatment in HCC. And that's going to be very important in future to find these kind of biomarkers. And I would note that multidisciplinary approach is a key factor to determine the effective treatment for patients with HCC. And with that, I would thank you so much for inviting me to be here.
Thank you. This was nice overview. Yes. So maybe we'll wait till others have question. I'll ask you.
Yeah.
The single prime dose, which Dr. Abu Alfa, our friend, always talk about, it's only in HCC proven, at least, that to have efficacy. not reproduce in any other cancer. So how convinced are you with the STRIDE regimen versus now the Epi-Nivo, where they gave the higher dose, the classical 3 milligram per kilogram for 4 doses, but more toxic?
Yeah.
Granted that comparing a cross trial, of course, we see survival up to 30 months, first time ever. But another observation I want to ask you, the control arm is doing extremely well. We are up to 20, 21 months, where the original trial were 10 months with the sorafenib, maybe 12, 13 months with lenvatinib. So how do you explain those differences? And like you said, should we stratify patients? Maybe hepatitis B, hepatitis C could be different players than others to choose which regimen to go for.
Excellent question, Dr. Hassan. I think when we are evaluating trials, it's very important also to put each one of these trials under the microscope and not just look at the numbers. So if we're going to compare Checkmate versus Himalaya study, of course we cannot do cross-trial regimen, but that's what we have in our hands, so we all do it all the time. So for Checkmate, if you look at the patient selection and patient population that included in the study, there was more than 30% of the patient who had BCLC-B. Himalaya was less than 20%. That's number one. So it can tell you that they selected patient with a better liver function, better performance status, and we expect these patients to do much better. That's number one. Number two, for the control arm, it's an impressive 20 months, which not seen before. So two factors contribute to that. First factor is the patient selection, as I said, and second factor, subsequent line of treatment. If you can look at the data, there was a subsequent patients who received second line treatment, including immunotherapy as well. Now, if we're going to talk about single priming dose, where the data speak for itself. Now we have 5 years update on the Himalaya. So single primer dose is effective and it's proven. Now let's talk about the repeating doses. Ipilimumab 3 milligram per kilogram. How many of my colleagues here in this room are using Ipi 3 milligram per kilogram up to 4 cycles? I would doubt maybe less than 5%. It's a very toxic thing to do. Actually, in fact, in the US, we are doing the flipping doses. We're doing Nivo 3, Ipi 1. That's number one. Number two, the toxicity profile is very important. Grade 3 and 4 immune-mediated toxicity on Checkmate was 30% versus less than 20% on Himalaya. Hepatitis rate from immunotherapy, 15% on Checkmate versus about 6% on Himalaya. And the need to use steroid. We know steroids reverse the effect of immunotherapy. So we should aim to less using of steroid for shorter period of time. So how did these two trials do? Checkmate had the patient on highest dose of steroid for prolonged period of time. Actually, 30% of the patient required that. Himalaya was less than 20% as well. Let's look at the response. If you want to compare numbers to numbers, 5%, Himalaya, sorafenib did 5% response rate versus about 20% on durvalumab. So that's about 4 times improvement. The Checkmate was about 13% on lenvatinib/sorafenib versus 36%. So about 3 times improvement. And of note, hazard ratio is exactly the same, 0.79, 0.8. So it's exactly identical. I would argue that toxicity is less on the Himalaya. Single primary dose was more effective. And if you look at the first 12 months, how did these patients do on Ipi-Nivo? There was crossing the lines, there is no improvement. In fact, sorafenib /lenvatinib was doing better than Ipi-Nivo. So I think the single priming dose, the data is speaking for itself. We have 5 years data on that.
Yeah, thank you. I mean, if you're going to compare to melanoma, that's the only one where we start the 3 milligram, the discontinuation rate was over 30%. Yeah. So we know it's very toxic. And as you properly said, many of us decrease those. 3 milligram is always hard to give. Yeah. Any other questions?
Thank you so much, Dr. Basil, for this excellent presentation. It's Dr. Al-Murtada Mullak, I'm a medical oncologist from SSMC. So I've got 2 questions. The first one is, so you know we have these different regimens that we can use for first line. So do you have any preference for those patients who are cirrhotic with a viral etiology? Because we know the immunotherapy doesn't work as well in patients with viral etiology, as you would know from the EMBRAVE 150. And my second question, we talk about child A for a lot, and that's what the inclusion criteria for almost all trials. Is there any data for Child-Pugh B, and what would you offer your patient with Child-Pugh B as a systemic treatment? Thank you so
Excellent
much.
questions. Yes, Child-Pugh has been used by clinical trial for a prolonged period of time. I would argue Child-Pugh is a subjective kind of way when we look at the patient. I mean, the ascites and encephalopathy is a subjective way. I also try to combine albigrade with the Child-Pugh when I'm trying to use which regimen I would prefer, because if we look at the data closely, the patient who did well on EMBRAVE are the patient who's albigrade 1. Albigrade 2 and 3, there was no difference at all. Versus Himalaya study, the benefit was seen across albigrade. Now, patient selection, like how do you want to choose the treatment based on the trials and the data we have available? On EMBRAVE 150, 50% of the patient was hepatitis B. So this is very important to know. When you have a 50% hepatitis B, Child-Pugh A, that's the kind of patient I would use atezobev for. Granted, they had to be albigrade 1. I would not use albigrade 2 and 3 patients and give them atezobev. Durvalumab, if you look at the patient selection and population, it's almost identical to the real world what we see. They included 30% hepatitis B, 30% hepatitis C, and 30% non-viral. So it was very well balanced. Ipi-Nivo, very good trial as well, but had higher percentage of BCLCB. So it was biasing more to the patient with better liver function. So I would recommend you try to combine albigrade as a scoring system with Child-Pugh. And as we don't have data for Child-Pugh B, we still try to offer these patients treatment. In fact, I have been doing durvalumab for my patient with Child-Pugh B. Child-Pugh B, higher risk of bleeding, maybe the EGD available or not. I don't have that luxury sometimes to get the EGD, which is very important. So atezobev will be out of the picture, especially Child-Pugh B likely to be albigrade 2 or 3. For this kind of patient, I have been using durvalumab.
Just a follow-up to this. Would you ever offer any upfront TKI for those patients?
So,
Sorafenib
like
or-
a first-line treatment for
Yeah.
unresectable?
Sorafenib
Yes.
or lenvatinib?
Yes. If I have a patient with significant autoimmune disease, that's clearly contraindication for immunotherapy, or if a patient with a high risk of bleeding, basically I am excluding both the immunotherapy and the VEGF inhibitors. These patients I would offer first-line TKI.
All right, I think in the interest of time, we have one more. Okay, one more. خلاص.
I cannot hear.
We cannot hear.
Sorry, Dr. Bas. Thank you for your presentation. I am Dr. Mazen from Adana Virgil Hospital. I would like to ask you about the Himalaya. You mentioned for Child-Pugh A. Is there any age limit? Because I have patient 90 years and she is good on application of Himalaya. Till now, she is on the durvalumab and she is good. Is there any age limit in the study or your opinion?
Yeah, excellent question. I don't think there is age limit, but at the end of the day, 90 years old is a 90 years old. And I think these patients, you can use single agent durvalumab, I would say, as a safe option. But the age is, again, 90 years old could look like he is 60, but can 90 years old do what the 30 years old do? I don't think so. So that's why I would say maybe single agent durvalumab will be a better option for that kind of patients.
All right, thank you. I think we'll move on to the next
Thank
question.
you.
Thank you. Maybe Dr. Faik, I think, it's your turn, and Dr. Waleed is not here. Oh, okay.
Dr. Deborah is here, so she can take over.
Cover.
Dr. Arif, Dr. Yes. So next session will be moderated by Dr. Arif and also Dr. Faik. Dr. Arif, he's a consultant oncologist at Sheikh Shakhbout Medical City, who will be moderating the next session.
As Dr. Arif is getting ready, for the interest of time, we're very behind on the schedule, so we're going to try to limit the questions as much as possible.
Thank you very much. Thank you, Professor Ahmed, and thank you for the organizing committee for inviting me. I think we're going further deep into subcategory in the treatment of oncology and hepatic malignancy. I think this was one of my fellowship research when we did the pharmacokinetic study between intra-arterial infusion of gemcitabine versus intravenous for locally unresected pancreatic cancer. I will not tell you the results, you have to read the article. So we'll go directly to Professor Dr. Muhammad Adila. He's a consultant surgical oncologist at Burjeel Medical City, and he's going to talk to us about the hepatic artery infusion for primary and secondary malignancy. So, Dr. Muhammad.
Sabah al-khair. Thank you very much for this invitation. I apologize for my voice. I contacted a virus just coming by. Let's go through. It's not Corona, doctor, don't worry. How do we push the slides here? No. I pushed it. Oh, okay, it's going. So it's a long talk, but I have to be concise because of the time. If we can, if I can draw your attention to this slide, the beginning slide, I try to convince you, and it's very hard for a surgical oncologist to convince leading medical oncologists on this treatment, but I'll try to convince you that HAI does contribute to patient outcomes. And it does so for a few categories of patients. The first category that I'm going to talk about is the unresectable colorectal metastasis. And HI does that by reducing tumor burden and improves disease control. And following that, with a lot of patients that will see that it will convert them to be resectable disease. The other category that HI will be helping patients is in the adjuvant setting, where HI is going to be delivered post-surgery for resectable colon metastasis in the liver. And there I will show you that by data that it can delay or prevent recurrence and improve overall survival. And the last category that is really evolving in the last meetings of ASCO and ESMO is the use of HAI in irresectable intrahepatic cholangiocarcinoma. So for the sake of the time we go forward, this is the outlines of my talk. We'll talk about the current status of liver treatment, metastasis, and management. We'll talk about the evolution of systemic therapy. I'll pass through very fast. Everybody here knows it. I'll talk about the definition of resectability. And then after that, I will talk about HAIP, the rationale of use, and the evidence behind it for all these categories I mentioned before. So this is the current treatment. Just to remind you that most of our patients would develop, sadly, colorectal liver metastasis after the presentation or synchronously when they present with their colon cancer. And most of these patients are unfortunately unresectable at the time of their presentation. And having said that, surgery is the only curative treatment option for most of these patients. And even though we resect most of these patients, 50% or more of these patients recur in the liver as a sole site of recurrence. And if they are unresectable with the best modern systemic therapy, their overall survival ranges up to 2 years. So these are not great data for our current status of therapy. And this is just going forward. You see very slow progress in evolution of systemic therapy, and we got to improve our overall median survival to up to 24 months of treatment. But we also figured this out very soon, though there has not been real randomized trials, but you can see with the big registration data presented by Adam René from France, and you can see clearly the only curative option for these patients is resection by 5 and 10 years. And even if they convert to resectability, their options are much better even with systemic therapy and resection. Resectability has been also evolving. Patients, we can debate who's resectable, who's not for a long time. At the beginning, early 90s, we were only resecting very few tumors here and there, 2-3 tumors, not very large tumors, low CA, and no extrahepatic disease. And this was only feasible for around 10% of patients. But this has expanded dramatically in 90s, 2000s. We started resecting larger tumors. Techniques are improving. We resected more and more tumors. We used portal vein embolizations to advance for resection and having a bigger future liver remnant. And in the 2000s and now, we started using more and more convergent chemotherapy to downstage and then resect these patients, followed by surgery. We also use new techniques and new methods like microwave ablations and others to preserve as much as we can from the liver to have the patients resected, because the major target here is getting them to resection, which is the only curative method. These trials, you know better than me, all of you, unresectable patients who try to convert resectability by using modern systemic therapy, non-cilium trial for KRAS wild types, good convergence, but still between 30 to 38%. If patients have KRAS mutancy or BRAS, their conversion to resection is way lower, talking about 20s. And not to mention the poor prognosis when they go to second or third line therapy, and we will mention that later on compared to HAI therapies. What about data talking about patients who are resectable? Is there any role for perioperative chemotherapy or adjuvant chemotherapy for these patients? I think the EPOCH trials clearly answered this question, mentioning that there is no significant improvement in overall survival for patients with totally resectable liver disease. Not to mention the new EPOCH trial with a possible inferiority in the cetuximab group. So having said that, we need to think a little bit outside of the box, and we need to find new ways of treatment. This is not actually new. This has been pushed and moved forward in Sloan Kettering for 30 years. And the rationale is very easy. You can see in the picture here how the liver gets dual blood supply from the portal vein and the hepatic artery. And in the angiogram here, where they injected the dye into the hepatic artery, you can see that liver tumors, secondary or primary, usually get most of their blood supply from the hepatic artery rather than from the portal vein, which supplies most of the normal hepatocytes. So there is a great selection when you give chemotherapy directed to the hepatic artery, and you can target more the tumor cells rather than the normal hepatic sites. And we have to take it a step forward, so we have to pick a drug that usually goes into the liver, gets digested by first-pass metabolism, and thus prevent extra hepatic side effects. And by doing that, we can give really higher doses, and I will show you what other chemotherapies has been used for that factor. This is how it's surgically done. I don't know if I have a slide. Oh, yes, I have a laser, but it doesn't work here. You can see the dissection coming out. We have the celiac trunk that brings out the hepatic artery. Hepatic artery goes to the liver, and you have right and left. And there is the GDA, the gastroduodenal artery, which is the preferred conduit where we put the catheter in. We dissect it out, we put the catheter into the GDA, and we dissect all the other vessels that go around, so prevent any extrahepatic perfusion. And by doing so, we hook this catheter to the artery and inject there the treatment. This can be done together simultaneously with liver resections or colon resections, depending on the patient treatment plan. Any patient can basically go into the surgery if they have good performance status and they don't have any big contraindications or high liver enzymes. We have to do for each patient CTA minimal before they go to the surgery to see their arterial anatomy, which is very variable between one patient and the other. And as you see here, many approaches has been done to give this therapy. In Europe, they mostly use ports, just the ones used to treat patients with chemotherapy. But their treatment plans does include other kinds of systemic therapy, which is oxaliplatin, for instance. The first-pass metabolism around 47%. It's still a good, valuable treatment, but it does not, to my opinion, even reach out the FUDR, which is the best drug used for now for the treatment of these cancers. For the FUDR, we can't give it in a bolus, so you can't use a port. You need to give it slowly, so the treatment can be really without toxicity to the liver. It's very, very effective, and you give it in high doses. So we use a pump. The only FDA-approved pump is the Intera pump, which is based in the USA. It was called the Codman's pump before it was sold by Johnson & Johnson in the late 2016-17. And the pump, actually, you put it underneath the skin, and you have a needle that goes into the pump, fill in the reservoir, and patients come every 2 weeks to change the reservoir, and they go home. It's like 5 minutes procedure in the outside clinic. This is why we use FUDR. FUDR is a pro-metabolite of 5-FU, but these changes that are done to FUDR gets it to hepatic clearance of about 99%, which means you can go up to 400 times the dose you can give into the patient's liver compared to what you can give to systemic therapy without inducing any real toxicity. Its half-life is very short, less than 10 minutes. Every patient gets a SPECT scan after the surgery. The SPECT scan is intended to see that there is no extra hepatic perfusion, where if this happens, has to be managed before we start the treatment, because this can really affect the stomach, the pancreas, whatever the feeding vessel is going there, and can do extreme damage because the doses are very high. What about complications? So this has evolved also. When they started it, there is a high rate of complications were reported, but now I will show you the rates that go on now with new protocols. There are complications that are related to the operation, which is hepatectomies, ablations, colon resection, whatever is done. And there are instrument-related complications like pump complications and catheter complications, and there are chemotherapy-related complications that you give and deliver, and you manage per protocols. This is the most common catheter or pump-related complications. It's mostly talk about dissecting hepatic artery and causing its occlusion, or thrombosis of the catheter, which prevent us from really giving the treatment. But it does happen in very few percentages. Look at the FUDR-induced toxicities. Out of all these, I picked with the red the biliary toxicity and sclerosing cholangitis, because this is the really limiting when it happens. And it was reported up to 14% in patients earlier in the stage of developing these therapies. And now, with giving dexamethasone and steroids together with a pump and heparin, and modulating the treatment dose according to their liver enzymes, this went down to around 4%. So what about the data for HIP therapy in unresectable colon cancer? What do we know about it? This is a patient of mine. Once diagnosed, was synchronous disease, colon and liver, and he was unresectable. You can see his images in the right side. Upper level and lower level. And you can see that he has many big liver lesions. We couldn't talk about resection. He received systemic therapy for 3 months. And then after I immediately put him into schedule for a pump, he got the pump therapy, 6 months for pump therapy. And then you can see these lesions almost disappeared. But they're still on the imaging. So I took him to the OR and we cleaned his liver, and he's liver-free from metastasis. This is something we see frequently with these patients, and this is why you will see in the end that this treatment is expanding largely in the USA, because whoever got trained in Sloan, he sees these patients, he sees the results, and he goes, okay, I need to do this in my country or wherever I am. And this is the conversion. Basically, this is one of the earlier studies by Kemeny. She's the primary leader of this therapy in the world. And you can see here that almost all patients respond. There's even a great response in previously treated patients. She used the FUDR with modern systemic therapy, excellent response rates, and almost 50% resectable disease after treatment with HIP. And we see another data coming shortly. This is another phase 2 trial published by D'Angelica and Kemeny. Also, excellent response rates. Median number of liver metastases 13. I don't know. This is like huge number of liver mets, and you still get these numbers. Heavily pretreated, almost 70%. Heavily pretreated. Excellent response rate, 73%. 53% converted to resectability. And once they convert to resectability and you take the tumors out, you go back to the first slides where you see upfront surgery is equal, curative intent you have here around 5-year survival of 63%. These are huge numbers. Talking about patients that were not fortunate to get to resectability. Even for these patients, when you put the pump in and give treatment with systemic therapy, all these patients do well. They get better disease control, and you can see their median overall survival improves 32 months compared to 15 months with systemic therapy alone. These are bad responders. Looking at data to talk about second line and third line, I mean, FDA approves now drugs that have 1 month increase in median overall survival, 2 weeks. And the response rates are very poor. When you compare these drugs to HI therapy together with modern systemic TPO that we use, excellent response rates, even for second line treatment, and improved median overall survival. Even for third lines treatment, very poor response rates for systemic therapy, way greater response for treatment. It reaches 38%. This is how it looks like when people get HI therapy for second and third line. You see the waterfall plot here, and the responses are excellent, and the median overall survival ranges between 20 to 30 months. This is second and third line. Even with some extrahepatic disease, usually these are patients with very few lung metastases. What about HIP for adjuvant therapy? These are resectable patients. They go for upfront resection of their tumors, and then you give HIP for resectable disease. These are the early reports that came from Nancy Kimeny in 1999 in New England, and she shows the primary endpoint was 2-year overall survival, and she shows excellent improvement in hepatic recurrence-free survival and overall survival for these patients. You can see the hepatic effect is actually really good. And this was the early stages this was no systemic therapy was basically 5-FU because there was no all the other ingredients, no FOLFOX, no other targeted. Another paper from the Kimeny family. This is Margaret Kimeny. She's actually her sister. She works in a different institute, and she also led a trial on the HIP plus systemic versus systemic alone. It also was a long time ago, and it was powered to detect liver recurrence only. It was not powered to detect overall survival. And it concluded, as you see in the numbers here, after 4 years, that the recurrence-free survival and hepatic recurrence-free survival is much better in the HIP group. Some of my colleagues take this trial, say, okay, it didn't show overall survival, but this wasn't power for it. So in summary, all the randomized controlled trials, the last one I didn't mention, it was outside in Greek, I think. And all these trials have shown that at 2 years and 5 years, there is dramatic improvement in hepatic recurrence-free survival, as you show by these numbers, and also by recurrence-free survival, as shown in here. Sloan decided, and this is where the things exploded back again in the States, because a lot of centers were not adopting this method, said, okay, I'm not sure we should use it, maybe it has a little bit of toxicity, and this is where things went back to be used, really, and I will show you how many centers started using the therapy after this paper came out. And this is the collective experience of Sloan Kettering for adjuvant therapy. We're talking about more than 2,000 patients that were compared the systemic plus HAI versus systemic therapy alone. And they also took the early ages versus the old ages. They took all the factors that you can think about, and I will show other factors. But basically, you get almost about 2 years improved overall survival for patients that get HAI treatment with FUDR after complete resection of their liver tumors. 2 years. If you look at these patients, most of them you will claim selection, but they were selected opposite to what you think. They had more KRAS, they had more liver metastases, They had a bad clinical risk score, and having said that, all these patients did way better with the HAI therapy. Sloan are so biased, they cannot lead any other trial because they have to now recommend pump therapy for everybody that comes in. This is what they do. There's no, they have no doubt. They will not run a phase 3 trial, but there is phase 3 trial that's going on, I will tell you about. What about HAIP therapy for irresectable? Pump trial, yes. So the cholangiocarcinoma resectable, you know, the facts, very rare disease, bad prognosis, very high rates of recurrence, up to 70%. And basically, I will show you in all the prospective data that there is no almost survival after 3 years. This is the pooled analysis from the ABC trial, which shows patients with intrahepatic cholangiocarcinoma unresectable. This is their median survival around 16.7 months. This is pooled data. And there is, most of them die by 2.5 years. There is almost no survivors after 3 years. What does HAI do to them? If you take all because it's very rare disease, you collect all the data together in a meta-analysis, you can track out like 154 patients, and you can see the differences in overall survival getting up to 39% at 3 years. But this did not stop the group in Netherlands led by Dr. Grootbas, who is also an expert of Memorial, to lead the PUMP2 trial that was recently shown in ASCO. And this is a single-arm trial which basically uses HAI therapy plus GEM and CIS, the standard regimen by the ABC trial, and compare it to GEM and CIS alone. And you can see the data here. You can get 33% patients at 3 years to survive compared to almost nothing at 3 years for the other group using the systemic therapy alone. Compare this data from the PUMP trial to other known data for you using TOPAZ-1 trial, immunotherapy, and the Keynote trial to show any improved in survival. And if you look at 1 and 2, 3 years for the PUMP trial, TOPAZ-1 trial, and Keynote trial for use of immunotherapy together with GEM-CIS, basically doubled. The numbers talk. So I hope by the end of my talk, time is up. This is what they say, that I could convince you that HAI is a very promising way and modality that we can use to treat patients with an unresectable disease, and for adjuvant therapy for resectable disease, and also for patients with unresectable iCCA. And the data was presented. There's so many other trials going on. One of my favorites is the EA 2222, which is led by my friend Mike Litsky and colleagues from Duke University, and they're basically trying to answer this question definitely. It's very hard to recruit for this trial because everybody is biased for the HAI therapy. You can see here the expansion of use of the HAI pumps by the 2016-17, where the papers came out from Sloan, and all the experts from Sloan were going all around the United States trying to get the treatment to their colleagues. They formed what's called the HAI Consortium. These are led by, it's around 60 centers now in the United States that trying to do this. For internationals, there is the Netherlands Cancer Center that is did the PUMP2 trial, and hopefully soon in Bordeaux Medical City we will do another center that would join the consortium. I would like to thank the pioneers, because without their work and dedication, this wouldn't have came true as therapy. You keep pushing. You know, I was triggered by the question about PPAC in the last session, and when you have all these pharma behind you to support all clinical trials, it's different when you lead a surgical trial. And we have a persistent oncologist that kept on doing this for 30 years, so people started believing her right now, and she's retired. This is a big say of how you should be persistent on what you believe is helping your patients. Mike D'Angelica, my mentor and the trainer of the surgical oncology program, Sloan, and reassessing, everybody knows from the Messiah trial of the rectal cancer, and also she led a lot of ICCA treatments for HAI. And Mike Litsky, who's heading the consortium right now. I would like to thank Dr. Hamid for his invitation and for working hard to having this therapy here in the EU. Thank you.
Excellent presentation, thank you. Floor is open. While wait, I'm going to ask before you. I am a proponent of HAI therapy, no question about it. I think the data is very compelling. The trouble that we hit were twofold. The first is we couldn't get the drug. The drug is too cheap. It's not, it is. So the first challenge is nobody was interested in the drug, and it was very hard to get, the FUDR. And that's why Europe was using oxaliplatin. And the second was the pump. The pump itself is quite expensive and was not covered by insurance companies, because this treatment is not covered by insurance companies because it's not FDA approved, or it's not, in NCCN guidelines and what have you. And as a result, the insurance companies will not cover this treatment. The patients will have to pay for the cost of the pump out of pocket, and the cost of the pump, if I remember, was something close to $40,000 US. And so those were the barriers that we hit when we were trying to implement this HAI protocol. I was wondering how you're going to overcome those.
Well, this is a really good question, because we sweat days and nights trying to answer this. FUDR is now very expensive. Actually, the main hurdle of us getting the treatment, because it's a monopoly in the market. People started using more and more HAI in the United States and Europe, and they closed the market for only one producer, I believe. And this is how a $200 drug came out to be $3,500 an ampoule. And it's quite a challenge. We try to mitigate this by splitting the vials and doing other ways of doing the delivery. The pump itself is not that expensive. The pump itself, I believe the rates are about $15,000, $16,000 each pump. But the main challenge now is the FUDR. I mean, if you compare this to current therapies that people get with the targeted therapies, I think with the results we have, it's compelling to give HAI. Very hard to convince, but we have to start.
So the solution was to make it more expensive.
So thank you. We were chatting earlier that I was a fellow in 1992, and we have been hearing about Nancy Kemeny since then. And unfortunately, it never got approvals. Now, it's very nice to see these numbers, but granted, you are comparing historical cohorts, numbers, and survival. So it's a little bit brainwashing. I think case selections is key here to benefit like you're showing. You have to have liver metastasis only. So if you have anything outside the liver, this is not going to work, unfortunately. Yes, you will have more PFS in the liver, so liver-related PFS will be improved, no question. But to impact on survival, you really have to select your cases. And as you mentioned, we need to see a good phase 3 trial. And I think now with more data accumulating, as you said, maybe it's a time to do the phase 3 to convince the rest of the world that, yes, it's worth going through the surgical procedure, the expense of the pump, etc. Otherwise, that's the reason it didn't go wild in the US even, because we were looking like, this is only in, Memorial. You have to go there to get these results. So nobody else really jumped on it. So I think we need the phase 3. It's nice to show these numbers, but again, case selection, I think, is key when you have to keep in mind.
We don't disagree.
Thank you.
Question? Same comment, thank you. Okay, we close?
Thank you.
Because of interest of time. Okay, thank you.
So we'll move to the next session. I would like to invite Dr. Trad and also Dr. Faq Jamali, both to moderate the next session. Dr. Trad does not need introduction. He's a consultant oncologist at WAM Hospital for many years, and we are pleased to have him with us tonight. Today, sorry.
Thank you, Ahmed, for the introduction. Now we come to the last session of this morning. Another topic, we hear a lot about it, but it's not very popular, and people keep debating whether it's needed or not needed. But of course, we are not going to talk now about this topic, HIPEC, but we are going to talk about PIPAC. So we need, for this, we have Dr. Muhammad Bashiruddin Inandar, who is consultant surgical oncologist at Berjil Specialty Hospital in Sharjah. And he is going to talk about the PIPAC, pressurized intraperitoneal aerosol chemotherapy in the treatment of solid tumors, feasibility, efficacy, safety, and indications. Dr. Muhammad.
Good morning, everyone. Thank you so much for inviting me. Professor Humaid, it's an honor to come to this honest gathering and share my thoughts. So PIPAC is nothing but pressurized intraperitoneal aerosolized chemotherapy in solid tumors. So the PIPAC will be considered for patients with disease something like this on the small bowel with extensive ascites. The agenda of my discussion will be introduction to PIPAC and the background, pharmacokinetics and the mechanism of action, clinical applications, safety and procedural guidelines, clinical results and studies. There are not too many studies actually, and dosage and treatment protocols and future directions. So why exactly do we need this modality of treatment, PIPAC? Peritoneal mets are seen once in every 30 seconds worldwide. A new patient is diagnosed, and the current therapy guidelines recommended only palliative treatment for these kind of patients. In spite of the recent progress, the peritoneal mets are supposed to perceived as a fatal disease with best supportive care as the treatment of choice. Patients with peritoneal mets have shorter survival than those with parenchymatous metastasis. They have extremely poor quality of life. For example, when we have a colorectal cancer with liver mets, they tend to have a very bad performance status when in patients who have colorectal cancer with peritoneal metastasis compared to have a very bad quality of life. So the poor prognosis is multifactorial. It is because of the chemoresistance to the cytotoxic drugs, poor tolerance of the chemotherapy, steeper patient performance decline, and majority of the patients develop intestinal dysfunction associated with tumor bowel invasion and also massive ascites, which tends to develop in these patients. Diffuse invasion of the small bowel is a contraindication for doing cytoreductive surgery in HIPEC. So extensive resection of the small bowel is not compatible with life. So these are the sort of patients we are targeting in PIPAC. Burden of disease, stomach cancer is the 5th most common incidence wise as well as causing mortality. Colorectal, 2nd in terms of incidence and 3rd in terms of mortality. These are the patients types we are dealing with when we are thinking in terms of doing PIPAC. As you can see in the image, patient with extensive small bowel deposits and also massive ascites. Brief about the peritoneum. Peritoneum is nothing but the continuous membrane which lies the abdominal cavity. It is parietal peritoneum which covers the abdominal walls, and the visceral peritoneum which covers the organs. So most common causes of peritoneal carcinomatosis, most common in women, it is ovary, and in men, it is colorectal. So overall, if we see ovarian cancer, colorectal, and carcinoma of unknown origin, followed by stomach and pancreas. So peritoneal transport of cells, malignancy happens because of 1, gravity, 2nd is the respiratory movements, and 3rd is bowel peristalsis. The risk of implants are maximum in the subphrenic, lesser sac, mesentery, diaphragm, and paracolic gutters, and also pouch of Douglas. So why are the peritoneal mets relatively resistant to the chemotherapy? The initial hypothesis which was proposed was because the molecular mechanisms were responsible, in spite of having developed new drugs, there was actually not much improvement in terms of the chemotherapy response. Like, for example, in gastric cancer, where doublet or triplet chemotherapy regimes were introduced, the survival of patients with peritoneal mets was modest at best. Same thing with colorectal cancer with irinotecan and oxaliplatin. The reasons of resistance are multifold. Number one reason is the peritoneum is very poorly vascularized. Only about 2 to 5% of the vascular supply from the cardiac output actually reaches the peritoneum. So whatever systemic therapy we give, only 2% reaches the target area. 98% is in the systemic therapy, is in the systemic circulation, thus causing more toxicity and less benefit. And also the peritoneal microcirculation has very small capillary vessels which actually do not let the drug reach the intended target. And the second important cause is when the tumor deposits on the peritoneum, it causes an increase in the interstitial pressure. This is very difficult for the chemotherapy drug to overcome and actually reach the intended area of treatment. Pharmacokinetics and mechanism of action. There is something like a blood-brain barrier. There's a peritoneal plasma barrier which prevents the absorption of most drugs. This, as I told you, is because of the, one is because of the small capillary size, and second, the increased interstitial pressure. So intraperitoneal delivery of drug can reach high local drug concentration where the treatment actually is intended. And also the second advantage is the systemic toxicity is very less because there's barely any systemic absorption. This is advantageous for treating diseases limited to the peritoneal cavity. On the other hand, as I told, IV drug delivery is relatively ineffective because of the mentioned effects. So tissue concentration, as shown, is superior in terms when given, when PIPAC is given, it is superior compared to systemic administration versus intraperitoneal liquid-based chemotherapy versus heated intraperitoneal chemotherapy versus laparoscopic HIPEC. And most of the studies have shown an increased depth of penetration by multiple folds when compared to normothermic intraperitoneal chemotherapy versus HIPEC, where it is slightly better, and for PIPAC it is markedly better. So PIPAC is nothing but a mode of drug delivery. Basically, it's a drug delivery system. It can be done in intra-abdominal, intrathoracic. So right now, only chemotherapy agents are used. Probably in the future, we can have all of these other molecules as well. The principles of PIPAC is it's a minimally invasive approach, optimizes the homogeneity of drug distribution by application of an aerosol instead of liquid, and applying increased intraperitoneal hydrostatic pressure to counteract the intratumoral interstitial pressure. And the blood outflow is limited because of the increased pressure used during the laparoscopy, and it does not cause significant liver and renal toxicity. So the clinical applications and indications, PIPAC is a novel technique where minimal drug concentrations are used. Typically, 1/10 of the drug which is used in HIPEC is used for PIPAC, and currently it is approved as a palliative scenario. Indications are usually histologically proven peritoneal surface malignancy after mostly multiple systemic chemotherapy with progressive ascites and peritoneal disease who are not generally fit to tolerate extensive systemic chemotherapy, and it has to be used only after a multidisciplinary tumor board. So this is an experimental model on the rat where on the left-hand side, the intraperitoneal chemotherapy without, which is normothermic. In the middle slide, we can see hyperthermic intraperitoneal chemotherapy showing the drug distribution it is increased onto the peritoneum. Whereas on the last side, during the PIPAC, there is a more homogeneous drug distribution pattern. So this is the advantage of doing PIPAC. The components used for PIPAC is number one, high pressure injector. We need an aerosolizer, which is called as a capnopen. Obviously, a drug has to be there and a target tissue. So this is the main component where all the magic happens. The liquid is converted into aerosol, and then under high pressure, it is injected. So we recommend for the caregivers, because we are using chemotherapy under high pressure, they have to be suited like how they used to during the COVID era. So this is not too unfamiliar for us. And PIPAC OT setup has to have absorbent mats all around, wrapping a transparent cover onto the capnopen where it gets connected with the high pressure injector so as to avoid any leaks, and safely dispose the disposables at the end of the procedure. For doing the actual procedure, we need to have an abdominal access. Basically, we need two ports, one 5 mm and one 12 mm. And during the PIPAC, we have to have tightness of the abdomen, which is documented by zero flow of carbon dioxide, because the PIPAC should not leak into the environment. And also the surgery has to be performed in an OT equipped with laminar flow, where frequent air changes happen and not much chemotherapy is actually left behind inside the OR. And these are the trocars which we use. They are specially designed balloon trocars, so they fit tightly against the abdominal wall from inside and also from outside, so that the leakage is prevented. The capnopen which is used is 9 millimeters in size. And during the PIPAC, the first step we do is do a laparoscopy, assess the peritoneal carcinomatosis index, take at least 4 biopsies, and the biopsies should be at least 3 millimeters in size, and try to use a punch biopsy instead of energy device. This is how the PCI score is calculated on a grade of 0 to 39. So most of the patients will have high PCI when we take them up for PIPAC. And this is how we take the biopsy, at least from 4 different quadrants. And the chemotherapy, when used, we have to use 4 eyes principle. So 2 people have to confirm name of the patient, the drug, and the dose, so as to avoid any untoward incidences. And this has to be a standard operative protocol. The first step we do is access the abdomen, do a staging laparoscopy, aspirate the ascites, calculate PCI, and take a biopsy. Prepare chemotherapy administration, do a safety checklist. And when we are actually doing the chemotherapy, we all go out of the OT. Probably this is the only surgery where the surgeon stands outside the OR and then does the procedure. So this is how the chemotherapy is circulated during the PIPAC, and this is the remote application from outside. The pressure is normally between 200 to 300 psi and a flow rate of 0.5 ml per second normally. This is the setup of the OR, and the surgeons are actually outside. So this is the pressure being shown on the monitor, and this is the OR setup. Clinical studies, so these are the results of one of our patients. During the first PIPAC, this is how the disease looked. After the second PIPAC, there is some fibrosis. And third PIPAC, we have extensive fibrosis and barely any disease which is seen. This is a case of colorectal cancer. There is a defined grading system to assess the response. This is called as a peritoneal regression grading system. Grade 1 shows complete response, where we barely see any tumor cells replaced by fibrosis. Grade 2 is major response, where we have less tumor cells and more fibrosis. Grade 3 is predominance of tumor cells, and PRGS grade 4, no tumor response. So the drugs normally used for upper GI are cisplatin at 10.5 mg per meter square, in 150 ml of normal saline, and doxorubicin at 2.1 mg per meter square. The pressure is 12 millimeter of mercury. The laparoscopic, during the laparoscopic procedure, and 200 psi, flow rate of 30 ml per minute, and the duration will be approximately 30 minutes. When we end the procedure, we have to be careful to avoid spillage. For contraindications for PIPAC, patients with extremely short life expectancy, less than 3 months, these are not good candidates to subject them to any invasive procedure. Second, patients with bowel obstruction and needing TPN and gastric drainage, very bad decompensated ascites. The relative contraindications are extraperitoneal mets, ECOG performance more than 2, and simultaneous anastomosis. The reasons to stop should be intraperitoneal progression, extraperitoneal progression, bowel obstruction, patient refusal, and conversion to curative cytoreductive surgery. Complications. PIPAC is not an experimental therapy. It has to be offered, though it is not yet FDA approved, in selected patients after careful multidisciplinary approach. We can offer. Available clinical evidence is class 2B. It shows that PIPAC is safe, feasible, and well tolerated, and it can be assessed by doing visually during the next procedure, also by RECIST and PRGS criteria, and also quality of life. Currently, these are the centers which are performing PIPAC across the world. There's a society of International Society for Study of Pleura and Peritoneum established in 2018, mostly based in Europe and few countries across the world. And there was a consensus statement in order to tell the exact dosage to be used. And it was decided that doxorubicin at 2.1 mg and cisplatin at 10.5 mg per meter square, followed by 30 minutes of observation. This is the checklist which is mandatory for all the procedures. And to conclude, advantages of PIPAC: it is minimally invasive approach, no debulking surgery is required, deeper uptake of drug in tumor tissues, it is wide, it has got a more effective drug distribution, fewer toxicity, less systemic absorption, and importantly, patients who undergo PIPAC notice increase in quality of life and not a decrease, and most of them tolerate the procedure very well, and it can be done as a daycare or one-day procedure at most. PIPAC is just a drug delivery system. It is an innovative technology taking advantage of the intraperitoneal barriers, and preliminary oncological results call for further comparative clinical studies. So what we do know now is PIPAC is safe. We do not know a lot of things because there are no randomized trials to support. And I conclude by this quote: all truth passes through 3 stages. First, it is ridiculed. Second, it is violently opposed. And third, it is accepted as being self-evident. Thank you. So there are quite a lot of studies. Due to lack of time, I'll skip them. Yeah, thank you. So these are the studies ongoing. And thank you.
Thank you, Dr. Mohammed, for the presentation. And the session is open for questions. I don't know, maybe because of the time limitations, maybe 1 or 2 questions. Hassan.
There's a video of the PIPAC which we can watch in the meantime. Yeah.
Real quick, I mean, as you alluded to, basically it is the HAI of the peritoneum.
Yep.
It is a local treatment that you are going to administer to the peritoneal cavity. The biggest challenge with it until today is what you alluded to, which is lack of data, right? So there's no consensus on the drug, the dose, which drug when, how do you select your patients, and what are the expected outcomes. So can you give us a little bit of your experience with this? I mean, how do you select your patients? How many, when do you stop? Do you give 3, you have good response, do you give more, do you stop? how do you integrate with medical oncology in the multidisciplinary setting?
So back in India, what we would do is like we would do these sessions once in 4 to 6 weeks. In between, systemic chemotherapy would be continued. And we've had patients who have received more than 6, 7 cycles, and with like therapy lasting for about 2 years. And these are patients of mostly colorectal and ovarian cancers. When it comes to upper GI, gastric cancers respond fairly well, but HPV generally don't do very well. The important thing is the patient should not be off systemic therapy in between if they are fit to tolerate the chemotherapy, though at lower doses.
So in this case, how do I know if the benefit is coming from the systemic therapy or for the combination of systemic and intraperitoneal?
So that is why during the procedure, we have a recording of the procedure always, and when the next procedure is done, we can actually record the procedure all over again, take biopsies exactly from the same sites where we previously took them from. We in fact put in markers to identify from where we took the biopsies, and we send them again and assess the peritoneal response based on, and based on that we decide whether there is a response or not. Whether it is due to systemic or intraperitoneal, so subjectively the patients definitely get benefit. In fact, we have a patient, we have done about 3 procedures in Burjeel right now. We have a patient who was draining 2 liters of ascites every day. He's a case of gastric malignancy. Post-procedure, we took out his drain and he's off drain, and after ultrasound, barely there is 300 to 400 cc. I would like Dr. Humaid to comment on this, if he can.
Again, we're not doing this for every single patient. We do highly selection for these patients, discuss the MDT, and then counsel the patient about the procedure not being approved 100%. I mean, we don't have anything approved 100%, but certainly we tell the patient, you know, this is a procedure that can be successful, can fail, and after a complete, comprehensive review with the patient, and if they agree, we go ahead with the procedure. Again, we know this is evolving, we know this is questionable, but still, I really think for desperate patient, I think we should discuss this with them.
I have a question on the choice of chemo. I mean, doxorubicin is not a known, antineoplastic for colorectal cancer, and the dose used is only 2 milligrams. So
no, for colorectal, oxaliplatin has been proposed. Doxorubicin and cisplatin is for upper GI and HPV.
And then the dose of cisplatin is really very high. Any systemic absorption? Any kidney damage may happen afterwards, or not really?
So we routinely assess the creatinine and the electrolytes at the end of the procedure. The dose is not very high. It's 10.5 mg per meter square, whereas in HIPEC we use somewhere close to 100. So it's like 1/10 of...
I thought it was per kilogram.
Per meter square. It's like 1/10. That is the advantage of this procedure. It has more drug penetration, lesser in terms of delivery, actually.
So are you considering it upfront, or patients who failed on first or second line of treatment? Because if it's late, in this case, these are patients who are really resistant to chemotherapy. So how do you...
So that's the resistance to chemotherapy is because of low, the chemotherapy does not actually reach that area. So we are trying to overcome. Usually these patients are after multiple lines of chemotherapy.
These are patients who we do see today, patients responding well to systemic therapy, and these patients are having peritoneal metastasis. So again, when they are developing resistance, it's not only outside the peritoneal area, but in the peritoneal area which was already exposed to chemotherapy. So how do we know that this is going to work on these tumor cells which are supposedly resistant to this?
So that's what we need to discuss them, and once the procedure is done, during the next procedure we can actually see the response. That's the beauty of this procedure. Each time the procedure is done, it is visible in front of our eyes whether the tumor is responding or not. So we suggest that 3 cycles are done, and then only call it whether it is responding or not responding. So
okay, thank you. I think this is our last session. We have break for 10 minutes. Oh, continue? Okay.
Okay, so whoever wants to go get coffee can go get their coffee and then come back.
Thank you very much.
We will continue.
Thank you. So we'll continue now. I know people would like to have a break, but just for the sake of time, we will move ahead with the next session. It is GU session, and no one better than Dr. Deborah Mukherjee to moderate the next session. Dr. Deborah Mukherjee, she is a consultant oncologist at Clemenceau Medical Center in Dubai, and also Dr. Saeed Hamad as well, moderating the next session. No break. Yeah, you want coffee? We'll bring you coffee. You know who's talking? Sure? Okay.
Don't worry. Good afternoon, everybody. So this is a GU session. I hope it will be a very exciting discussion. So if everybody had their coffee, and please can sit down, we can start the session. Let me ask my speakers to be with me. Dr. Sarfaraz, a urologist, please on the podium. Dr. Faraz is a consultant urology surgeon working in the Sheikh Shakood Medical City. And then I have Dr. Mariam Al-Sani. She's a consultant radiation oncologist working in Medical University Hospital, and Dr. Deborah Mukherjee, consultant medical oncologist from Clemenceau. And the aim of this session is to discuss what are the current advances for patients with muscle invasive bladder cancer, and we're talking about curative treatment option for these patients. It's quite. If we can, bit quiet in the house, please. It's a bit loud. Thank you. So let me ask Dr. Deborah Mukherjee to present a case, and there will be discussion around the case. There will be some voting questions. I will hope that we have an active discussion during the session. Thank you.
Thank you so much, everyone. In the interest of time, we'll ask everyone to grab their coffee and come and participate in our interactive case. And we have our multidisciplinary panel here for you today. We have our urology, radiation oncology, and medical oncology experts, as well as you all to discuss a really tricky question about locally advanced muscle-invasive bladder cancer. So we're going to start with a case. This is a 53-year-old female patient presenting with hematuria. She has found on TURBT to have an anterior bladder mass, and on MRI she has extension to the fat, a T30, no obvious lymph nodes, tiny pelvic lymph nodes seen on the scans. She has significant lower urinary tract symptoms, particularly after her procedure and biopsy. Her PET-CT shows no obvious metastatic disease, and a biopsy shows high-grade muscle-invasive urothelial carcinoma. She is of relatively good performance status. Her only comorbidity, I think, was hypothyroidism. All right, so we're just going to have a little bit of a review of how we approach the multidisciplinary management of the patient with locally advanced muscle-invasive bladder cancer, and we're also going to just touch on some of the new data that's been presented recently, including the recent ESMO meeting, and just as a reminder about the NCCN guidelines in muscle-invasive bladder cancer. We have lots of different options, and we're going to talk with our multidisciplinary team about these. So our primary treatment, we have the options for neoadjuvant chemotherapy, bladder preservation with chemoradiation. If patients are not candidates, we have other systemic options, plus the option of upfront surgery. So lots of things to discuss with our multidisciplinary team. So if you'd like to scan the Slido, we have our first question coming up. Has everyone managed to do that? I think we're missing a slide. Okay. I think we're missing a slide about options. So this is our first slide voting question about treatment options. And I'm going to start talking to the panel. So okay, let's talk to our panel first of all. So from the urology side, which patients are candidates for upfront cystectomy, Dr. Ahmed?
Thank you, Deborah. I think if you think about the surgical options for the patient with the bladder cancer, first question we need to ask whether we really need to take bladder out or we can opt for the bladder preservation surgeries. In this typical case we presented, we like to make sure there is no carcinoma in situ. What is the bladder capacity, especially she has significant symptoms. So these two important factors will decide us whether bladder can be preserved or not. And coming back to your question, like whether which will be upfront cystectomy. So we have patient who is non-muscle invasive, highest risk bladder cancer. They can go for cystectomy if they opt not to preserve bladder. And we have a patient who has a contraindication for neoadjuvant chemotherapy, and they are otherwise fit to get cystectomy, so we can proceed with the cystectomy for these patients.
Okay, always something that we need to discuss. So you can't see the voting results here, but we have more than 70% of patients voting for neoadjuvant chemotherapy. We have 29% of, down to 27, complete TURBT plus chemoradiation. So Dr. Ansari, which type of patients would be suitable for the bladder preservation strategy as an upfront strategy?
Hi, Aslan is my last name. That's okay. So, so when we are dealing with the confined to the bladder TCC, we have to make sure there is no lymph node metastasis. So PET-CT that is negative, it is imperative for us. Also, any contraindication to neoadjuvant chemotherapy, as Doctor said, it basically is important because we like to start with the neoadjuvant chemotherapy that is usually followed by a maximal TURBT. And in the case of non-metastatic disease in the pelvic and also in systematically, obviously, then we can proceed with the protocols that basically includes radiation as a part of the bladder preservation.
And this patient had a T3 disease going all the way into the fat. Is that a relative contraindication to?
No,
that
we can
still is something that we can do?
The fact that she has lots of lower basically symptoms, that would might basically induce that she's going to harbor more of a significant side effects, but that is still not an absolute contraindication.
Okay. Dr. Hamad, you have worked in the UK. They do a lot of bladder preservation in the UK. Which patients are you tending towards recommending neoadjuvant chemotherapy versus bladder preservation strategy?
So I think when we discuss the patient in MDT and after seeing the patient, we need to be mindful of what is the aim for the treatment for that patient and what the patient preferences are as well. Obviously, depending on the patient's comorbidities and the type of the disease they have, what about the bladder capacity, how much superficial disease, how much previous BCG has been given. All these factors are very important, and what the patient wishes in terms of preservation of the bladder versus cystectomy. Obviously, there are differences in terms of oncological outcome from these two strategies, but there's never been a head-to-head comparison. So I think the patients who have radiotherapy tend to be frail patients and often not fit for surgery. Hence, we can't really compare the two. So I'll look into these factors when deciding treatment for patients. I think each patient treatment should be individualized.
Absolutely. And I think up till now, the standard of care has been, in fit patients, neoadjuvant chemotherapy followed by cystectomy. We know that in many areas, patients do go straight to cystectomy, whether that's a plus or a minus. And now we're getting into more perioperative therapies that we'll see the data for later. I think just the main message is that all of these patients do need to be discussed in the multidisciplinary team, and that we take all of their comorbidities, their bladder function, all of these things, renal function, all of these things into consideration. So most of our audience want to go for neoadjuvant chemotherapy. So our next question is, what type of platinum chemotherapy would you use? So if you could scan the code again, I'd like you to all vote on your favorite neoadjuvant chemotherapy. Dr. Hammond, as our medical, what would you go for? What do you use in your clinic for someone who has good renal function?
If somebody has good renal function, we're planning for cystectomy, so that was the question, yeah?
Chemo, yes, chemo protocol. So we've got a choice between cisplatin gemcitabine or dose-dense MVAC.
I tend to use gemcitabine and cisplatin. That's always been the case. I've not really used dose as MVAC. But outcomes look very similar. And especially now with the fact that we have adjuvant immunotherapy, I don't think we need to really intensify the chemotherapy anymore.
Okay,
so I think GemCis is a reasonable option for majority of the patients.
That's a very good point. Now we're thinking about other options. So most of our audience, more than 90% will go for cisplatin gemcitabine. We know that certainly in the metastatic setting, there's been equivalence between the two. I'd just like to draw your attention, if we can go back to the slides, to the fact that we do have some provisional data. Again, this was a negative trial, but with some really interesting data on later on follow-up about the use of dose-dense MVAC versus gemcitabine cisplatin for perioperative treatment. So this is 5-year follow-up. So this is a randomized trial. They had 500 patients enrolled. At 3 years, there was an improvement in progression-free survival, but the study didn't meet its primary endpoint, so this was a negative study. But the surprise was that at 5 years, we did see this separation of the curves. You can see those crossing hazard ratio, those crossing confidence intervals, but we still do have these separation of curves. And I think if this was an immunotherapy trial, we'd all be jumping up and down and it would be potentially approved. But we do have to bear this in mind. This is an option for perhaps our younger and fitter patients with a shorter duration of neoadjuvant treatment. So any comments on the use of dose-dense MVAC? Were you convinced after seeing these data presented at ASCO last year?
I think it was after a long time we saw such data, but I think at the same time we have emergence of immunotherapy really coming in, and I think long-term outcomes looking very promising for those patients. I think for me the future is really beyond the chemotherapy now, really looking into long-term outcomes with the use of immunotherapy. So that's what I'll be more excited. I think GemCis has been used in the immunotherapy trials, and this regimen has not been tested in the immunotherapy trial, so I think that would be a bit difficult to interpret.
Absolutely. And I think one of the main messages from the follow-up of this study is that the cumulative dose of cisplatin really does matter. So the patients who did best, obviously with the fewer comorbidities, were able to tolerate 4 full doses or 4 or more full doses of cisplatin or dose-dense MVAC. So duration and cisplatin dose do matter when we're going for the best responses in neoadjuvant therapy. Okay, so possible standards of care. This is a slide borrowed from Dr. Plymack. So once we give our systemic therapy, we may have no residual disease left in the bladder. We may have residual disease, or we could have potentially progressive disease or subclinical metastasis beyond the bladder. Currently, perhaps our standard of care has been surgery for all patients after neoadjuvant chemotherapy. So do all patients need cystectomy? Do those patients who have a great response need a cystectomy? And I'd like you to vote again, but we have some possible scenarios of patients having no residual disease, having no surgery, perhaps some adjuvant therapy, as Dr. Hamad mentioned. Patients who have residual disease in the bladder, could they have surgery or radiation therapy? Could we then personalize the treatment based on pathology? So if you could vote again, if you could scan the code. Again, I'd like to ask our audience for their current discussions and what they're leaning towards in their MDTs. So, A, cystectomy in patients who have a complete response on imaging and TURBT after neoadjuvant chemotherapy. Next step, majority are voting for cystectomy, surveillance 12%, chemo-RT 7-8%. Okay, Dr. Ahmed, what do you think? Is cystectomy still standard of care, even in patients who have a response to perioperative therapy?
Yeah, I think still the standard of care is they will go for cystectomy, and there is a reason for that. The effect of chemotherapy is not durable. The disease will come back. We have some data from the SWAG S2019 study where the 60% patient who have clinical T0 disease and they went for cystectomy, they have a residual disease. But this area is also an active area of interest, research, and I think we may get more data in the next coming years. But current standard is that all of these patients, they need to go for cystectomy.
And do you have patients that then refuse cystectomy after having an excellent response?
I don't have any patient refuse because they were explained in a way like this effect is not durable. Some of the patients, like after cystectomy, say there is no tumor, so why the bladder was taken out? Then we need to have a discussion that these effects are not durable, which we achieve for the neoadjuvant chemotherapy at the initial stages.
Okay. Very important. About patient expectations when they start on a treatment, what are they expecting to have at the end? Dr. Asalani, your views on patients, and do you see these patients who have a very good response or complete response as far as we can tell to neoadjuvant chemotherapy are then keen on a bladder preservation strategy? Because this is certainly something that many of our patients are keen for once they know that they've had a great response.
That's true. As I said, a very instrumental factor is that the patient must achieve a good response and have a maximal TURBT if you want to proceed with any kind of a bladder preservation. I also want to draw your attention to a study that was basically presented only last week ago in the presidential of Astro, dealing with the same cohort of the patients, T2, T3, T4, and 0, and it was basically presented as a new era in treatment of the bladder cancer patient, where we can use the adaptive radiotherapy. So when you do adaptive, meaning every day that the patient comes, we do adapt the calculations and all the dose distribution based on the position and based on the anatomy of the bladder that day. This helps us to basically escalate the dose. And the study was, again, three subcategory of patients. First category, they received a standard treatment the way we deliver. Second was standard doses with adaptive, and the third was dose-escalated adaptive, where we can give SIB to the whatever residual disease left. And 2 years follow-up basically shows it has higher disease-free survival on the dose-escalated arm. So it's a new era. We can consider it. We can discuss it with the patient as a possibility.
Dr. Hammond, are you offering or discussing the possibility of bladder preservation in patients who have a good response, or are they all expecting to have surgery from the start?
I think in the MDT, when you're offering someone neoadjuvant chemotherapy, obviously the plan is that this patient will go for cystectomy. When we're talking about going for radiotherapy, that's a change in the plan. So something has happened that asking us to change the plan. So I think because neoadjuvant chemotherapy followed by chemoradiotherapy has not been tested. So although some clinicians start chemotherapy and then start chemoradiotherapy, but that's not usually the plan, so it's not been proven. But if someone who has a very good bladder function and excellent TURBT, and there's no disease at the end of the neoadjuvant, and that now they want to preserve the bladder, I think it could be a very good option for that patient, as long as they understand the surveillance requirement which comes with bladder preservation. I think it could be a very good option for that particular patient, yeah.
Fantastic. So again, more room for MDT discussion, even when patients are starting on our perioperative therapy. So if we move on, if we could go back to the slides, you've already mentioned the issue of adjuvant therapy, and we have had 1 negative and now 2 positive studies using immunotherapy in the adjuvant setting. So we have the Checkmate 274, this is approved, the adjuvant nivolumab for 1 year in patients who still have disease after neoadjuvant chemotherapy or have straight to surgery and have high risk for recurrence. We also saw the very similarly designed Ambassador trial, which was presented this ESMO. This was positive for disease-free survival. Of course, we're still waiting for those overall survival endpoints, and we do not yet have evidence that this strategy of adjuvant immunotherapy improves overall survival. So, Dr. Hammond, you mentioned this. Is this something that you've adopted in clinical practice for adjuvant immunotherapy in high-risk patients?
Yeah, I think the data for nivolumab looks really promising. So that's been adopted in our practice currently. So I'm offering these patients adjuvant immunotherapy for a year with this high-risk group, yes.
And still, even without overall survival data, you're happy to adopt this?
I think that there is trends towards overall survival. If you look at the data and it looks promising. And similarly, the data for pembro also looks very promising, although early results. But I think it is something we should. It's already recommended in the guidelines as well. So I'm using it for my patients. We can ask colleagues in the session what's their practice is.
So who is currently using adjuvant immunotherapy for high-risk patients as per approval? Yep, okay, good. Again, another reason to discuss these patients in the MDT. So I think the main message is that these patients need discussion along their disease course, not just at the beginning. And can we improve on perioperative therapies? So the aim of this session was really to discuss a case, get different opinions, but also give you some flavours of updates on what's to come. And we just saw this study presented at the recent ESMO session by Tom Powles, showing that there is now evidence for perioperative chemoimmunotherapy followed by adjuvant immunotherapy. So this study was randomizing patients to the standard arm, which was gemcitabine cisplatin, which many of us are using, versus durvalumab plus chemotherapy. This was 4 cycles in the neoadjuvant setting, followed by surgery. And then in the experimental arm, the patients had 8 cycles of adjuvant immunotherapy. So this was the overall survival curve, which again, a very nice separation, looking with a hazard ratio of 0.75. So again, these are really exciting times in bladder cancer. For the first times, we're seeing advances in both advanced and the perioperative management of patients. So let's ask our surgeon, Dr. Ahmed, what do you think of these data? Would this be something that you would be keen for your team to adopt in terms of these types of survival curves? This is 82% at 24 months.
I think the real challenge for the bladder cancer patient is that we haven't seen much in survival benefit despite doing all the surgicals and previous. So any data which is showing us there is a survival advantage, this will excite not only the physician, the oncologist, and also benefit patient. So I think this will have a role in the management of bladder cancer in future.
And any concerns about operating on patients after neoadjuvant chemoimmunotherapy, or this is not something that you'd be worried about?
I think it's because it's not done so much at the moment, like we don't have much data to say what effect will have. But there is no much evidence like whether it will be any intraoperative difficulty or not. So I think this need to be assessed as we start using this a bit more frequently in future.
Okay. Dr. Aslani, for patients who have chemoradiation, do you think there may be a role in the future also for adjuvant immunotherapy or incorporating checkpoint inhibitors?
Yes, so we are looking for radiosensitizers all the time. So if there is any added benefit in terms of enhancing the effect of the radiation, that would be greatly appreciated with the immunotherapy.
Good. And Dr. Howard, what do you think of the Niagara data? Is it something you'd be keen to use? Should it be approved?
I think it's a very important trial because you're starting to see higher complete responses. So response rates, I think, increased by 10 to 15% from the chemotherapy, on the top of the chemotherapy. So again, a patient of yours who had chemotherapy and doesn't want surgery, and if he has a complete response from this study, may even opt for organ preservation. It's not been tested, but the response rates are going up, which is very interesting. I think, so in adjuvant setting, you don't know which patient is responding. So in the neoadjuvant setting, actually, you can determine whether the patient actually responded to the immunotherapy. I think that will be very useful.
Absolutely. So exciting times in bladder cancer. We're now seeing more effective therapies in the advanced disease, bringing these forward into the perioperative setting. And just a few concluding slides. Is this going to not advance? No? There we go. So just in summary of our discussion, before we move to our next segment, neoadjuvant platinum-based chemotherapy remains our standard of care for muscle-invasive disease. We certainly have options in some patients for upfront cystectomy, in some patients for upfront bladder preservation strategies, and all these patients need to be discussed. We have new data for perioperative chemoimmunotherapy that's not yet approved, but most likely will be, and multiple studies investigating combination therapies and bladder preservation strategies in the neoadjuvant setting we need to watch out for. The high risk of recurrence, as was mentioned, post-cystectomy remains a challenge, and adjuvant nivolumab is now FDA approved, and we are using it here in the UAE. For high-risk cases, we now have new data for the use of adjuvant pembrolizumab, which has just been presented as well. And I think that's the end of our slides. Any final comments before we move to our next session from our panelists? Dr. Hammond.
I think bladder cancer is an aggressive disease. I think MDTs is really important. I think patients should be involved in the discussion because it's, even surgery is life-changing experience for these patients. So I think we got to make the decisions carefully and discussion with our colleagues. I think it's very important that we do an MDT for all our patients before taking any decision for these patients.
So I'll let our panelists have a final concluding word before opening to a couple of questions. Dr. Aslani.
Oncologists, we like the concept of bladder preservation to be more entertained, more considered, more discussed with the patient, especially by our surgical colleagues. With the advances of immunotherapy and also delivery of the radiation, I think this is a new era in the future treatment of the bladder cancer.
Fantastic.
I agree. I think the trimodality treatment has, we have now big data for the trimodality treatment with the maximum TURBT, then radiotherapy. And now if you look at the Lancet Oncology paper last year, they even recommended that all the patients who has a suitable criteria, along with a cystectomy, they should be discussed about TMT as well. So I think the bladder's cancer management is changing, and so we just need to keep our ears and eye open. Surgical interventions will be there, but adjuvant treatment, perioperative treatment, and also the radiotherapy, they will have a major role in management of bladder cancer.
Fantastic. Thank you so much. So just as we've been discussing this morning with rectal cancer and organ preservation, this is also something that we're aiming for suitable selected patients with bladder cancer as well. So thank you. I'd like to open for a couple of questions.
Yes.
We have one first question.
Just comment.
No, I have to give the
no, I was
microphone.
waiting. You didn't see me. No, I was going to say more than half the patients are not surgical candidates, so it's not a trivial thing, as mentioned. And this was stressed lately, that trimodality therapy can have very close survival to surgery. So I know we all talk about surgery, but it is not a must that we send these patients to surgery. And certainly chemoradiotherapy, we have been doing it for years and years, but the latest trial confirmed that up to 60–65% can be cured with chemoradiation.
Exciting times for bladder preservation. Dr. Aida, can we have a microphone here?
To the adjuvant immunotherapy, nivolumab. I mean, I'm a little bit skeptical because we don't have overall survival, but if you looked at the graph, it's a little bit different than the adjuvant immunotherapy trial where we see separation of the curve very early on in the intention to treat population, but then with the longer follow-up, you see that the curve is actually sort of like closely to join together. So I'm skeptical that it may show overall survival in the future. So I would prefer always chemotherapy over that. And I would reserve this option for those who actually cannot totally tolerate or eligible for chemotherapy. So what's your intake, the panel, on this point?
Adjuvant immunotherapy is an option for patients who receive neoadjuvant chemotherapy. For patients who did not receive neoadjuvant chemotherapy, they can receive adjuvant chemotherapy followed by nivolumab. So it's an addition on the top of the chemotherapy. So it's not a replacement of the chemotherapy currently, the data. So currently the data is after the adjuvant or neoadjuvant chemotherapy.
Yeah, so I don't think it replaces, I don't think you're right. I would be very concerned about replacing chemotherapy with immune checkpoint inhibitors. And we know from the metastatic setting that only those who really are ineligible for platinum-based chemotherapy are eligible for single-agent checkpoint inhibition, and they should have the biomarker of a high PD-L1 score. Given that, there are patients who are frail and have long-term responses, we all know, and we have those patients in the clinic. So currently, our standard of care would be chemotherapy plus the consideration of adjuvant immunotherapy. Dr. Rana.
Yeah, just one comment and then one question. The comment is that in bladder cancer, I think for the local treatment, we have reached the peak. Surgery, radiotherapy, that this debate is kind of over. Because patients they suffer because of systemic disease. So we look forward to have more biomarkers and more systemic therapies and IOs and all kind of stuff. My question is that in this locally advanced patient, if Dr. Sarfaraz went in for surgery after having had chemotherapy and the final outcome came back as positive margin with one positive lymph node, how would you then, what do you recommend in that setting?
So this is a tricky one. There are some data, I think there's some really nice studies from Egypt about adjuvant chemoradiation. This is something to be discussed with the patient, but we really don't have level 1 evidence that it really does make a difference. We now have adjuvant immunotherapy, which we do perhaps have some bigger studies. There is really interesting data about adjuvant circulating tumor cells, which we didn't have a slide here, but lots of trials are ongoing, stratifying patients to ctDNA positive or negative to give adjuvant immunotherapy or other treatments. So I think that you're absolutely right. There are some patients who are going to do very badly, and we need to intensify those treatment as per selection. You had a comment, Dr. Hamad.
Yeah, what would you do right now if in your clinic, for example? Just wanted to know your opinion for that type of patient.
So the patient has neoadjuvant chemotherapy, has surgery, and then has a positive margin and a positive lymph node. Okay, Dr. Hamad.
For me, it's quite easy. I'll call you and say whether you're willing to give an adjuvant radiotherapy. Majority of the time, you say no. Because of the risk of toxicity. And we know from the Pembro neoadjuvant data, patient with positive margin actually tried more benefit. So we have an option for those patients currently, but we do not have any randomized data for adjuvant radiotherapy in bladder cancer. So we do not have any category 1 data available for this.
Dr. Aslani, would you
I think everybody discussed that. Yes, something to be discussed. We have apprehension in terms of the side effects. Again, I think so much depends how much of a positive margin we are looking at, how much of a gross disease left in the pelvis, what is the extent of lymph node involvement. So I think it's something that you can discuss it on the individual basis. We cannot have a clear plan for all the cases with the same scenario.
I think that's the problem. We know that it definitely can be done. Will it help the patient above and beyond more systemic therapy? Will it actually cure them? We don't have really solid evidence that it will. But we do know that patients who have this early immunotherapy, perhaps this can preserve their quality of life for longer. The overall survival data may be muddied by patients who have early relapse and then immunotherapy in the metastatic setting, which pushes the survival curves. I'm not sure. We have lots of new studies to come. Great. I think we're going to have to move on to our second session, and I think it's time to thank our panelists. Thank you so much for joining us today. Truly multidisciplinary.
Thank you very much, Dr. Mukherjee. It was an excellent session. Let's move on to our very heated debate. I think we may come to some conclusions today. So this is the second time we're debating it. But thank God I'm out of the debate this time. So we will be discussing the first line management for patients with metastatic advanced bladder cancer. We have two speakers with us. We have Dr. Wael Al-Shastahvi from Egypt. He will be discussing role of EV Pembro in the first-line settings. And then second speaker will be Dr. Jawahir Ansari, consultant medical oncologist from Tamam Hospital, colleague and friend, and he will be talking about platinum immunotherapy in this setting. And we really need to tease out how we're going to select our patients better for these very effective treatment that we have now available. So we'll have 10 minutes each. Speaker will have 10 minutes, and then we'll have a discussion. If I can invite both of you to please be on the stage. Thank you very much. We'll start with Prof.
Bismillah ar-Rahman ar-Rahim. First of all, I would thank Dr. Hamid for this very kind invitation to be here with you, and congratulations for the success of this very elegant conference. Actually, I'm coming from Al-Azhar University, one of the oldest universities in the world, The Al-Azhar Mosque has been built more than 1,000 years ago. And when the first medical school has initiated in Egypt, they chose the student from Al-Azhar University. So I'm very proud to belong to this very elegant university. Slides, please.
Micheline, we had a voting slide first, yeah?
I can't speak without slides.
We're just going to do a voting, quick voting.
Voting first? Okay. What percentage of patients, for fit patients with metastatic urinary bladder cancer would use Pembro plus EV versus platinum immunotherapy? So most of the audience vote for Pembro plus EV, so my job will be easy today. Next question. Do we have more questions? No?
Can we start the presentation for Prof, please?
This is my agenda for today. I will go through my talk very quick because of the time. Actually, we have more than half million patients with bladder cancer diagnosed every year worldwide. And we have mortality like 200,000 patients every year. In Egypt, bladder cancer ranked third. And once the patient gets a metastatic disease, the mortality rate will reach it like 5% at 5 years. The first step in treating a patient with metastatic bladder cancer should be patient evaluation and stratifying patient according to eligibility to different treatment modalities, cisplatin eligibility, immunotherapy eligibility, and recently enfortumab vedotin eligibility. Additionally, we have to consider the previous treatment received by the patient, the interval between treatment and relapse, cost of treatment, and eligibility for this treatment in the region. Actually, along 30 years, we didn't see any achievement in the overall survival of metastatic cancer patient, bladder cancer patients. The median overall survival was ranging about 15 months until the year 2020, when the Javelin 100 trial showed improvement for the first time in the outcome regarding survival. At this time, we have exceeded the 20 months overall survival. In the year 2023, we have two emerging very promising protocols, another standard of care. The first one is a Checkmate 901 that showed again median survival above 20 months, and the second booming trial was the EV302 that showed median overall survival exceeding the 30 months for the first time. And we're still waiting the future. I think in the coming few years we'll see maybe a 10-way debate instead of 3-way debate. This pushed the guidelines, the ESMO guidelines, to classify the treatment guidelines based on the availability of the EV. If the EV is available, then the recommended EV plus Pembro as first line, and if it's not available, then the patient is stratified according to cisplatin eligibility. And if the patient is cisplatin eligible, then he have two options, either to start cisplatin with chemotherapy, followed by avelumab as maintenance, or to receive Nivo plus chemotherapy, cisplatin chemotherapy, followed by maintenance Nivo. The other option, if the patient is not eligible for cisplatin, then the platinum-based chemotherapy followed by avelumab is the option if the patient didn't progress after this initial treatment. Actually, the NCCN guidelines come with the same also recommendations, but the pembro plus EV as the first-line preferred regimen and other recommended regimens, IO plus chemotherapy either concurrently or sequentially. The antibody drug conjugate, we are know that, I think we are all familiar with this slide, how it works. The important point here is there is synergistic effect coming from combining the EV or antibody drug conjugate with the immunotherapy, because actually the antibody drug conjugate likely priming the immune system to initiate some immunity against the tumor. So if we combine both together, we may get benefit or maximum benefit from these both new treatments. The bladder cancer patients is lucky because they have multiple receptors expressed on the different histopathological types of bladder cancers. We have the Nectin-4 expressed almost in 80 to 100% of the patients who have bladder cancer. So we have actually like targeted receptors on the cell walls that we can target. The first phase 3 trial that showed efficacy from AV in the bladder cancer was the AV301 that randomized patients in the second setting after failure on platinum-based chemotherapy or checkpoint inhibitors to receive either EV or to receive physician choice chemotherapy. This trial showed clear improvement in overall survival, with median overall survival about 13 months versus only 9 months for the chemotherapy, and with response rate 40% objective response rate for the EV versus only 18% for the patient who received the chemotherapy. But in this trial, we was having mortality rate related to treatment recorded as 2.4% in the patient who received the EV. This is not only the ADCs that showed promising result in the bladder cancer, also the cetuximab givotican has shown also promising result also, maybe in the same figures like we have seen in the AV. The median overall survival for the patient received this second-line treatment was about 11 months, just matching what we have seen with the EV. But remember that this is phase 2 trial. And the emerging trials that did make like or made like a very big change in the treatment paradigm of bladder cancer treatment or stage 4 bladder cancer treatment is the AV302. This trial randomized patient regardless the platinum eligibility to one of two arms, either to receive non-chemotherapy containing arm for the first time, the enfortumab vedotin plus pembrolizumab versus gemcitabine plus cisplatin or carboplatin. The primary endpoint of this trial was PFS and overall survival. The median age of the patient received this trial or treated in this trial was about 70 years. It was 69 years. And half of the patient almost was cisplatin eligible, and another half was carboplatin eligible. And the BDL1 expression was highly expressed in about 60% of the patient. This trial showed marvelous actually improvement in PFS. The absolute benefit at 2 years was 32%, and the other ratio was 0.45. And this benefit seen along all the different subgroup of patients. The same has been done has been watched for the overall survival. The absolute difference of the overall survival was more than 24%, and the other ratio was 0.47. and with again benefit seen over all the subgroup of patients, either the cisplatin eligible or non-cisplatin eligible. Even for the non-cisplatin eligible patient, the median survival was better. Regardless the PD-L1 expression, regardless the site of metastasis, liver, lymph node, or any other site, with very good duration of response. The duration of response did not reach it for the patient who received the AVB, and the confirmed objective response rate was about 70% for the patient who received the AVB, versus only 44%, with about 30% develop complete remission after this regimen. Important point is the subsequent treatments that received at failure, and not at failure, even after the initial treatment. About 30% of the patients who treated with chemotherapy received avelumab as maintenance therapy. This may generate a control arm for the patient who treated with cisplatin or platinum-based chemotherapy followed by avelumab versus the patient who received the AVB as the non-chemotherapy regimen. Important point here is the toxicity. Actually, if we look at the toxicity, you will find the grade 3 or more toxicity is less in the AVB protocol. But we have a unique toxicity associated with the AVB. The dermatological toxicity, the diabetes or hyperglycemia, and importantly, the peripheral neuropathy. We have to monitor our patient very well during treatment. Actually, the dangerous toxicity coming from the AVB coming early. Because of this, we have to watch our patient very strictly after or during the first 2 cycles of treatment. We have to monitor the patient, we have to take prevention measures, and we have to warn our patients about the dangerous symptoms or the warning symptoms of dangerous side effects like malaise, fever, mucosal infection, and dermatodemia. If the patient develops grade 1 or 2 toxicity, nothing to be done, we'll continue treatment. If the patient develops the grade 3 toxicity, we have to stop treatment, give the appropriate treatment, then we resume the treatment either with the same dose or reduced dose, only 1-step dose reduction. And if the patient developed Stevens-Johnson syndrome that should be confirmed by biopsy or grade 4 toxicity, we have to stop treatment permanently. This is this table showing the 3 trials that we are debating about it now. Actually, it's not for the comparison for the trials, but we have to take a look for the 3 trials in one slide so we can make a decision based on the response, expected toxicity, and the other factors. The advantage, the biggest oncological outcome has been seen for the patient who received AVB plus Pembro. However, the discontinuation rate was 35% for the patient who received AVB. And there is some unique toxicities associated with this regimen. And we have to remember that the treatment-related deaths in this trial was less than 1%. Looks to me that we are learning more about the toxicity of the AVB. And additionally, the cost is very important. It's a little bit high for the first few cycles during the AVB. This is in Egyptian pounds. After the PSP programs we have in Egypt, actually we have a good chance in Egypt. All these drugs are not available in the governmental hospital, but we have deal with Beit Zakah al-Masri that can offer these drugs for free for our patients in Egypt if the patient is fully eligible for these treatments. So this is all. Actually, this is not the end of the story. We have coming data along the 2-3 years. I think we will see more lines of treatment available. And finally, the conclusion take-home message. We are in the beginning of new era in systemic therapy for bladder cancer. Key components for successful treatment include through baseline evaluation of patients, symptoms control, treatment choice based on patient eligibility, early recognition and management of treatment-related toxicity, AVB has emerged as the preferred first-line regimen for metastatic bladder cancer, irrespective of cisplatin eligibility. However, eligibility for AV and IO are critical before starting treatment. Additionally, close monitoring of the toxicity, particularly during the early treatment cycles, is essential. In case where AVB is either unavailable or the patient is ineligible, alternative highly reasonable treatment options include cisplatin, gemcitabine, navalbine for cisplatin-eligible patients only, or platinum-based chemotherapy followed by maintenance avelumab in patients who are platinum eligible. By this, thank you for your attention. Thank you again for the invitation. And I have the privilege to remind you with the coming Onco Azhar in Egypt. It will be next year in September, inshallah. Just book your agenda. Thank you very much.
Thank you very much, Dr. Weil. Let's listen to Dr. Jawahar Ansari, how he's going to have a counter-argument. Initially, the debate, before the debate, we had the voting in favor of EV panel. Let's see what Jawahar can do to convince her. Thank you.
Assalamu alaikum. Good afternoon, everyone. I'd like to thank the organizing committee, Dr. Humaid and Dr. Said Al-Mazi for kindly inviting me here today. I clearly have an uphill task. As you can see, 75 to 80% of the audience is with my opponent. So I'm going to have a challenging task to give the other side of the argument. You've clearly heard just one side of the argument now, and I'm here to present the other side. So I'm going to support platinum immunotherapy, either combination or as maintenance. Here are my disclosures. So this is where we were to begin with. If you can recall the days when we had limited treatment options, only platinum-based chemotherapy. With gemcitabine cisplatin, you were looking at median survival of around 14 months. For platinum or cisplatin ineligible patients, you're looking at a median survival of around 9 months with carboplatin-based chemotherapy. So clearly this was an unmet need, and a lot was desired at this stage. And this is where we are now. You've just heard the argument a few minutes ago with the EV302 trial, which looked at pembrolizumab plus enfortumab vedotin versus chemotherapy. Clearly remarkable data, clearly practice changing. But it's a platinum-free regimen, but not chemotherapy-free. All said and done, enfortumab vedotin is still a chemotherapy. Although labeled as an antibody-drug conjugate, it behaves very much like a chemotherapy in terms of side effects and in terms of how we are delivering it. And we're now talking about indefinite chemotherapy. So when did we shift to indefinite chemotherapy? I'm still not clear. The other trials that we are going to discuss now is the Javelin 100 trial, which looks at maintenance immunotherapy with avelumab, and also the Checkmate 901 trial, which looks at chemo-immunotherapy combination, as is being done in several other cancer sites. To begin with, keynote 839 or EV302 already presented. I won't discuss too much about it. The trial looked at EV plus pembro versus chemotherapy. But point to note is the pembrolizumab, as per the previous trials, is for 2 years, but enfortumab vedotin is given indefinitely. The main two endpoints is the dual primary endpoint of PFS and overall survival, and you can see remarkable data. Risk of death was reduced by 53%, median survival almost doubled, 31.5 months. However, here are my thoughts. Is pembro plus EV a good treatment option for first-line metastatic urothelial cancer? I agree. Not close to the argument. Is pembro plus EV the preferred treatment option for all metastatic urothelial cancer? I don't agree. Are there better treatment options in certain clinical scenarios? Of course there are. Is quality of life, patient convenience, long-term toxicity, and cost, are these factors important? Of course they're important. And when did we move from a chemo-free regimen to free chemotherapy regimen or indefinite chemotherapy regimen for life? That's something we need to debate. And if we use two potent agents in the first-line setting, what are we going to do in the second-line setting? These are things that we need to discuss. So switch maintenance with avelumab was one of the key standards really which revolutionized treatment for bladder cancer early on. So this trial looked at patients with metastatic urothelial cancer that had responded to first-line platinum-based chemotherapy. Could be either GemCis or GemCarbo. So these patients, if they had either complete response, partial response, or stable disease after 4 to 6 cycles of chemotherapy, were randomized to either best supportive care or maintenance treatment with avelumab given every 2 weeks indefinitely with a key primary endpoint of overall survival. This set the standards, improved median survival from 15 months to 23.8 months. Numerically, this doesn't look a lot, but you can set the standards and calculate the survival as per the other trials. So if you cannot compare apples and pears really. So for the EV Pembro trial, you're looking at median survival from the beginning of the trial. So if you look at the median survival for platinum-eligible patients getting cisplatin-based chemotherapy, from the beginning of first-line chemotherapy, the median survival is very similar, around 31 months. But you might say this is manipulating the data. If you look at real-world data, we have got the large French Avenant study, which showed that median survival in routine clinical practice is around 21 months, which replicates the clinical trial data. And this is what we like to see, is large real-world data sets which are replicating the clinical trial evidence. Now, looking at chemotherapy, immunotherapy combinations, we have at least 3 trials. The first trial, Danube trial, looked at immunotherapy alone with either durvalumab or durvalumab versus chemotherapy. The second one, Keynote 361, looked at pembro plus chemotherapy, whereas IMvigor 130 looked at atezo plus chemotherapy. Unfortunately, all the 3 trials were negative. But if you look at them with a little bit magnifying glass, you can see that there is a trend towards improvement in overall survival, although none of it was statistically significant. So there was a numerical improvement, but this did not reach statistical significance. You put all this together, look at it in a systematic review, and do meta-analysis. There's a clear benefit in terms of improvement in overall survival, progression-free survival, and objective response rate. So clearly thought-provoking, but we needed some confirmatory trial, such as the Checkmate 901. So this trial looked at looking at chemotherapy plus immunotherapy upfront, as is done in lung cancer and many other trial settings. There was no reason why this would not work in bladder cancer. We know that immunotherapy has a clear role in bladder cancer. We've discussed already neoadjuvant setting and adjuvant setting, and we know that it works in second-line setting. We know it works in maintenance setting. There's no reason it should not work in first-line setting in combination with chemotherapy. So this trial looked at cisplatin-eligible patients and randomized them to either standard of care chemotherapy for 6 cycles or chemotherapy plus immunotherapy with nivolumab for 6 cycles, followed by maintenance nivolumab for up to 2 years, with primary endpoints as listed here. Again, showed a dramatic improvement in overall survival. You can see that the control arm did overperform in this trial, as opposed to the Pembro EV trial, where the control arm median survival was 16 months. It was 18.9 months here, thereby narrowing the margin of benefit for overall survival. So the median survival with Nivo plus Gemcis was 21.7 months. If you look at select patients with lymph node-only disease, of which there was nearly 50% of patients in the complete response group, you see that 81.5% of patients with lymph node-only disease had a response with Nivo plus Gemcis. 63% complete response rate, unheard of in metastatic bladder cancer. Median overall survival of 46.3 months, unheard of in metastatic bladder cancer. So patients with metastatic bladder cancer or metastatic urothelial cancer with lymph node-only disease, we know the prognosis is good, but we have shown that with combination of nivolumab and chemotherapy, remarkable results can be achieved in this setting as well. So this is where we are now. So we've got at the bottom EV302, Pembro plus EV, showing a dramatic improvement in overall survival, median survival 31.5 months. In the far right, we have Nivo plus Gemcis with a median survival of almost 21.7 months. And on the left, you have maintenance avelumab, median survival of 23.8 months. Make it a slightly fairer comparison. You look at median survival from the beginning of first-line chemotherapy for avelumab, and here the median survival again is 31 months, and very similar to the Pembro plus EV, but clearly a much less toxic regimen where chemotherapy followed by avelumab. In the maintenance setting, avelumab can be continued for several years. Now let's compare for several factors really. If you look at the infusion time and protocol, avelumab given intravenously every 2 weeks. Not very convenient, but minimal toxicity, so the patients can be continued on this for a prolonged period of time. The label says indefinitely, NICE guideline says 5 years. Look at nivolumab, it's a 60-minute infusion, can be given 2 weekly or 4 weekly. It's quite convenient. Initially it's 3 weekly along with chemotherapy, and you stop this at 2 years. Now coming to Pembro plus EV, it's a 90-minute infusion. You have 2 drugs, and you know that pembrolizumab can be stopped at 2 years, but EV is indefinite, given on day 1 and day 8. Not an easy drug to give, and patients are almost here 2 out of 3 weeks for life. And that's not something the patients are willing to accept when you discuss this with the patients. Toxicities already mentioned earlier. Briefly to point out, nearly half these patients got peripheral neuropathy. Nearly a third of patients got skin rash. This is one of my patient images really of a grade 3 skin rash where I had to stop, at least he's currently on a break receiving steroids. So it's not without toxicity, especially the longer you go on the treatment, you know that you're likely to encounter significant toxicities. And if we were to use Pembro plus EV in the first line setting, what are we going to do in the second line setting? In the absence of FGFR alterations or HER2 expression with limited treatment options. As presented earlier, we've seen the results of EV301 in the second line setting, which have shown remarkable results, almost 40% response rate, improvement in median survival. So EV is a very potent drug to be used, and I've used it for a few months now, and it's one of the preferred agents in the second line setting after failure of platinum-based chemotherapy or immunotherapy. But if you're using it in the first line setting, we don't have this option in further line setting. And that was seen in the evidence study as well, which is the real world study I mentioned earlier. 4 patients in the Javelin Bladder 100 type trial, when you're using avelumab in the maintenance setting, when they had disease progression, the most common drug of choice was antibody drug conjugates, of which EV was one of the key treatment options. Median survival for those patients that received an ADC in this real-world study was 40 months. Again, a very remarkable finding. Now, coming to the challenging topic of health economics, some of you might not want to listen to this data. So, if you were to give, avelumab is given for life, but assuming you're giving this for 2 years, I want to make the comparison fair. The median duration on the trial was only 25 weeks. So assuming you're giving it for 2 years, you're looking at just under 1 million dirhams. That's just the cost of the drugs. If you're giving nivolumab, just say it's 1.2 times, around 1.2 million. If you're looking at the 2-year treatment, the median duration on the trial was 7 months, which is 28 weeks. Now coming to Pembro plus EV, after all this, we say that 2 years of Pembro plus EV is almost 2.5 million dirhams. Still not NICE approved. The median duration on the trial was 36 weeks. So this is something comparative, and we need to think about in a setting where health economics play a very important role. These new cancer drugs have been quite transformative with the results in the median survival, but with the improvement in patient outcomes, we need to see whether the cost is quite prohibitive for their usage in clinical practice, and in several countries where this can be the GDP of several countries if you treat 10, 20 patients. Just to present a small case study, 62-year-old male TCC bladder, stage 4, lymph node only metastasis, multiple paraaortic lymph nodes. I've just shown some of the pelvic and paraaortic lymph nodes at baseline. A fit gentleman had a good response with platinum-based chemotherapy. We gave him GemCis. He had a partial response, went on to maintenance avelumab November 2021. I did optimize that with addition of radiotherapy, which is something I do quite as standard really for patients with low volume disease. We targeted those areas of metastatic disease, which was not done on the Javelin 100 trial. Patient had a complete response and has been on avelumab for almost 3 years. I did use concurrent immunoradiotherapy as well. I didn't have any side effects for this patient. Now, NCCN guidelines already presented. It's almost like a shopping list. Everything is category 1. It says preferred and other. So I'm still having trouble reading the NCCN guidelines, but essentially all the options that we have discussed are available there. So we have 3 category 1 NCCN recommendation. Pembro plus EV is indicated for a broad population of metastatic urothelial cancer patients, irrespective of platinum eligibility. Nivo plus GemCis, followed by Nivo for cisplatin eligible patients. Switch maintenance avelumab after 4 to 6 cycles of platinum-based chemotherapy. These are the 3 options. There's no clinically relevant biomarkers yet to decide what is your preferred option. There is potential for HRR pathway deficiency to look at platinum sensitivity or ERK-C2 mutations in the future, but they're still being explored in the neoadjuvant setting, and we still don't know their role in the metastatic setting. So several considerations for EV plus Pembro. The cost can be prohibitive unless they get offered free as an Egypt, it can be an option. Indefinite chemotherapy, indefinite EV can be a challenge really for some patients. Inconvenient schedule coming 2 out of 3 weeks can be a problem. Significant toxicity as has been encountered in the clinical trial and in clinical practice. And also, if you were to use this potent combination in the first-line setting, there is no guideline what to use in the second-line setting. A third of patients on the clinical trial got platinum-based chemotherapy again, voila, in the second-line setting. So why not use it in the first-line setting and then use single-agent EV? You save your cost as well, and you have lesser problems. There's no future de-escalation in the line, really. If you were to stop Pembro and then continue EV, it doesn't make much sense. Whereas if you stop EV and continue Pembro is a much more tolerable agent in the longer term. So in clinic, it's useful to consider several parameters prior to deciding exactly what treatment option to use for these patients. Clinical parameters such as performance status, comorbidities, and for the health center, you need to look at your reimbursement, funding policies, accessibility to these drugs, patient consideration as well, whether you want to visit twice in 3 weeks, the duration of the treatment, whether you want indefinite chemotherapy, intensity of treatment, the quality of life during these treatment options, and also the adverse effects before treatment initiation. I hope we've given a brief overview of the options that are available, and I hope you'll choose wisely for the next question. And also in the era, there's a definite role in day-to-day practice for the other 2 regimens that we have mentioned. Thank you.
Thank you very much, Dr. Jawahir and Dr. Weil, for excellent presentation. I think we had a very balanced debate. Is it exciting times that we're debating what to give in the first-line setting, so we are spoiled for choices? I think that's at least a good take-home message, that we have so good options available now. But obviously, does one side fit all? So we can maybe start with the voting again to see did we manage to convince more people on one or the other side, so if we can have that. And following this, we'll have some questions from the audience, and we'll take some personal opinions of the speakers as well, what they will be doing in the clinic on Monday. Okay. Looks like, you know. Has everyone voted then? Okay, maybe we can stop it here. If we can keep it on the screen, please, for now. So what we have here, so 56% EV Pembro versus platinum immunotherapy, 47%. So I think it's almost very close to each other. So it looks like we still have a debate. So still there are a number of patients who will be eligible for each regimen. So one size does not fit all. So if there are any burning questions from the audience before I ask the panel a question. Okay. I think while we are finding the mic for Dr. Hassan, maybe I can ask from the panel, do you look at the platinum as an eligibility criteria for your regimens currently, or does it not matter now? So how do you select your patients when we look at platinum eligibility currently for any of those regimens that are available now?
So if I'm considering Javelin 100 type regimen, of course we would look at platinum eligibility and use the regimen appropriately. For Checkmate 901, you need them to be cisplatin eligible, so it's a prerequisite. If I'm using Pembro plus EV, I'm not looking at eligibility criteria, but there are several other factors we need to look at prior to considering that.
Yes, I think still platinum eligibility is very important, because if you look at the EV 302 trials, they selected only patient who has GFR more than 30%. And this is typically what we prescribe for carboplatin. So this is, yes, still the platinum eligibility is valid for all the options.
Thank you. And obviously in platinum eligibility, we're also looking at other factors apart from the GFR as well. Okay, Dr. Hassan Ghazal. Yes, please.
Okay, so this was really nice presentation from both. Obviously, there are pluses and minuses of each choice. So perhaps individualized case by case is valid. However, I think in the chemoimmunotherapy, the biggest defect in the avelumab conclusion is that you are choosing your patient after your chemotherapy. So about a third of patients are not going to receive the avelumab, and their outcome is more inferior. And if you're taking the good group, that's the one that have the 30+ months survival, as you mentioned. So just to put things in perspective. The other thing with the nivolumab, obviously it's only cisplatin. So this is unique to cisplatin eligible patients, because perhaps that was many experts saying that's probably the reason why it was the only one showing significance when you start up front. I say that because you want to start as much as possible the active agents and not delay them till later. So, however, the EV Pembro on the other side is more expensive, is more long-term toxicity, certainly can accumulate on you. So if I have a fit patients, it's going to be hard to decide. But what do you think of the argument that at least with EV Pembro, you don't delay any introduction of the immunotherapy? And again, if it's a cisplatin eligible patient, Nivo plus chemo gave you the 21 months, which is very close to what we are seeing with the control arm at 18 months. So again, perhaps they overperformed, that limited the variance. The other contrast on the EV Pembro, none of these patients received on the control arm received EV. That's, I think, a big defect in when you're controlling who really got EV afterwards, because that's the most active agent in second line. So if you started with chemo, you are getting immunotherapy second line. It's okay, but it is not as effective as the EV. And that will impact on the survival difference that you saw. So any comments on that?
So I didn't get the question.
So it's all questions and answers.
Too many questions.
I will answer your comment.
The question for you about delay in the introduction of immunotherapy in the javelin.
If you were to consider as immunotherapy as the most potent of the combination, I would hate to break the ice, because in Checkmate 901 as well, the curves don't separate in the first 6 months. The actual curves start separating after the first 6-month period. So majority of the benefit, even in Checkmate 901, appears to be with the maintenance nivolumab. Similarly, obviously, as you already mentioned, for Javelin 100, which was a maintenance study, analysis from early on, you rightly said we are picking the winners, but you've got obviously something to compare with the other trials where you've been counting the median survival from the beginning of systemic therapy. So it's a different way to look at the comparison, not to fudge the data too much, but essentially like-for-like comparison really. But maintenance therapy is really useful, we know that. And if you're worried of any early progressors, yes, immunotherapy early on might be something really useful. But we've seen just for single-agent immunotherapy, response rates are no more than 50 to 20%. So I think EV is a very potent agent, first line, second line, or third line period really. We know that it's a very good drug to use. The question is where you would place this with the potential toxicities, cost involved, how long you want to treat it. So these are the challenges.
I think your question is, we will lose the second-line effective treatment if we use EV early in the treatment. Actually, along the different sites of diseases, we are doing this all the time. We choose to treat the patient with the most effective treatment upfront line, because likely we have the best chance and the best response from the treatment as early as we use it. This is a lesson we have learned from the different sites. All the time we face this problem. We have new drug coming to upfront treatment, and then we lose it in the second line. So if we apply this for all diseases, yes, we likely all the time use the most effective treatment in the first line. So this is maybe the answer for your question.
Thank you. Maybe I can ask the last question if there is no question from the audience. There looks to be Dr. Shahryar has a question, please. Dr. Shahryar from Sheikh Shahput Hospital.
one comment actually, I think, which goes in the favor of checkmate 901, and maybe you can, Jawahir, could correct me or explain, that in the node-only positive population, there was actually significant benefit with checkmate 901 regimen. So do you think that subgroup is particularly favorable for this approach, even comparing to EV-Pembro?
So it was a post hoc analysis, but clearly I put one of the slides really more than 80%, so 81% response rate, 63% complete response rate in the node positive only cohort. We know that node positive is a good prognostic factor, but the level of response seen, the median survival of 40.3 months was unprecedented really. So I think for a subgroup of node positive patients only, I think this could be one of the preferred options, I agree.
Thank you, Jawahir. If for the audience, can you give us a patient profile for each of those regimens that you would use in the clinic, just to help the audience when they're selecting these regimens in the clinic on Monday?
For the EV-Pembro, we have to have patient eligible for both AV and immunotherapy. Eligibility for AV include patient who doesn't have like extensive skin disease before starting treatment. The patient should have EGFR more than 30. Patient should have no autoimmune active disease for the immunotherapy choice, and no organ transplantation, of course, and controlled diabetes. This is a very important point. We have to have patients, diabetes is controlled before starting this AV, because we have some resistance to treatment if we start the AV before diabetic patients. And diabetic patients also may suffer from side effects of the immunotherapy that needs high dose steroids that will make the problem worse even.
Thank you. Okay, Dr. Jawahir.
Although I was arguing for the other side, I would still say that EV plus Pembro is one of the preferred options as per the NCCN guidelines, clearly because of the unprecedented survival benefit. It was a winner in the ASCO plenary session as well, purely for the depth of the data and the improvement in survival that was seen in that session. However, the caveat of cost and long-term toxicities, all this needs to be kept into place. But as majority of the patients in first-line setting can be considered for EV-Pembro. Selected patients, I think, should be considered for chemo followed by immunotherapy, maintenance with avelumab. That is the patients with low-volume disease. Lymph node-only disease is a very good group of disease really to consider for Nivo plus chemotherapy.
I just have a comment on the cost and the time of treatment with EV. Actually, if you look at the trial, you will find the median number of cycles received for the patient is 8 cycles only, and 12 cycles, I think, for the patient who received Pembro. This is both of them?
We're running out of time,
cycles.
I think.
Yeah, so, yeah. 12 cycles. And in practice, I think most of the practitioners stop at like 8 cycles because of the sensory effect, the peripheral neuropathy coming from the AV. So at this point, we stop the cost at this point, and we continue with the Pembro as a single agent as a patient-tolerated treatment. So this is like not the cost is not going to the end.
So very practical. Thank you very much. With this, we'll conclude the session. I thank you, my speakers, for an excellent debate. Thank you very much.
Thank you. Thank you. So, Dr. Sayed, I know we're running late. People are hungry. They want to have lunch, pray. Okay, so we'll move now to the next session with Dr. Mohammed Farouk. And please, after this lecture, we're going to have a group photo, so please stay with us. Dr. Mohammed Farouk, he's a consultant oncologist at Dubai Hospital, Dubai Health. He trained in UK, and he's also the fellow of the Royal College of Physicians in Glasgow and Edinburgh. Welcome, Dr. Farouk.
Thank you, Dr. Hamid, for the introduction. We are approaching the last and very important session of the morning before we break for the lunch. It's my pleasure to introduce Professor Stephen Freeland. He's a professor of surgery at Cedars-Sinai Medical Center in USA. He specializes in the management of prostate cancer. He has published over 700 articles in peer-reviewed journals and sits on various journal editorial boards. It is my pleasure to invite Professor Stephen Freeland. He will talk to us about first-line management of metastatic CRPC and what is next after ADT plus ARPI, and some insights into EMBARK trial. The floor is yours.
Thank you very much, and thank you very much to the organizers for allowing me to speak today. I originally submitted just an abstract to present a poster here and got the honor to be able to give a talk here. So I do want to kind of summarize what we had planned to talk about in the poster, but then talk about where do we go forward from there. So it's kind of two different talks. We'll finish on time, but the first one is some novel insights from EMBARK, and I'll talk briefly about what is EMBARK, and then we'll talk about when patients progress and now go on to castration-resistant prostate cancer, what are the options for those patients. So this is the prostate cancer treatment options as outlined, and we kind of think about prostate cancer as either it's non-metastatic or it's metastatic. It's castration-resistant, means we've given hormonal therapy and the patient is now progressing, or it's castrate-sensitive. And most patients present in the top left box there with what we call non-metastatic castration-sensitive prostate cancer. And if we treat, as we often do, for those patients where the initial treatment is not curative, they develop what's called a biochemical recurrence. And this is where EMBARK fits. For those patients, conventional imaging negative, not necessarily non-metastatic, but conventional imaging negative, CT and bone scan, short PSA doubling time, so the PSA is going up rapidly, that we have a new option. It's approved by the FDA, it's in the NCCN guidelines, enzalutamide either with or without androgen deprivation therapy. So the first therapy we have is first line for prostate cancer that actually does not involve ADT. Very novel. So we're going to give some insights into that space and then talk about, as we get to the bottom right, that's where the deaths occur, that metastatic castration resistant, what are our options in that space? So again, this was the abstract that I had submitted, and it's really looking at a new analysis from EMBARK and specifically those who got treatment suspension. I am a consultant for many different companies, including Astellas and Pfizer, the makers of enzalutamide. So we know from EMBARK that enzalutamide demonstrated metastasis-free survival, metastasis or death benefits relative to ADT alone in this high-risk biochemical recurrence setting. There were no new safety signals, and quality of life was preserved. So that's been previously reported in the New England Journal, the primary paper, the quality of life, the New England Journal of Medicine evidence. But one of the really interesting things about EMBARK is, unlike we just heard the talk last about EV being given for life versus what do we want to give it for a year or two, was here with EMBARK, the patients got 9 months of treatment, and if they got a good response, they were able to stop treatment. So the question is, what happened to those patients who stopped the treatment, and how does that work? And so that's what we wanted to focus in on, patients who got the enzalutamide combination, enzalutamide plus ADT, versus ADT alone in those who either did or did not get that treatment suspension. And this was the study design of EMBARK as a refresher. So this was a phase 3 global randomized trial of patients, again, with high-risk biochemical recurrence. PSA doubling times less than 9 months, PSA greater than 1 post-surgery, or greater than nadir plus 2 post-radiation. Randomized to enzalutamide combination, ADT alone, or enzalutamide alone, which is a really interesting option for patients. I'm not going to have time today to focus on that. But again, if they got a good response, PSA less than 0.2, treatment was suspended. If they didn't get a good response, treatment was continued. And the question is, how did the outcomes vary between combination and ADT as a function of whether treatment was suspended or not? And so if we look here, what we see is on those assigned to enzalutamide combination on the left, we had about 7% of patients discontinue early due to side effects. And of those that remained, the vast majority had PSAs less than 0.2. So in total, less than 3% of patients who started on enzalutamide combination did not get a good biochemical response. Less than 3%. That's how effective these agents are. Whereas if you look at the ADT alone, you had discontinuation rates very similar to what we saw in the enzalutamide combination, 7% within the 37 weeks, but 67% had that good biochemical response, but 25%, 1 out of every 4 patients, did not nadir to less than 0.2 on ADT, just proving yet again ADT for these patients is not good enough. So, very complicated slide, but what we see by and large is the patients that did nadir, it's highlighted in the boxes there, it's more on the right, tended to have lower PSAs, makes sense, they had a little bit less aggressive disease, and they were more likely to be the surgical patients. So again, lower PSAs, surgery we tend to select for less aggressive disease, the worst of the worst tends to get radiation. So again, kind of makes sense, but some of the other factors that we looked at really didn't pan out, including surprisingly doubling time, didn't really predict who would get a treatment suspension or not. And so we looked at those who got the treatment suspension and then remained on the treatment suspension. So the proportion of patients who had an undetectable PSA still 2 years later. So 2 years after treatment suspension, still doing great. PSA is undetectable. It's almost twice as many in combination, 17% versus 10% in ADT alone. And then just the proportion of patients who remained still on treatment suspension. So not necessarily undetectable PSA, but still on treatment suspension. 1/3 of patients on combination versus 1/4 of patients on ADT, both of those being statistically significant. And importantly, if we look at those patients who got treatment suspension, so they all had a really good response to that initial treatment, went off treatment, when the time came, they went back on treatment, and even in that group that did well, we still see the Enza combination group did significantly better. So with a hazard ratio of 0.47 for metastasis-free survival. So saying just because you gave ADT and the PSA came down nicely is still not good enough. We can do better. Our patients deserve doing better. So, and interestingly, when we look at those who did not get treatment suspension, though we didn't see a statistically significant improvement for combination, keep in mind only 9 patients did not get treatment suspension on combination. So it's really not a robust analysis when your experimental group has 9 patients, because it's just so effective at lowering that PSA. When we looked at safety, by and large the safety was relatively similar, that those who got the treatment suspension had very similar side effects relative to those who did not get treatment suspension. And in general, we see slightly more side effects with the combination relative to the ADT alone. So in summary, kind of from the abstract side of things, in those with treatment suspension, Enza combination did better than ADT alone in delaying metastasis or death, a surrogate endpoint for overall survival. And in those without treatment suspension, it was only 9 patients in the Enza combination. Not anything we could statistically, with any validity, analyze, but nonetheless, results were similar. So, and again, in those who got treatment suspension, Enza combination, more likely to have an undetectable PSA, and more likely to be off treatment 2 years later. And in summary, I think this provides even more robust analyses to support that enzalutamide, with or without ADT, we didn't talk about the without ADT here, but with or without ADT really is the new standard of care for these high-risk biochemical recurrent patients, and I think tells us when the patient is ready for systemic therapy in this space, this is how we should be doing it. It should be with enzalutamide. Now, when exactly to introduce systemic therapy, lots of options, that still is a hotly debated topic. So kind of moving on from this, so we put a patient with high-risk biochemical recurrence. Think about the scenario. We put them on enzalutamide plus ADT, and it works great, but eventually we're down the road years, and the patient is now progressing. Now what should we do for that patient? They've already received ADT plus an ARPI, so where do we go? And again, coming back to our treatment guidelines, if we look, there's a lot of places we're using ARPIs now before MCRPC. So what do we do for that patient who's gotten to MCRPC and has already received an ARPI? And this is not related to the Stellus or Pfizer that supporting me being here. This is just this next 10 minutes, just my random thoughts about how we should think about prostate cancer. So again, ADT plus ARPI is standard in many cases. And so what to do when that patient gets to MCRPC? Well, if we look at NCCN guidelines, they break it down whether the patient has received docetaxel, received an ARPI, received both or neither. So let's blow up this one in terms of progression on prior novel hormonal therapy. So our preferred options are docetaxel, chemotherapy, and so patients don't love chemotherapy. And the original data, and I'll show you, that defined chemotherapy for prostate cancer, actually ARPIs didn't even exist in that era. So do ARPIs even work, or just chemo even work after ARPI? I think the answer is yes, and I'll show you why, but it's still, I've heard this argument, well, we don't know if chemo works. Certainly if they have a BRCA mutation, or more broadly homologous recombination, we got PARP inhibitors, but that leaves a lot of space. 75% of patients are not going to have homologous recombination deficiency. They don't want chemo. What should we do? So, you know, one option is ARPI switch. It's not in the guidelines, but we know real-world data says it happens all the time. Is that a good idea? I would argue no. In general, if we look at trial after trial after trial, and I've listed 5 trials that I could think of, and there's probably some more that I missed, where the control arm was going from ARPI to ARPI, and we look at the time to progression, 3 months, 4 months, and these are some of selected patients to be more aggressive. PSMA4 selected to perhaps be a little bit less aggressive because they weren't yet ready for chemo. 5 months. The response is not very good. Maybe ENZA is a little more active post-ABI than the other way around, but it's not a great response. We really got to be thinking outside the AR box, so to speak. So certainly we should be doing molecular testing. Ideally, it should have been done before they got to MCRPC, but it's not done when you need to do it. Because about a quarter of patients will have homologous recombination repair deficiencies, in which case the right answer is a PARP inhibitor. If they have a high TMB, MSI high, other mutations, which account for less mismatch repair, less than 10% of our patients, we got to think immunotherapy, pembrolizumab. However, the vast majority are going to be biomarker negative. And they may have other biomarkers, P10 loss, P53, RB1. We don't know how to treat those. We just know it's a bad sign, but we don't know how to treat them. So the standard would be chemotherapy, and I'll talk about it in a second. If they have bone only, would be radium-223. In the United States, Provenge, not approved here, not available, but it's not even used widely in the United States. In the near future, Pluvicto. So the question is, does chemotherapy work post-ARPI? So interestingly, because I've heard this argument from some people, well, we don't even know chemo works after an ARPI, why should I do it? It's in the guidelines, but the clinical trial, TAX327, was before we even had ARPIs. It was 2004. And so if we look in Triton3, which was all BRCA positive patients, and they were randomized to rucaparib or dealer's choice. They'd had an ARPI. And if we look at those who got docetaxel, and you could think that maybe those were the selected to be the worst of the worst, perhaps they agreed to chemotherapy, and yet the rPFS, a radiographic progression-free survival, was better than switching to an ARPI, 8 months versus 4.5 months, okay? If we look at the CARD trial, now there they had all had docetaxel, so now we're asking cabazitaxel, not docetaxel, but we certainly know in the first-line setting, docetaxel and cabazitaxel are equivalent, and this is in the second-line setting that we saw that going to chemo, cabazitaxel, was significantly better than an ARPI switch. So I think we have some data, it's not perfect data, but I think we have some data to argue chemotherapy does work post-ARPI, and certainly anecdotally we've seen patients, their pain gets better, their PSAs go down, so I think we can argue likely that it works. And this was the card trial here, and again, these patients had all had an ARPI and chemo, so they had one ARPI, one chemo. The question is, do you go to a second chemo or a second ARPI? Seems a pretty simple question. And these were selected to have progressed relatively rapidly on their ARPI, less than 12 months. And what we see is if we look at imaging-based progression-free survival, we see significant benefits to second chemo over second ARPI, hazard ratio of 0.5, and we see an overall survival benefit with a hazard ratio of 0.64. And this was such a profound statement, it's actually published in the New England Journal. Really says practice changing, that we probably should not be routinely doing this ARPI switch. We should probably be pulling chemo off more. But again, patients don't like it, but I think that's where talking to the patients and really explaining the data. And importantly, what you actually see is, interestingly, I think it's better shown on the right, that the patients who got cabazitaxel actually had a better quality of life. So we think chemo has all this effects and patients like, oh, I'm going to feel horrible, I don't want this. Your quality of life is actually better. Because you get into really late stage cancer patients, the greatest threat to their quality of life is not the therapies we give, it's the cancer itself. So if you have an effective therapy that controls the cancer, we can actually improve their quality of life, even though we're giving chemotherapy. And I think that's the message, is we need to be aggressive with these patients, and the mantra I use is aggressive disease needs aggressive therapy. And likewise, non-aggressive disease needs non-aggressive therapy. In MCRPC, I would argue they're almost all aggressive. This applies even to earlier stage, high-risk bowel colon recurrence, even at diagnosis. So how about Pluvicto? PSMA-targeted therapy. We have the VISION trial, significant benefits available post-chemo, but does it benefit patients prior to chemo? And this is the PSMA-4 trial. And I don't know the status necessarily here. I'm sure you guys can enlighten me, but certainly not approved yet at home. And we'll see why there's been some delays in this. So this is PSMA-4, and these are patients who had progressed on an ARPI, metastatic castration resistant, had not received chemotherapy, and they're randomized to lutetium, or again, a switch of ARPI. And something I think very ethical, but makes interpretation of the data very challenging, is that patients who progressed on the ARPI were offered a switch to the lutetium arm before they got chemotherapy. So at the end of the day, about 80% of patients crossed over. So it's really a test of early lutetium versus late lutetium, and it makes it kind of challenging to see. But if we look at radiographic progression-free survival, you see a very clear benefit. Hazard ratio of 0.49, cutting the risk of progression in half. Really significant benefits. And if we look at worsening quality of life, preventing quality of life from getting worse, again, these patients late stage progressing cancers, we see significant benefits. The challenge is when we look at overall survival, you see nothing. The first two interim analyses actually had a hazard ratio above 1. Now, as it's published, hazard ratio of 0.98. So again, I think we can debate when to give lutetium. I think it's a very fair and honest debate. I do think it should be in the armamentarium and we should be using it. I'm not sure we necessarily know when to use it. But what happens in the real world? So this is a study that we had done with Medicare patients in the United States, metastatic castration resistant, and interestingly, a quarter of patients down there on the bottom got nothing. No treatment for their MCRPC. 78% did, but of those, barely half went on to receive a second-line therapy. And then of those, only half went on to see a third-line therapy. So we're losing half the patients at each line, meaning the majority of patients are going to get one line of therapy, maybe two. And if we're doing ARPI and ARPI switch, it means the vast majority of our patients out there are getting nothing beyond AR targeting. And AR targeting is very effective, but there are other mechanisms of actions that our patients should be seeing as well. So to summarize, for high-risk biochemical recurrent patients, enzalutamide either with or without ADT, again, we didn't talk about the without, but the data are there, it delays metastasis-free survival, it met many of its secondary outcomes, no new safety signals, preserves quality of life, and I strongly believe is the new standard of care. But we got to think about what happens afterwards. And when patients reach that mCRPC, we should be sequencing them, if not done before, treat appropriately, and really want to maximize our lines of therapy. And to me, that often starts with starting that ARPI early. So when they get to mCRPC, they're still healthy enough, they still got long enough life left that we can give them the chemo, the Pluvicto, the other therapies that are coming along, leading to better quality of life and better quantity of life as well. On that note, I'd like to thank you all for your attention, again, inviting me to be here.
Thank you, Prof. Freeland, for an excellent overview of treatment options and insight into EMBARK trial. I'm sure we'll have lots of questions. I can see a number of hands raised.
Okay.
Dr. Hamad, he wants to ask a question, or whoever wants to go first.
I can. So just one clarification on the EMBARK trial. What happened to patients who had radiation plus ADT? Were they included as well?
The radiation plus ADT? You mean?
No, I mean before they reached the biochemical recurrence, if they had ADT with radiation, you know.
Got it. Okay. Yeah, so patients were allowed a certain amount of hormonal therapy.
Right.
With radiation, it had to be less than 36 months of duration, had to be, if I remember correctly, greater than 9 months prior to the start of trial, and testosterone had to be normal at the time, above 150 at the time of entry. So hormonal therapy with the radiation was allowed, and even a little bit of hormonal therapy for biochemical recurrence was allowed, again, assuming there was a break before entry, testosterone was normal.
And then what do you think of the strategy of reusing the ARPs in combination? You know, obviously if they have BRCA or BRCA-ness HRR, we have 2 trials that use combination. The problem is they all were exposed to ARP, whether it's enzalutamide or abiraterone, but we have 2 trials combining them. And recently at ESMO, we saw even the radium combined with enza as well.
Yeah, so for the 2 trials that you're referring to, being Propel, Talipro 2, and there was Magnitude as well, the only one that allowed some prior ARPI was Talipro 2. And there was about 5% of patients, really small numbers, that had prior ARPI. And there was some analysis done looking in that very small subset. It looks like the benefits, and this was patients who had ABI, now coming out of the trial, they got enza plus talazoparib. And it looks like the benefits of the combination, enza plus talazoparib, were maintained in those who had prior ABI. And again, as I said, enza has some activity post-ABI, relatively little the other way around. So I think if a patient is failing ABI, coming in and has one of those mutations, homologous recombination, I think switching to the combination enza plus talazoparib makes a lot of sense. If they don't have the mutations, in Europe it's approved, enza plus talazoparib for all comers. In the United States it's limited to HRR. The benefits are certainly less than wild type, but I think that's the area where we need to think about. And then you have the piece 3, enza plus radium, but again, you weren't allowed to have had prior ARPI. So I think we're evolving, we're still learning. It's a great question though.
Thank you very much. Can I have a question with regards to the first-line CRPC for biomarker negative population, the difficult population? So you've shown us the data about lutetium bringing early. There was no survival benefit, but we in the last 5 years we had always had comments from nuclear medicine physicians that you send the patient so late after chemotherapy that they are not able to deliver lutetium. Hence, we try and bring it early. And with regards to chemotherapy, although there was no direct evidence, but you've shown us some data that may be an option. So how are you selecting your patient? Do you still think we should use chemotherapy for majority of patients in this setting, followed by lutetium, or other way around?
So let's imagine a world where PSMA4 is approved and you have that option. Because at least for us at home, right now we don't have that option. So it would be chemo, and then lutetium would have to be after chemo. So let's assume PSMA4 is approved and you have that option. I think there's a lot of patient interest in lutetium because it's not chemo. Patients hear the word chemo and they get scared, that they don't want it. We certainly don't have any lutetium head-to-head data versus chemo. I think we also need to remember lutetium is a biomarker-directed treatment. It's not an option for every patient. 85% is pretty good, are going to be eligible, but there's a subset that aren't going to be eligible for it. So I think it becomes dealer's choice at that point. I think when you start to think visceral metastases, AR negative, most visceral metastases, particularly liver, which is the really aggressive lethal, tend to be PSMA negative or PSMA very low expressing. There's some really nice data with lutetium that the higher PSMA expression seems to have a better response. So if you have liver mets, visceral mets, I would probably push more towards chemo. If you don't and it's bone predominant, then I think lutetium. You'd also have to think radium, that's similar, but I think lutetium's the new shiny object and things. So I think we'd probably do more lutetium, but it's not necessarily everyone's going to go one way or another. We've got to think about the patient and things.
Okay, that's fine. Just one more question, if I may ask, regarding the EMBARK trial. What was the rationale of using treatment suspension and single suspension and follow-on from clinical practice point of view, patients who have suspension and then go back on treatment after they have a PSA progression, would you consider further suspensions if they respond really well? And what would be the patient group you would do?
Yeah, so great question. So what was the rationale for treatment suspension? So if you look, there was a randomized trial out of Canada. Juanita Crook was the first author. Laurie Klotz was senior author, published in New England Journal in 2012, compared in biochemical recurrent patients, intermittent ADT versus continuous, and showed no overall survival difference. So that's often driven guidelines to say intermittent's okay. Patients like a treatment break, like to be off therapy and say, hey, things are going well. So we decided to incorporate one treatment break. We did 9 months of therapy based upon some data from Martin Gleave and others that's kind of maximizes the anti-tumor effect. And then the question is, why not multiple rounds? And I think part of the challenge is when you're designing a big global phase 3 and patients are going on and off and on and off and on and off, it gets really challenging to try and follow them throughout and the scans and interpretation of the data. I can tell you it's already driving us a little crazy with 3 arms and on therapy and off and back on again, and just the analysis and interpretation is challenging. So, I think it was the right decision in terms of a global phase 3 to do the one treatment suspension. And how you would do it in real world practice, I think it's up to the physicians. I mean, I think we see that the patients that get treatment suspension and stay off treatment suspension or stay on treatment suspension for a long time have a really good outcomes. And so I think it allows that opportunity to think about in clinical practice a second off treatment. If the off treatment cycle is really short, I'm kind of worried about that person. I'm not necessarily excited to give them a second off treatment, but if they responded really well, and then we throw in PSMA, can we do metastasis-directed therapy and different things? That's the interesting part. I'll see how it evolves in the real world.
Thank you very much. Thank you. I think that's the end of the session.
So, thank you so much. We'll conclude now, but before we go, we'll take a group photo because I know after lunch there will be significant decline. Please, everyone, come over, please. We'll try come back in 30 minutes. I know it's too short, maybe 30 minutes only. 30 minutes break, lunch, coffee, prayer, everything. 10 minutes, 10 minutes each.
Assalamu alaikum. Thank you for being with us today. And we are going to start the afternoon session, starting with the lung cancer session. So it's my pleasure to introduce Dr. Lorenza Landi, the Director of the Clinical Trial Unit Phase 1 and the Precision Medicine at the National Cancer Institute Regina Elena in Rome, Italy. Dr. Landi, the floor is yours. Thank you for being with us today. This is a very special day for you. And honestly, the EOS want to celebrate it, and they are just prepared very small message for you. So just happy birthday. Thank you. Thank you. Thank you so much. Wow. Thank you. You're very special. Thank you. So, thank you for... It's a special way to celebrate. So, can I start with my presentation? Yes. So, first of all, thanks for your invitation. This is a privilege for me to be here and share with you my feelings about the management of oncogene-driven non-small cell lung cancer. These are my disclosures, and what comes to mind when I think to oncogene-driven non-small cell lung cancer? I think to two relevant concepts. The first one is the incidence of driver events. Here you can see an updated biomarker SPI of non-small cell lung cancer, and if you consider all the driver events, approximately half of our patients are subject to an actionable target therapy. And the other point is that missing the driver events negative affect patient outcome. And these are the reason why molecular testing is mandatory at the time of diagnosis in all cases of advanced non-squamous non-small cell lung cancer. And this is my personal to-do list. I follow these simple rules when I manage patients with oncogene-driven disease. The first point is for sure decipher the disease in terms of complete molecular profile And then also in terms of complete tumor staging. In those patients is of great relevance to do a PET scan and brain MRI and a scan of thorax and abdomen. I consider the patients, the clinical presentation of patients in terms of symptoms, but also in terms of patient expectations. I consider the best drug first when this is possible, and I never forget the CNS because 30% of patients with oncogene-driven disease present brain metastasis at diagnosis, and up to 60% of patients will develop brain metastasis during the course of the disease. So brain is an issue in oncogene-driven disease. And for sure, I am always prepared for progression because eventually all patients relapse due to the occurrence of acquired resistance. And at the time of resistance, we need to consider all the potential strategies that we had. But unfortunately, not all oncogene-driven patients are equally in terms of biology and in terms of access to drug. This is the picture that we have in Europe. I don't know what exactly is the situation here, but in Europe we can use frontline targeted agent only in the case of EGFR mutation, ALK gene rearrangement, or ROS1 fusion in some RET fusion positive disease, but in the other case, as highlighted in the green box, we can use targeted agents only in second-line treatment. And just to summarize the option for these patients, I call this patient the patient with the drivers in between, because for KRAS, EGFR exon 20 insertion, BRAF V600, MET exon 14, HER2 mutation, for this patient we choose first-line treatment based on clinical characteristic and probably PD-L1. So this patient in first-line treatment can receive chemotherapy plus immunotherapy, but at the time of progression, these patients are for sure candidate for targeted agents. And actionability in this case means frequently assess patients because targeted agents should be offered at the first time of sign of progression. So in this case, is not the best first, but the best ASAP. Moving to a more comfort zone, I will spend all the rest of the time of my presentation describing the option in EGFR, ALK, and ROS1 because they are the vast majority of patients with oncogene-driven disease that we see in our clinical practice. For EGFR patient, the standard of care is represented by osimertinib. Osimertinib demonstrated its superiority over second-generation EGFR TKI in the FLORA trial. Here you can see the progression-free survival and the overall survival curves, but as you can see, these patients, this patient eventually relapsed. So there is a need for more potent strategies able to delay progression. Last year, we saw the results of two different strategies in thinking that for some patients, the only treatment with osimertinib should be not optimal. So we can combine osimertinib with chemotherapy, or we can use a strategy chemo-free, combining different targeted agents. In the FLORA trial, the osimertinib was added to 4 cycles of chemotherapy, platinum pemetrexed chemotherapy. In the Mariposa trial, the combination of amivantamab, an antibody anti-MET and anti-EGFR, was combined to an anti-EGFR treatment. Both trials were positive for the primary endpoint of PFS, and as you can see, PFS reached 2 years, so 24 months in both trials. Of course, I don't know what is the best option and if these two options will replace osimertinib monotherapy, but some of the issues concerning the best selection of patients for these two strategies could be the safety profile, because in the case of Laura, we had the toxicity of chemotherapy, and this is mainly in the first months of treatment. With the Mariposa regimen, we add new and less easy to treat in some way adverse event, including some adverse event related to EGFR blockade, such as paronychia, rash, and stomatitis and pruritus, and some adverse event related to MET inhibition. In addition, amivantamab can cause infusion-related reaction in a fraction of patients that is more than 50%. So not so easy to manage in clinical practice. But what can we do today for patients who progress under osimertinib? The standard of care is platinum-based chemotherapy. We perfectly know that the addition of immunotherapy to a platinum doublet regimen do not produce any significant benefit in terms of disease control and progression-free survival, and we add some adverse event. So there is a general consensus in not prescribe this regimen in those patients who fail osimertinib. But few weeks ago, during the ESMO meeting, Professor Hu presented the results of this very, very interesting study. This is a phase 2 study in which a bispecific monoclonal antibody targeting both PD-L1 and VEGF, so the strategy, once again, of immunotherapy and blocking anti-angiogenesis, was offered to patients who fail EGFR tyrosine kinase inhibitors. And as you can see in the patient characteristics, the vast majority of patients receive prior osimertinib. According to PD-L1 expression, there is no clear signals of the benefit of the treatment in those patients with some levels of PD-L1. You can see in the negative population, response rate was 14%, so very interesting results. And in terms of toxicity, the drug, the combination of the bispecific monoclonal antibody with chemotherapy seems safe. And the other options is to consider the addition of amivantamab to chemotherapy. Here we have the results of the Mariposa phase 3 trial, recently updated at the ESMO meeting. This is not our reality. We have to wait to have these options in clinical practice, but once again, toxicity seems to be a limitation for the widespread use in pretreated populations. Moving from EGFR to ALK, what are the options in front line for ALK-positive patients? We have 3 main trials comparing second generation or third generation tyrosine kinase inhibitors to crizotinib. Alectinib and brigatinib produce very similar results in this group of patients with treatment-naive ALK-positive advanced non-small cell lung cancer, and the median PFS as assessed by investigator is approximately 24 months. The new kids on the block, so the new options that we have is lorlatinib. Lorlatinib is a third generation ALK tyrosine kinase inhibitor. Its activity has been clearly demonstrated by the results of the CROWN trial. As you can see, the silhouette of the curve seems to suggest a long-term benefit for this drug, and also an indirect comparison of the results of these 3 trials seem to suggest lorlatinib as the best options, as the 60% of patients at 5 years are free of progression compares to the other trials in which more than 50% of patients relapsed within the first 3 years. The strengthness point of lorlatinib is for sure its ability to cross the blood-brain barrier to control brain metastasis in terms to prolong the intracranial progression-free survival, but also in terms to prevent metastatic spread within the CNS. So, in my opinion, there is no reason to not consider this drug as the preferential frontline treatment. What happens at ALK tyrosine kinase failures? You can see a number of pie describing the mechanisms of acquired resistance to crizotinib and second-generation tyrosine kinase inhibitors, and on the other side of the slide, the potential mechanism after lorlatinib progression. And in the case of lorlatinib, even if we have only limited data, we can see that the vast majority of patients progress by developing a bypass mechanism compared to the patients who receive alectinib or crizotinib or brigatinib, in which resistance is mainly due to the occurrence of resistance mutations. Those patients treated with second-generation tyrosine kinase inhibitors in frontline can receive lorlatinib. These are the results of a phase 1-2 trials in which lorlatinib demonstrated a progression-free survival of approximately 5 months. But in patients, and this is irrespective of the type of mutation. So we can use lorlatinib in patients irrespective of their molecular testing. But there are new drugs that are in development. This is the Nuvalent 655. This is a 4th-generation tyrosine kinase inhibitors, which demonstrated a marked efficacy in those patients pre-treated with different line of ALK tyrosine kinase inhibitor, in particular also in patients who receive lorlatinib. So this could be a suitable option, a suitable future option for our patient. And this drug seems to be particularly effective and particularly well tolerated, because the safety profile is quite similar to the profile that we see originally with crizotinib. Finally, the word of ROS1. ROS1 is a less common driver event occurring in approximately 2 to 4% of our patients. In frontline setting, we can propose to patients crizotinib or entrectinib. These two drugs are very, very similar in terms of activity, duration of response, and progression-free survival in the general population. Probably entrectinib is more active in those patients with brain metastasis, but the drug is not effective in preventing metastatic spread within the CNS. And when we take a look at the mechanism of resistance, we found the same mechanism for both drugs, so the occurrence of acquired resistant mutation. So in the case of ROS1, we need a more potential drug to use in frontline setting. Among different trials that has been conducted in the last few years, I reported in red the results for repotrectinib and taletrectinib, because these two new generation ROS1 tyrosine kinase inhibitor are getting high marks in the untreated population. In the case of repotrectinib, these are the results of the Trident-1 trial. Based on the results, FDA approved repotrectinib for the use in frontline of in ROS1 positive patient, but also approve repotrectinib in pretreated population. The other drug is taletrectinib. The results of the two new agents are very similar in terms of response rate and also in terms of progression-free survival. We are exceeding 30 months, but the safety profile is something to discuss, especially for repotrectinib. And repotrectinib can cause some neurological adverse event difficult to manage. At the time of resistance, at the present, so for patients who relapse after crizotinib or entrectinib, we can consider few options because also in this case, the standard of care is represented by chemotherapy, platinum doublet chemotherapy. We can offer some specific anti-ROS1 agents by an expanded access program or using off-label way, but when we consider also in the pretreated population data produced by lorlatinib, repotrectinib or taletrectinib, in general population, they are very similar in terms of progression-free survival response rate and intracranial response rate. There is some difference in those cases in which we documented the G22R resistant mutations, but also in the case of ROS1, we have a new drug, in this case the new valent compound, that exhibited a very marked response in patients pretreated not only with repotrectinib but also with lorlatinib. And as you can see, the drug is particularly effective also in controlling metastatic spread within the CNS. So we are waiting for this drug in clinical practice to set up a new algorithm in ALK and ROS1 positive disease. So to conclude, we can say that oncogene-driven non-small cell lung cancer are handled with care disease, so NGS testing is mandatory at the time of diagnosis. Missing the driver events negatively affect patient survival and obviously patient journey. In the field of EGFR, ALK, and ROS1, new agents and new strategies are getting high marks, but their optimal positioning is under investigation. And this is my personal mantra. In the field of precision medicine, we need precise oncologists. Thank you.
Thank you. Thank you, Dr. Navina. Yes, today is the birthday of Doctora, so we wish her a happy day and all the best wishes. So, thank you for this interesting overview. We can take some questions. Yes, Dr. Hassan.
Thank you. So back to EGFR, obviously all of a sudden we are bombarded with so much information because before it was, osimertinib versus erlotinib and that was it. So my question to you, is there a space still for single agent osimertinib? And who would you give chemotherapy? Is it the high volume disease, intracranial disease perhaps? And then where would you place amivantamab? Is it better to leave it to second line since we have data on second line? Or do you see it moving to first line?
Okay. I consider osimertinib single agent in some populations such as the frail patient, older patients, or with low tumor burden, because in such case osimertinib could be an optimal solution, particularly if we consider the safety profile that is very, very manageable. Probably, in my opinion, the good option in front line for those patients with aggressive disease, with metastatic disease within the CNS could be the combination of chemotherapy plus osimertinib. We have some data describing some particularly group of risk patients, so patients with liver metastasis with TP53 mutation, so aggressive disease, this could be an option. And I consider the combination of chemo plus osimertinib more easy to manage in terms of a safety profile because we as oncologists are used to manage the toxicity of chemotherapy. I don't know if there are some patients really benefiting from the combination of amivantamab plus lazertinib or osimertinib. But in such case, I'm waiting for the subcutaneous formulation of amivantamab that is more safe. Probably an extended profiling, genomic profiling of these patients would be necessary to guide selection. So in some cases with the EGFR mutation and some alteration in MET at baseline, the association with amivantamab plus the anti-EGFR could be the optimal solution.
So, Dr. Aida.
Thank you so much for your excellent presentation. I mean, you covered everything. So in a patient who let's say if I started a patient on osimertinib, exon 19 deletion, and I do have a patient, is there any role, and the patient got carbopemetrexed in prior line setting, which he progressed on, any role for amivantamab as a single agent? I don't know. I know that we don't have data, but would you consider it just because, you know, we are using something to override the resistance?
Yeah, thank you. I tried these options requiring an off-label use of the drug, and I treated 3 or 4 patients. There is a rationale to use monotherapy with amivantamab in patients who fail at least 2 lines of treatment. But in terms of disease control, there is no clear evidence of long-term benefit, and the skin toxicity was an issue to manage, especially because this patient already received an anti-EGFR before. So in this case, the cutaneous toxicity could be much more higher than expected. Yeah.
Yes, Dr. Dalia.
So in general, in my practice, I retest patient each progression just to have the most important information. In other words, this patient is still sensitive to EGFR inhibition or not, and to evaluate the possibility to enroll this patient in some clinical trials, because in my practice, I can't offer the combination of amivantamab and in patients who fail osimertinib treatment. So I can consider or a clinical trial or platinum chemotherapy. And to ask your question, in the case of patients missed EGFR and in case of a high burden of tumor, probably I can consider the combination with immunotherapy. So in some cases, we consider in those patients who do not have great benefit from prior EGFR TKI, so those patients with stable disease, in patients with older smokers, male, we consider also the options of chemo IO.
Thank you. Any more? Yes, Dr. Hassan.
Hello, my name is Saliha from Ajman University. First of all, thank you for a very wonderful talk. There was a small question. I wanted to ask that loratinib, which we are using for lung cancer, so how it is overcoming chemo resistance? And when we talk of precision medicine, are we considering the tumor and microenvironment in that?
So your question is what happened on lorlatinib failure? Right. Okay.
Yes.
So we had some only preliminary data, and in the case of lorlatinib progression, as the majority, even if small group of patients progress by developing bypass track mechanisms, I consider chemotherapy. So chemotherapy probably in such cases could be a suitable option without adding immunotherapy in this case. Probably at the second progression, the patients can in some way recuperate the ALK dependency. So we, in any case, retest these patients. But in terms of blocking something in the microenvironment, we have no data supporting these strategies.
Okay,
Last question from Dr. Hassan.
Yeah, so we know that immunotherapy alone doesn't work in the EGFR mutated population, but we saw some data with ivonescimab, which is a PD-L1 and VEGF bispecific, and even in the EGFR population, I think the phase 2 study looks quite intriguing. So what are your thoughts on this agent in the first line setting? And my second question is, there is a small group of patients who have c-Met aberrations with EGFR, and there is a, I think, phase 2 study using savolitinib with osimertinib in the front line. So what do you make of this approach in general? Thank you.
So I consider, thanks for your question, I consider the possibility to use in the future the chemotherapy plus a bispecific monoclonal antibodies in the context of acquired resistance, not in front line, at least for the data that we have today. But bispecific agents seems to be superior to the combo of an immunotherapeutic agent plus an anti-angiogenic agent. So I don't know exactly why, but in terms of synergistic effect, there is a more pronounced anti-tumoral effect when we use bispecific monoclonal antibodies. In the case of co-occurrence of EGFR and MET alteration, it depends on the type of MET alteration, because I consider a real driver only the amplification of MET, nor the overexpression, and it's a very rare to find an exon 14 mutation plus an EGFR mutation. So in the case, I found a patient with EGFR mutation plus an amplification of MET. Probably the dual combination of an anti-EGFR and anti-MET is the most effective strategy, but only in the case of amplification.
Thank you, everyone. Thank you, Dr. Lanzi, for this interesting topic. And we can move to the next conference. I will invite Dr. Dina to moderate the session. Is Dr. Dina now? Dr. Yes.
Yes, please, thank you. So, بعمل لك introduction. Yeah, please go ahead. Assalamu alaikum. Good afternoon, everyone. First of all, thanks for the organization for keeping us updated and having this imminent meeting. Secondly, thanks for Professor Hamid keeping us all on the spot. So without delay, we'll discuss a very nice topic about lung cancer in the neoadjuvant setting on immunotherapy. It will be presented by Dr. Ola. Dr. Professor Ola Khurshid is well known to all of us. She's actually a professor of medical oncology in NCI Cairo University. She's founder and chairman of Millennium Healthcare Company in Egypt, and she has also participated in several topics of worldwide lectures and presentations. She has been actually Secretary General of the Mediterranean Multidisciplinary Oncology Forum and ISMO certified since 2006. Dr. Khorshid trained at MD Anderson and developed the medical oncology curriculum for Egypt's fellowship board. She has also numerous publications, as I mentioned, and focusing mainly on the lung and GU, breast cancer, and hematological malignancies. She has a strong research interest in lymphoma and leukemia and BMT. Without delay, I'll give the floor for Dr. Aula. Thank you very much.
Well, thank you so much, Professor Sonia. And it's always an honor and a pleasure to be here in Emirates. Thank you, Dr. Hamid, for inviting me, and congratulations on the 8th Congress. So a very important, debatable topic is neoadjuvant treatment, or how do you treat our early disease, and what kind of, okay. And so whenever we have a patient with early stage lung cancer, what do we do? Do we give neoadjuvant treatment, or do we give adjuvant treatment only? And if we're going to give neoadjuvant treatment, is it for only the resectable disease? Or can we give it for the unresectable disease? And this is another debatable point. And what's the role of our treatment if you have a patient with a PD-L1 negative? And what about the patients who do have a residual disease? What do we do for those patients? So you'll always see those patients whenever you have an MDT meeting. So what would you do for this patient? If you have a patient, he's a 54 years old patient, a T1 disease, N2 as you see, would you offer this patient surgery? Is he resectable and then go for adjuvant treatment? Or would you think that maybe we need to give neoadjuvant treatment? This is a resectable patient, we need to give neoadjuvant treatment and then surgery. Or do we need to add after this adjuvant treatment? Or this patient is not resectable, we need to go for concurrent chemoradiotherapy, the standard of care, and durva. And then we have this other patient who has this infiltrative N2 disease. What would you do for that patient? So reality is, even if you have this patient who has only this lesion, no mediastinal lymph nodes, you're not able to cure this patient with surgery. And the reason is that, again, it's important to know what is a resectable and what's not a resectable disease, and this is quite a debatable manner. You can see that what we used to think as non-resectable is now becoming potentially resectable. And even in the N2 disease, which is really how we base our treatment, what we used to think as multiple stations, is this resectable or non-resectable? This is changing now to potential resectability, bulky N2, is it resectable or not, and whether or not it's invasive. So why is surgery alone not going to be curative? Because we know that even if you have a stage 2 disease, the possibility of your patient who has a stage 2 disease to survive is only 40% at 5 years. So the incidence of recurrence or death for even stage 1B, more than 4 centimeters, we're talking about 45%. And for stage 3, it is 76%. So 80% of your patients are not going to be surviving at 5 years if you have a patient with a stage 3 disease who's supposedly to be a curable disease. Now, the history is telling us that when you give adjuvant treatment, whether you give adjuvant or neoadjuvant, you will only improve the survival of those patients by 5%, which means that we still have an unmet need, meaning that you have a patient with a stage 2 disease where 50% of those patients are going to be lost at 5 years. When you give the adjuvant treatment, you improve it by only 5%. So it's only 55%, and that's not okay for us. Now, just to define the approaches that we have, we either give adjuvant treatment, and this either mandates to give chemotherapy or not to give chemotherapy, or to give neoadjuvant approach, whether we have neoadjuvant alone, and we have only one trial for that, or now what we use is the perioperative treatment, where we give the immune chemotherapy before surgery, then go for surgery, and then go for adjuvant 1 year of immune therapy. So we've seen with the adjuvant trials, we have 3 trials now for the adjuvant immune checkpoint inhibitors. IMPAR 10 is a trial that looked at giving patients who had a resectable disease, stage 1B till stage 3A, to give them the 4 cycles of chemotherapy and then to offer them 1 year of adjuvant atezolizumab. And for those patients, there was an improvement in the 3-year event-free survival. So our patients who would receive only chemotherapy and get a 5% improvement in the overall survival, you're able to improve the 3-year event-free survival with a hazard ratio of 0.79. Now, it's important to know that this is only for patients who are PD-L1 high. So just to show, if you have a patient who has a PD-L1 that is more than 50%, those are the patients who will have a significant improvement in the overall survival. And this is why the EMA has approved giving adjuvant atezolizumab in patients who are PD-L1 high. Now, again, we know the PEARL trial. Again, this is an adjuvant trial for patients. And in this trial, they did not mandate to have chemotherapy. Some patients received chemotherapy and some did not receive chemotherapy. But after the chemotherapy or adjuvant treatment, they received 1 year of pembrolizumab. And again, there was an improvement in the event-free survival. And that was regardless of the PD-L1 expression. And why is that? You'll see, we were astonished to see that in the PD-L1 high, there was actually no difference between the survival of patients. The reason was that the normal, the non-comparative, was actually performing much, much better. So the chemotherapy alone was performing much, much better. And I'll explain why in a second. And then we had the recent BR31 trial for the Durva adjuvant, and this was a negative trial. So if you are going to give adjuvant immune checkpoint inhibitor, you would expect an event-free survival and an overall survival for patients who have a high expression if you give them immune atezolizumab, and for all comers in the PD-L1 negative positive patients. Now, what about some considerations if you're giving adjuvant treatment? It's important to know that if you have a patient with squamous histology, those patients are not going to do well if you give them adjuvant immune checkpoint inhibitor. And if you have a patient who is having an EGFR mutation, those patients will not do well. And finally, if you have a patient who has, who did not receive chemotherapy, and this was in the PEARLS trial, those patients did not do well on the adjuvant immune checkpoint inhibitor. So these are points that you need to consider when you are treating a patient who has an early disease and you need to give them adjuvant treatment. So this led to why not give neoadjuvant immune checkpoint inhibitor. And the reason that we're giving neoadjuvant immune checkpoint inhibitor is really to eradicate micrometastasis. And this is the data that we saw from the melanoma. If you give pembrolizumab for 18 cycles, compare this to giving neoadjuvant pembrolizumab for 3 cycles followed by 15 cycles of pembrolizumab after surgery, you're able to improve the survival of the patients, as you can see. So, putting this in mind and knowing that most of the patients are stage 3 disease, most of the patients are not going to be compliant, and the only survival that we're seeing with the adjuvant is for those patients who are non-squamous and those patients who are PD-L1 high. This is where neoadjuvant trials have come. And again, these are the neoadjuvant and these are the perioperative trials where we have more than 6 trials now going on. So the Checkmate was a trial that looked at giving 3 cycles of chemotherapy together with Nivo compared to chemotherapy. And in this trial, it did show an improvement in the primary endpoint. The event-free survival was significantly higher. There was a 24% improvement in the event-free survival. And this was as higher with the PD-L1. The higher the PD-L1 expression, the higher was the event-free survival and the pathological CR. This trial showed a pathological CR of 24%. Efficacy for the Checkmate trial, the 816, when you give Nivo before the surgery, is actually seen in PD-L1 positive patients. The pathological CR is 33%. The event-free survival is significantly high, and you are able to improve the 3-year overall survival to 85%, with a hazard ratio of 0.37, decreasing the risk of death. Now, if you have a patient with PD-L1 negative disease, despite the fact that you will have a pathological CR, the event-free survival and overall survival were not significantly high. So this is why the EMA approved giving the Checkmate 816 neoadjuvant Nivo with chemotherapy only in the PD-L1 high positive patients. And then this led to why not give the neoadjuvant treatment followed by surgery, followed by adjuvant immune checkpoint inhibitor. So we have a series of trials. The oldest was, and the longest follow-up was for the Keynote 671 trial, where patients were randomized to receive neoadjuvant pembrolizumab with chemotherapy compared to chemotherapy, and then go for surgery, and then go for 1 year of pembrolizumab. And again, they included patients according to the TNM-8, stage 2 to 3A disease. You can see that the event-free survival was significantly higher when you add pembrolizumab before and after surgery, and the overall is significantly higher, and this is the only trial in the perioperative setting that has shown improvement in the overall survival, with a 4-year overall survival of 67% compared to 51% and hazard ratio of 0.72. And this was seen across all subgroup analysis. Now, I just want to highlight one thing, is that if you look at the comparative arm for overall survival here, it's actually performing very well too. So despite the fact that the comparative arm is again performing very well, the Keynote had an improvement in the overall survival. Now, one caveat that needs to be addressed in all the perioperative trials is, first of all, you need to check for the oncogenic-driven mutation. In the Keynote 671 trial, 30% of the patients, or actually 68% of the patients were not checked for the EGFR mutation. And mind you that most of the patients were Asian patients, and interestingly, that after progression, 18% of the patients received EGFR TKI inhibitor, which means that this, despite of having that, and despite of having that caveat, this, the survival can be confounded, and this is probably why there was an overperformance of the comparative arm. So if you look at the surgical outcome of all the trials, the perioperative and the neoadjuvant trials, they're all having, most of them are going to go for surgery. And 20% of the patients might not go for surgery. So surgery is okay for 83% of your patients. Now, the reason that patients didn't go for surgery was, which was in about 10%, progressive disease happened in 6% of the patients, and adverse events in around 7%. Now, it's important to understand that if you're giving, because when you're discussing with your surgeon, and the surgeon is going to be asking the question, is it okay for the patient to go for surgery or not, and they're worried about the toxicities, just even for those patients who did surgery and were going to go for adjuvant therapy in the Empower 10 and the Keynote 91, 7% of the patients did have a progressive disease, and these were early patients, had a progressive disease and were not able to go for IO adjuvant treatment. And this is the surgical outcome. Basically, more patients went into surgery. So compared to chemotherapy, 83% went into surgery and 75% compared to chemotherapy alone. And the surgery was shorter, and there were more RZO resections. So it is safe to go for neoadjuvant treatment and then go for surgery and then go for perioperative treatment if needed. Now, it's important to know how are you going to restage the patient after giving the neoadjuvant treatment, because more than likely you're going to see those patients who are going to have a lymph node progression, a mediastinal lymph node progression. This is seen in around 30% of the patients. However, it's important to understand that nodal immune flare does happen, and this can mimic progression, and it has been seen that most of the patients who do have an immunohistochemical assessment turns out to be necrotizing non-caseating granuloma. So the other question is, now we have a lot of perioperative trials, so are they different? Are they the same? And the answer is they are all performing the same. So whether you're giving Pembro, whether you're giving Durva, whether you're giving Tori, they're all performing the same. They're all giving the same progression-free survival, event-free survival, and pathological CRs. Now the question is, how many cycles of chemotherapy do we give before the surgery? And we can see that most of the the perioperative were 4 cycles. Yet if you look at the Checkmate 816, it was only 3 cycles, and they were able to give the same pathological CR of around 25%. Now, The other question that we always ask, do we need to give further adjuvant 1 year of immune checkpoint inhibitor? So do we need to give the perioperative, or just neoadjuvant would be the same? And if you look at the 816 trial, event-free survival and pathological CR, the event-free survival is similar between the Checkmate 816 and all the other perioperative trials. The hazard ratios are similar, and even the pathological CRs are similar. So how do we choose? And one way, because we don't have any comparative trial that looked at giving neoadjuvant alone, Checkmate 816, or giving adjuvant or perioperative treatment and an adjuvant 1 year of immune checkpoint inhibitor. So the only thing that is evident is that if you look at the Checkmate 816, patients who don't achieve a pathological CR, those patients are actually not doing, it is as if they did not receive any immune checkpoint inhibitor. They're exactly like the chemotherapy. Survival is very poor. Yet in the Keynote 671 patients, for those patients who received immune checkpoint inhibitor and didn't achieve a pathological CR, you can see that they are actually performing better. It's not like the pathological CR, but they are performing better. Now, residual volume is going to be something that we are going to be looking at in a lot of the trials, asking the question, how much of a residual volume is going to affect the survival of our patients? So if you have that patient with an 80% residual volume, is there any role for giving immune checkpoint inhibitor for those patients, or do we need to do something that is different? And then the other question is, what about the PD-L1 negative patients? Can we give immune checkpoint inhibitors for PD-L1 negative patients? And the answer is, based on 8 randomized controlled trials, that for those patients who have PD-L1 negative, we know that for the PD-L1 high, the pathological CR and event-free survivals are quite high, and the overall survival is high. For the PD-L1 low, it's again, you will have a survival benefit. And for the PD-L1 negative, you still have a pathological CR of 16%. You'll have an event-free survival that is significant. The overall survival is not as significant as we have seen in the PD-L1 high or low patients. What about the stage 2 disease? Again, fact is, stage 2 disease, the survival of those patients, once you have a tumor that's more than 4 centimeters or lymph node positive, is very dismal, with a survival that is less than 60% at 5 years. So should we give neoadjuvant IO for those patients? Again, this is a repeated question that we ask in our MDTs. And if you look at the meta-analysis, the answer is yes, because again, pathological CR is in the ranges of 16% in those patients. And the higher the PD-L1, the higher is going to be the pathological CR. But more important is the event-free survival is still longer when you give the neoadjuvant immune checkpoint inhibitor. But important to know, if you're going to give the perioperative treatment, it should be in patients beyond 4 centimeters, because we know there is no advantage for those patients less than 4 centimeters. You need to conform with pathological staging. If you have a patient with a tumor that is beyond 4 centimeters, those patients will benefit from the perioperative treatment. And again, remember, there is no role of giving immune checkpoint inhibitor as adjuvant if you're not going to give chemotherapy. We've known that from the PEARLS trial. And there is absolutely no role of giving adjuvant immune checkpoint inhibitor if a patient has EGFR or ALK-positive disease. And finally, what about the unresectable stage? Can we offer patients neoadjuvant treatment, send them for surgery if they're unresectable? Now, that's another question that we have. Facts are, with the Pacific trial, the median overall survival is 47.5 months, and this is a stage 3 disease. And again, we're going to lose more than 50% of our patients. So an interesting trial that is a phase 2 trial, it's a Chinese trial that is looking at patients who have an unresectable disease and receive a neoadjuvant immune checkpoint inhibitor with chemotherapy. They're sent to surgery, and then they were followed by or radiotherapy, and then they were followed by 1 year of immune checkpoint inhibitor. And interesting in this trial is that they found a 25% conversion rate for patients who were unresectable and received neoadjuvant treatment. Lobectomy was easily performed, R0 resection in 100% of the patients. 61% were downstage from N3 to N2 disease, and pathological CR in unresectable patients was 26%. So that is something that is important to discuss. And this will change the idea of marginal resectability that we're hearing. It's going to change, where we'll probably see more of addition of patients who have unresectable disease. This is the NCCN guidelines, which is clearly saying now that for any patient with a tumor that is 4 centimeters or higher but resectable, these are the guidelines for now, should receive perioperative treatment. Now, whenever we have a patient who has early stage disease, we think about, is it resectable or not? And then we look at the biomarkers, we look at the PD-L1 expression, and we look at the EGFR mutation. And then based on the pathological CR, we choose the treatment, whether we're going to give immune checkpoint inhibitor as adjuvant or not. This is probably going to change, where we're now going to look more at the biomarkers. If we have PD-L1 high patients, those patients are going to have a pathological CR that is much higher. And then we will assess for the resectability, regardless of or not they were unresectable in the beginning. And then according to the pathological CR, if the patient has a pathological CR, do we really need to give adjuvant immune checkpoint inhibitor or not? If the patient doesn't achieve a pathological CR, do we need to give further adjuvant IO, or do we need to give something different, combination? Example with ADCs and IOs, but truly we need to have a clinical trial for that. So again, just my conclusion at the end, that stage 2 and 3 patients who have a resectable disease, those are the indications for the perioperative treatment. For patients with potentially resectable, for now, we will wait for the clinical trials that should be done. We give it for the patients whether it's PD-L1 positive or negative, and whether or not we need to give adjuvant treatment. Again, the recommendation is to give for all comers, but for patients who don't have a pathological CR, those are the patients who will definitely benefit from 1 year of immune checkpoint inhibitor. And you have to check for EGFR and ALK mutations, because those patients will not benefit from perioperative treatment. And MDT, of course, is the key. And finally, I would like to invite you all to 2 important congresses. One will be in November. This is the NCI Congress, Bridging Gaps on Oncology. And in January, we have the famous Thoracic Malignancy Congress, the Oncothoracic International Congress. Happy to invite everyone, and happy to take questions. Thank you.
Thank you, my dear Professor Dr. Ala. Now take 2 questions, please. دكتور حسن غزال ما بيسيبش حد. المايك.
Yeah. Actually, it's positive. The only problem is that, you know, it was the
high PD-L1 one was negative.
Yeah.
So if out of 3, 1 is clearly positive, do you think this is an outlier trial? Like some people have questioned, is maybe IMpower 010 was the outlier because the other 2 trials are not as convincing? That's number 1. My other question is in the other space of perioperative and neoadjuvant. Stage 2 patients also derive some benefit, but it's less than stage 3, and PD-L1 negative also derive benefit, but it's less than PD-L1 positive. So what if you have a stage 2 PD-L1 negative patient? Would you confidently offer immunotherapy? Thank you.
That's a very good question. That's an excellent debatable question. So again, if we have, let me first answer the first one. So the 3 trials that we have in the adjuvant setting, we have the Empower 010 with atezolizumab, we have the PEARLS trial with pembrolizumab, and we have the BR trial with the durva. So facts are, when you give the atezolizumab for a patient who received his adjuvant chemotherapy, and you add 1 year of atezolizumab, you're still improving the survival, especially when your patients are PD-L1 high. So if you have that patient who didn't go for perioperative treatment and he went for surgery and his PD-L1 positive high, I would give that patient 1 year of atezolizumab. If the patient, same patient, didn't receive perioperative treatment and his PD-L1 low or intermediate, is he going to derive benefit from atezo? The answer is no. Is he going to get benefit from pembro? then we have the PEARLS trial that is saying yes. PEARLS trial problem, and again in the keynote 561 trial, was that they did not check for EGFR mutation. And most of the patients were Asians. And we know for those patients, they respond, if you have a patient with EGFR mutation, he's going to respond very well on chemotherapy. So this is probably why the patients are having this excellent improvement in the overall survival for those patients. So this is regarding the adjuvant treatment. I would not say that it was the Empower was the outcaster one. No, I would say that Empower was actually, and Pearl, they are positive trials, and I would still give adjuvant immune checkpoint inhibitors. Now, your other question is very important, is, again, do we need to give a perioperative treatment for patients with stage 2 disease? The meta-analysis is saying yes. But we have to put into consideration a lot of things. We have to put costs into consideration. We have to put a lot of other confounding factors. Because reality is you don't have an overall survival for those patients. You'll only have event-free survival for those patients. For the same patient, stage 2, with PD-L1 negative, the pathological CR is low. You're still going to have pathological CR that's around 16%. You're still going to have event-free survival, but it is going to be much, much less than that patient who has a PD-L1 positive and higher stage disease. So it has to be discussed with real wisdom. So if you have a patient who's willing to go for the extra mile to make sure that this disease never comes back, then you have to discuss this with him and tell him then this is the benefit that we can have, and with the expected cost and financial and side effects.
Here, so I'm just a follow up on that. PD-L1 can be heterogeneous, so I don't know if a small biopsy is going to sway me one way or another. I will not depend on PD-L1 if I want to give neoadjuvant therapy. That's my thinking. I don't know if you agree or disagree, but like you said, there is benefit even in those group of patients, and a small biopsy may not be fully representative of what the tumor is. Number 2 point I want to comment on what you mentioned is it's not just resectability. We know if you operate on N2 disease, yeah, surgeon will say, oh, I can operate, it's a small volume, nothing. The outcome is dismal, and you cannot salvage these patients with adjuvant therapy. So I think all these patients need to get into the neoadjuvant approach, at least give them a chance. And we know from the data, I don't know if you mentioned it, that we can clear 60% of N2 disease. And that's a prelude to improve outcome, is the clearance of N2 disease at the time of surgery. My question to you, so if you have a stage 3 disease and then you found out it is an EGFR mutated, let's say, I know it's still ongoing trial, but now in the clinic, how do you manage such patients? Because I know the initial data with osimertinib has not seen a high CR in phase 1-2 trials. But so how do you approach these patients? Do you still go with chemo, maybe chemo plus OC? We don't have, obviously, guidelines.
Well, thank you. I think after Dr. Hassan, we will stop the questions because we are out of time. Thank you very much. Yes, Dr. Anna,
so
please.
I'll answer you. So first of all, my comment for your first comment is, yes, absolutely agree with you that neoadjuvant should be given to all the patients with early disease, and now we're trying to shift it to even the unresectable patients. His question was, stage 2 disease, PD-L1 negative. Now that is, he's asking, is the patient going to drive value from that or not? This is going to be a debatable point that needs to be discussed. What about those patients who have an oncogenic-driven mutation, whether it's EGFR or ALK? That's your question. We have to wait for the new ADORA trial and see the results. But again, if I have that patient with EGFR mutation, I would like very much to give him the neoadjuvant, osimertinib, or even whichever the EGFR TKI inhibitor, but I will give it with chemotherapy. Thank you.
Thank you. With that, we end the session. Thank you very much. Dr. Hassan, thank you.
Good afternoon, dear all. I'm really delighted to chair the next session, which will be a debate. And the main question is for patient with EGFR mutation, the common mutation, do you go for single agent osimertinib or you go for the combination of anti-EGFR plus chemotherapy? So first we can vote for that question and then we will see the debate. And also I'm delighted to invite Dr. Kinj also to chair the session with me. So I encourage everyone to vote. It's only 3, 8. So almost 55 in favor of the combination versus 45. So really I'm delighted to present my colleague and friend, Dr. Arafat Twaili, who will first vote for single agent osimertinib. Dr. Arafat is a consultant medical oncology. He has his training in US from George Washington University, and he is working currently in AUB. Also, he is the head of the clinical research, and he is mainly responsible for lung cancer. He is supposed to be with us today, but because of the unfortunate what is happening in Lebanon, God saved them. So he will present it virtually with us. So most welcome, Dr. Arafat.
Thank you, Dr. Hassan, for the invitation and for the introduction. Can you hear me well?
Yes.
Okay. So as mentioned by Dr. Hassan, this is a debate. Should we go in patients with EGFR mutated non-small cell lung cancer upfront treatment? Should we go with single agent osimertinib versus combination therapy? And my role is to support the evidence for single agent osimertinib, and definitely I'll be interested to listen to the opposing opinion. So as a background, it all started in 2004 with the first description of EGFR mutations. And since then, things have really developed more rapidly, and it is getting more and more complicated as we go on. And so the first wave of trials that compared first and second generation TKIs versus chemotherapy, they all favor the TKI. And what I need you to keep in mind a few numbers during this presentation. So if you look at the progression-free survival column, the progression-free survival with the TKI is in the neighborhood of 9 to 10, maximum 11 months. And there was no overall survival on these trials, mostly because of crossover. Most of these trials allowed crossover to the TKI after failure of chemotherapy. But essentially, the progression-free survival, probably, which is a reasonable endpoint in first line, was in the neighborhood of around 10 to 11 months with the first and second generation TKIs. And it's clear really from multiple series. This is the LCMC3 series, where a large series of patients who got tested for driver mutations. And the orange line represents the population who had a driver mutation and did receive their targeted agent. Of course, they had a better survival compared to the patients who had no driver mutation, or they had a driver mutation but did not receive the targeted agent. And this is very important, especially in our region. So if you were to offer NGS testing on somebody looking for some mutation, but you don't have a drug for it, why test it? Because really, you're just gonna cause more distress for the patient and so on. So before we go on with testing, we have to see what comes as a result of that testing before doing it routinely in our patient population. So, and following that, we have at least 2 trials. This is one of them. This one is from India, where they tested the combination of chemo plus TKI. As a reminder, before selecting for EGFR mutation, all the chemo plus TKI were negative. But this trial is specifically in patients with EGFR mutation. So the patients are newly diagnosed with exon 18, 19, or 21 mutation, and they get randomized to the first generation TKI, namely gefitinib, or the gefitinib plus chemotherapy. And the chemotherapy was given as 4 cycles of platinum pemetrexate, followed by maintenance pemetrexate, in addition to the gefitinib. And the result from that trial is very interesting. You see an improvement in progression-free survival, as well as improvement in event-free survival. If you look at the actual numbers for PFS, the median for gefitinib was 8%, and for the gefitinib plus chemo was 16 months. So there was doubling of the PFS. So of course, this is an interesting approach, and I think it's a reasonable thing to consider in patients who don't have access to osimertinib. We're going to see the data on osimertinib, but you have access only to gefitinib. We have a trial that shows a doubling of the PFS and overall survival when you add the chemotherapy to it. And then came the FLORA trial, the famous FLORA trial, I'm sure most of you are familiar with, which compared the third generation TKI, osimertinib, versus the first generation TKIs, gefitinib and or orlatinib. These are patients with common mutations only, exon 19 and exon 21, newly diagnosed, and they get randomized 1-to-1 to one of the two arms. Very important, really a very important aspect of the design of this trial is the crossover. Patients who received gefitinib or erlotinib, and when they progressed and they tested positive for T790M mutation, they were allowed to have access to osimertinib. And this is a very important design aspect. I'm going to mention this several times. Really, we have to keep in mind what the patient receives in the later lines of treatment, not only in that line of treatment. So if the patient is going to derive the same benefit from receiving the drug in the later line, the argument for giving it in first line becomes weaker and weaker. So these are patients who received a third generation or first generation, but those who had first generation and they had progression and T790 mutation, they were able to receive osimertinib as part of the trial. Primary endpoint was PFS with multiple other secondary endpoints. And as you know, the PFS was definitely in favor of osimertinib, with improved from 10 months to 19 months. So these are the second set of numbers I need to remember, the 10 months to 19 months. So the 10 months is exactly what we saw on all the other trials that compared first and second generation to chemo. So it tells you the patients did receive the drug as expected, and they achieved the PFS that's expected, which is around 10 months. And that number improved to around 19 months. So this is the second number we need to remember, 19 months PFS when osimertinib was given with a hazard ratio of 0.46. And whatever subgroup you look at, really the benefit was very consistent according to age, sex, race, smoking history, exon 19 or exon 21, and so on. There was almost universal benefit in favor of osimertinib. Whether the patient had CNS metastasis or no CNS metastasis, the hazard ratio were exactly the same, 0.47 and 0.46. Response rate did not improve much, that's expected, because the response rate to the first generation TKIs is very respectable, 76%. That number improved only to 80%. But importantly, the duration of response was better in favor of osimertinib, and that's why the PFS was significantly improved. So although the majority, 4 out of patients, do respond to both drugs, the duration of response lasts longer, and that's what explains the improvement in the PFS. And importantly, although this was not the primary endpoint, we do have overall survival. And this is a very essential aspect. You're not going to see this overall survival on most of the other trials I'm going to discuss with you. We do have overall survival despite the crossover. I'll share with you the crossover results. So patients who had first generation TKI and they progressed and they received osimertinib second line, despite all of this, you have overall survival. What this tells me, yes, you need to use it first line, not first generation followed by third generation, because you do have overall survival despite allowing the patients at T790M progress. At 3 years, there was a 10% improvement. At 2 years, almost 15% improvement in overall survival in favor of osimertinib. So as you can see, this is a summary. Essentially, whatever endpoint you looked at, it was better in favor of osimertinib compared to first generation. And this is what happens after treatment. So as we mentioned, crossover was allowed. So if you look at the 2 columns to the right, these are the patients who received first generation TKI. 65% of them switched to receive a later line of treatment, and 47% receive osimertinib. And this is a very respectable number, 47%. As you know, T790M mutation happens in almost 50 to 60% of the patients once they progress on first generation TKI. So having 47% of the patients receive osimertinib, this tells you really the patients had adequate access to treatment. Okay, and the other things I need to look at, to the column to the left, patients who received osimertinib, only 31% of the patients did not have subsequent anti-cancer treatment. So 70% of the patient had subsequent treatment. So if you start with osimertinib, 70% of the patients will have will receive second line. You can see a different number in the other trials. So really, essentially, we have an improvement in PFS from 10 to 19 months, an improvement in OS despite crossover. And the third thing is 70% of the patients did receive second line, which you're not going to see in the other trials I'm going to discuss in a few minutes. And those of you who have used osimertinib, you really can tell it's a very gentle, it's a very easy medication to treat. This is the side effect profile. To the left is that of osimertinib, or to the right is that of first generation TKI. All three are very gentle medications. You see a little bit more rash with the first generation, a little bit more liver enzymes with the first generation. The third number I need you to remember is the 18% incidence of grade 3 toxicity with osimertinib. 18%, not higher. In fact, really, I don't remember the last time I stopped a medication, I stopped osimertinib on somebody because of toxicity. So the grade 3 and 4 toxicity is only 18%, not higher, in the FLORA trial. And then we have these 2 trials I'm going to share. They were briefly mentioned in the previous presentations, but these are the 2 competing approaches to osimertinib. So the first approach is FLORA-2. So just like the Indian study did chemo plus gefitinib versus gefitinib alone, FLORA-2 is essentially osimertinib versus osimertinib plus chemo. So same chemo, platinum plus pemetrexate, followed by pemetrexate maintenance with osimertinib versus osimertinib alone. And progression-free survival is the primary endpoint in that trial. And the progression-free survival improved. So you can see the actual numbers improved from 19 to 29 months. So 19 is exactly what we saw in the FLORA trial, which tells you, yes, this is how does osimertinib behave. That number improved to 29%. And is that good enough to adopt that regimen? In my opinion, no. And there are several reasons. So this is PFS2, meaning time to progression after first and second line. You see very little difference. We see some trending right now in favor of the combination, but a really very limited difference. But most importantly, if you look at the subsequent treatment, so these are what did the patient receive after first line? The first red rectangle, you see 40% of the patient on osimertinib did not receive any treatment, and 50% on the combination did not receive any treatment. So really a large patient did not have proper access to post-treatment. Only 54% of the patient has cytotoxic chemotherapy with osimertinib. We know in clinical practice, really much larger population do receive second line because very few patients are too sick to receive second line after osimertinib. It's a very gentle medication. Surprisingly, 10 to 15% received first or second generation TKI, which we know do not work on these patients after osimertinib. So I'm not sure why this was given. And around 8 to 15% received PD-1, PD-L1 inhibitors. Also, we know these drugs do not work in EGFR mutation. So really, the subsequent treatment was left open. In my opinion, is really substandard treatment because a small percentage, smaller than expected percentage received the second line, and many of the agents used in second lines are not ideal, either first generation or immunotherapy and so on. And that's why I have my doubts about the result of the FLORA-2 trials because it's not really well designed. If you remember, FLORA had a crossover. This one does not have a standard crossover as part of it. And the most important endpoint is overall survival. No hint of difference between single agent for combination. So if I have an agent that gives you the same overall survival, with much better tolerability, why combining with other agents and toxicity? The second trial, which again was mentioned in previous presentation, is the Mariposa trial. So these are patients who received osimertinib versus amivantamab plus lazertinib or lazertinib alone, and the progression-free survival was the primary endpoint. Again, only exon 19 and 21 mutations, and the PFS favored amivantamab plus lazertinib. I put in the red square the actual numbers. So you see osimertinib did a little bit worse than when we saw in FLORA and FLORA-2 trials. Median PFS of 16 months, where then the other two we saw a 19-month PFS. And the combination as amivantamab plus lazertinib was 23 months, which is better than osimertinib alone. Lazertinib alone was not better than osimertinib. And why I have my doubts about this? First of all, overall survival remains negative. We don't have any evidence that the combination is better compared to osimertinib alone. And very importantly is the toxicity profile. So grade 3 toxicities, 75% of the patients that amivantamab plus had grade 3 toxicity. Osimertinib, 43%, which I don't believe this number, to be honest. Remember the FLORA trial, the other number I asked you to remember was 18%. See here, we see the 43% had grade 3-4 toxicity for osimertinib, which I'm sure those of you who are familiar with osimertinib, we don't see in clinical practice. Look at the discontinuation rate, the interruptions, and so on. So amivantamab plus lazertinib, 83% of the patients had to interrupt the drug, 59% had to reduce, and 35% had to discontinue the drugs because of toxicity. With the osimertinib, only 14% had to discontinue it. Again, I feel these numbers are higher because this is not what we see in our clinical practice. It's a very safe, well-tolerated medication. So we have a combination that does not improve survival, and it's much more toxic on the patient. While the beauty of a single agent osimertinib is a simple pill that you take at home and very convenient with minimal toxicity. Safety profile, to the left is the combination, to the right is osimertinib. You can see all of the toxicities are higher with amivantamab plus lazertinib. That's why I don't favor that. So in summary, I believe first-line osimertinib remains the standard of care in patients with advanced EGFR-mutated non-small cell lung cancer. The addition of chemotherapy is a controversial effect, and amivantamab plus lazertinib improved PFS, but no OS with significant toxicity. Thank you.
Thank you, Dr. Tfaili. Thank you so much. It is my pleasure right now to introduce Dr. Hassan Shahriyar, a US-trained medical oncologist. He's in Sheikh Shakhbout Medical Center. He will be voting for the combination versus the single agent.
Okay, thank you very much, Dr. Kinch, for the nice introduction, and thanks to Dr. Hamed Shamsi and the scientific committee of EOS for inviting me today. So I will be speaking for the combination, and when I was preparing this talk, my goal was to look at the first line management really, but I think that's really the most important question now. What is the most optimal way to treat? I want to thank my esteemed colleague, Dr. Arafat, for laying out the stage already nicely. I'm not going to be showing a lot of new data. There is some data that has not been discussed yet, so I will go into that in more detail. But a lot of data, I think I'm going to give a different aspect of the way we look at it. So again, so what are the options in our first-line treatment of metastatic non-small cell lung cancer with EGFR mutation? We already heard the very eloquent speech on the FLORA data. This was the study which set the standard of care in 2018, and it showed improvement in PFS of about 9 months compared to the first-generation TKI, and it also had an overall survival benefit of about 9 months as well. Very conveniently offered a treatment. Patient tolerated it very well. It was a superb option, I think. And now, as I would debate, I don't think this is dead, but I think most of our patients should now be treated with some of the more exciting data that we have seen come out in the last 1 year or so. So I'm referring to the FLORA-2 and the Mariposa studies. These are the frontline phase 3 trials. And also, these are not the only options. I think there are some other options also emerging which are promising in the frontline setting. We won't discuss that in detail today. My focus is going to be on OSI mono versus combination therapy. So let's go again with a new look, with a new approach of interpreting the FLORA-2 and Mariposa trials. So FLORA-2 is, as we know, is a combination of osimertinib plus chemotherapy, the standard platinum-based chemotherapy, compared to OSI alone. And it showed an improvement in the PFS, which was the primary endpoint of the study, 25.5 months compared to 16.7 months. The overall survival is not reached yet. It's still immature. And in the Mariposa study, we saw actually very similar efficacy outcomes, PFS of 23.7 months in the combination versus 16.6 months with osimertinib. And you can see the osimertinib control arm is performing very similar, so that's good to know from a comparative standpoint as well. Today, we will not be going into the choice between which combination. I think that's another debate. Thankfully, I'll just focus on the combination strategy versus single agent osimertinib. So when you look at the primary endpoint of PFS, the hazard ratios were improved 0.62 in favor of osimertinib plus platinum-based chemotherapy in the all-comer population. And this was confirmed in the independent review as well. So it clearly met its endpoint with a hazard ratio reduction in the progression by about, I would say, 38 to 40%. I think the key is in the subgroup analyses, or what I would say the high-risk population. Now, metastatic EGFR lung cancer is a very heterogeneous population. Not all are the same. We understand that some of the patients may have CNS metastases, liver metastases. They may have other co-mutations, which confer them a different prognosis than the standard average EGFR mutant lung cancer population. And I didn't mention this in the earlier slides, but if you look at the PFS in the FLORA trial, patients who have L858R mutation or CNS metastasis has a poor PFS compared to the average garden variety. So clearly there is a group of patients in this population where osimertinib alone is not going to cut it. And we know that almost all the patients eventually will progress on osimertinib. So when we focus on the CNS metastases group of EGFR mutant lung cancer, the combination of osimertinib with platinum chemotherapy did fantastically better than osimertinib alone. So hazard ratio of 0.47, so more than 50% risk reduction compared to patients who had no brain metastases, for example. There was still a benefit of 0.75 HR, but more pronounced in patients who have CNS mets. I understand that these are subgroups, but still you can see that there is a clear separation of the curve, so there is definitely a very convincing signal here. Now, we talked about the overall survival. So this was the second interim overall survival data presented just a month ago at the World Lung Congress. And it is still not fully mature, only 41% maturity, and we will await the final overall analysis next year, hopefully. But as you can see in the curves, the latter half of the curves, the curves are continuing to separate. We don't see them coming together as we saw in earlier overall survival graph. So I think the signal is looking very promising and positive. And for me, it is as an optimist, I feel that we will hit an overall survival benefit. So currently the hazard ratio is 0.75, which is quite decent. There were a few other high-risk groups defined in the FLORA-2 study. So the other groups is the tumor volume or the tumor burden. And it was defined as number of metastatic sites. So if you have 3 or higher, you were considered in the higher tumor burden, and if you were less than 3, you were considered low burden. So in this high-risk subgroup, again, you see when you combine chemotherapy with osimertinib, you have a clear benefit. Your patients are doing better. Single-agent monotherapy with osimertinib is not enough. So hazard ratio of 0.57 compared to hazard ratio of 0.75. And another subgroup and a high-risk group is the liver or bone metastases. So again, both are shown here. In patients who had liver metastases, they clearly seem to be doing better with osimertinib with chemotherapy compared to osimertinib alone. And in patients who had bone metastases, they also seem to be doing fairly well. Hazard ratios are, again, very decent, 0.56 and 0.66. And the curves are separating right from the get-go. So there's a much clearer, I think, benefit seen in these group of patients. And now coming to the toxicity, of course, when we are combining osimertinib with chemotherapy, there is additional hematological and GI toxicity from chemotherapy, and we are all very familiar and comfortable with giving platinum-based chemotherapy. So yes, there is a higher anemia, nausea, low appetite, fatigue, neutropenia, and thrombocytopenia in the chemotherapy arm, but I think these are all very manageable side effects and should not deter us from offering it to our right patients. Now let's switch gears to the Mariposa trial. So this was the primary endpoint of PFS. So we have amivantamab, lazertinib compared to osimertinib in the top bar here. So 23.7 months versus 16.6 months with a hazard ratio of 0.70 and a p-value of 0.001. So it met its primary endpoint. And also, when you combine with the lazertinib, the hazard ratios are similar and the benefits stand. So significant improvement in the PFS when you give lazertinib combination compared to osimertinib. And again, we saw that in this trial as well, this Mariposa trial was enriched for high-risk population. About 90% of the patient had at least one or high-risk feature. And it's not uncommon in our clinical practice also to find patients who have at least one high-risk feature. So I think this is very similar to what we see in our clinics. Patients have brain metastases at baseline or liver metastases. And if we are able to perform NGS or ctDNA studies, we can find that they may have TP53 mutations and the presence of ctDNA. So this has been earlier shown in the studies that patients who have detectable EGFR ctDNA at baseline and who do not clear their ctDNA by 9 weeks, they do poorly than those who are able to do so. So in these high-risk groups of brain mets, liver mets, positive ctDNA, co-mutations with TP53, RB1, all of these groups very clearly seems to do better with the Mariposa regimen of amivantamab plus lazertinib compared to osimertinib alone. So in somebody like him, I think I would be a little reluctant to offer just single-agent osimertinib. We also saw the longer follow-up, which is about still 31 months of follow-up. data presented at the World Lung Congress a month ago. This was, again, the update on the Mariposa. So, and then this is the overall survival curves shown here. And you can see that there is a clear separation in the curves. Initially, there is a period of overlap, but then after about 12 months, the two groups clearly start to separate, and they remain separate. So I think this is very encouraging. Again, this data is not fully mature, but the landmark analysis is already showing at least 10% absolute benefit in patients who go on to combination versus single agent osimertinib. This is, again, the similar efficacy data shown here in the table form. So overall survival has not reached with ME laser, and it's 37.3 months with osimertinib. And at 3 years, 61% of the patients are alive with ME laser versus 53% with osimertinib. And in the secondary post-progression endpoints of time to deterioration, time to second therapy, we see that there is a numerical and actually statistically significant improvement in these other outcomes. PFS2 is also not reached on the ME laser arm, so again with a p-value of 0.004. So PFS2 can also be a surrogate for overall survival data. So it's looking all in the right direction that this combination is superior to osimertinib alone. In terms of intracranial PFS, we see again a doubling of the PFS in the CNS met. So at 3 years, 38% versus 18%. So I think this efficacy data is quite clear that combination now is the way to go in this high-risk group, at least, who will not do well with osimertinib alone. This was the exploratory analysis of lazertinib versus osimertinib. Both are third-generation TKIs, so it's no surprise that they are quite comparable, although their side effect profile is quite different. Lazertinib has a lower QTc and cardiomyopathy, diarrhea, thrombocytopenia, but can have higher rash or muscle spasms compared to osimertinib. Of course, I think the important thing with Mariposa trial is to discuss the toxicity profile. So amivantamab is a bispecific EGFR MET antibody, and it has side effects related to EGFR inhibition as well as MET inhibition. So we see more paronychia, rash, diarrhea, and we see more peripheral edema, hypoalbuminemia with amivantamab. But there are a few things to be, I think, noted here. First, we also saw the SKIPPER trial, which was presented at ESPO, and it showed us that if you can pre-medicate these patients with dexamethasone for 2 days prior, you can cut down the risk of infusion reactions by more than 1/3. So I think that's an important take-home message from that study in how we administer amivantamab. And second, I think with the subcutaneous formulation, which should be available next year, hopefully we will see most of these infusion reactions at least disappear, and we'll be left with a very small percentage of patients who have VTE and a skin rash. And like any other new drug, I think there will be a learning curve for all of us on how to administer, how to manage the skin toxicity and other toxicities, and I think we will get better at managing these patients' side effects. So of course, when we are looking at combination toxicity, quality of life, financial cost, and overtreatment are all those important things that we have to consider when choosing the right regimen. But I think there is a distinct population, which is, I think, the vast majority of these patients who will now benefit from combination. So here I'm giving you two broad, it's a spectrum, right? So risk is not something you can point your finger at. It's a spectrum of combination of different factors, and we have to take into consideration all of them. So on one hand, we have a low-risk EGFR mutant lung cancer, which could be an older person with a favorable EGFR exon 19 deletion, asymptomatic oligometastatic disease, thoracic limited, slow-growing, maybe ctDNA negative. That would be an ideal patient for, I think, osimertinib monotherapy. So yes, it is not dead, but I think for the vast majority of other patients, and on the extreme end are those like young patients who want everything done. Remember, this is a disease which happens in younger people. So there will be patients who want every possible benefit from available treatment. So young patients with a poor risk features like L858R, TP53, RB1, high tumor symptom burden, fast-growing, brain metastases, liver metastases, bone mets, high volume, multiple sites. These are the patients who should be offered a combination therapy, whether it's OSI with chemo or with the Mariposa regimen. So we're definitely, we are moving forward, I think, and with that, I want to thank everyone and I'm happy to take any questions.
Thank you very much for both speakers. Thank you very much for both speakers. If we can have the voting before we have a discussion, and it will be short discussion because of the sake of time. So do we have any questions? I have a question. If you have a patient with less common mutation, those patients, we know that afatinib is by the guidelines, and we know that there are many series also for osimertinib. So do you think those patient risk category put them on the high risk category that you have to put the combination and you apply the Mariposa or the Flora combination chemotherapy?
Yeah, I mean, that's a good question. I think definitely the uncommon EGFR mutations we have less data in the at least pivotal trials, and some of the responses to standard therapy may be less than what we see in the classical mutations. But we do have, like from the Mariposa regimen and even with osimertinib, these uncommon mutations were targeted successfully. So I would not exclude them from these trials. And I would definitely favor a combination because I think monotherapy may not have the same response rate as we see in the classical mutation.
Dr. Hassan.
So thanks for a beautiful debate already. I want to just remind Dr. Arafat, my friend, first stay safe, of course, that it took so many years before we saw the survival benefit between osimertinib and first generations. And in fact, if you look at the PFS, it's almost the same hazard ratio that we are seeing now with combination chemo plus osimertinib. So I agree with the initial curve of survival. We are on the right track. I think it's just a matter of time before we see a significant survival, statistically significant survival advantage. I don't know what you think about that. And then just a comment on what he was saying on the first trial between osimertinib and first generation. If you start with first generation, not all patients are eligible for osimertinib, of course. You have to have the T790 mutation, which is about 50-50. So if about a third received osimertinib, that's actually pretty good in terms of getting the standard of care in that second line. And just about the 10% who got first generation after osimertinib, we know that certain mutation that may still be sensitive to first generation, like the C486, I forgot the exact number, but they can potentially be sensitive to first generation.
I agree with you, Hassan, but the only issue I have is because in the Flora trial, the patients, as part of the design of the trial, they had the standard of care. So they had first generation followed by osimertinib if they had T790 mutation, and despite that, there was overall survival. That's why it's preferred. While in the Flora 2 or in the Mariposa trials, the second line regimen was left open. So really, and clearly, I think from the data from the Mariposa 2 trial, the access to medications was suboptimal in the second line option. That's why I think that the subgroup had a lower performance. Regarding the second question, you mentioned the first generation. Yes, I agree with you some, but this is very rare. You're talking about the T797 mutation. That's very rare. You're talking maybe 1 to 2%, not 15%. In the Mariposa trial, 15% has had first generation, which is very unusual.
Again, I mean, the answer is not one thing fits all. Those patients, clearly, as you mentioned earlier, sequencing of the treatment, much less toxic. Those patients, they can get into first and second line treatment, while those with visceral crisis, brain metastasis, probably have the chance of one shot to give those treatment. So thank you for both speakers. Thank you for all. I think for the sake of time,
sorry,
please.
one criticism that I want to respond to regarding the second subsequent therapy and the post-protocol treatment. First of all, I fully agree that post-protocol treatment is very important. It affects the outcomes. However, I think if you look at it from another aspect, this attrition is really the problem, that a lot of people are not able to get to the second-line therapy, so you want to choose your best treatment up front. So maybe giving them a stronger combination.
I mean, this is always a criticism in many clinical trials, that you are giving 2 lines of therapy rather than 1 line, and you cannot guarantee those patients automatically go, so they mandate the second line. So I think always this will be a criticism. Thank you very much for all. Thank you, Dr. Kinje. And we'll move to the second presentation.
Good afternoon, everyone. Thanks, EOS, for giving us this chance. I think there have been hot topics on cancer since yesterday. And without further ado, I'm going to present Professor Thorsten Furder, who is an associate professor of medical oncology at the Medical University of Vienna, who is heading the immuno-oncology research platform. Yesterday, we heard a very nice discussion from him about the immunotherapy in lung cancer, and today he's going to take us to another platform about the antibody-drug conjugates in lung cancer. Professor Furder, we are very happy to hear the next presentation. The floor is yours.
So thank you so much for the kind introduction. So I'm back again, you as well, obviously. Yeah, different topic today. Today I want to address a bit and talk about antibody-drug conjugates. There's a lot of enthusiasm about these new classes of drugs and substances, and I will try to address the current status, but also give you my considerations regarding the future developments. So my disclosures. As all of you know, antibody-drug conjugates consist of a monoclonal antibody which targets a protein on the surface of the tumor cell, a linker. This linker is usually linked, obviously, to a cytotoxic drug payload. There are 2 types of linkers, cleavable and non-cleavable linker. Initially it was thought that non-cleavable linkers are the preferred option, but for now the most effective ADCs have cleavable linkers. The cytotoxic payload, as it's stated, is commonly chemotherapy, which usually cannot be given as it's on its own, but it has to be given linked to this antibody due to toxicity concerns. So regarding the mechanism of action, as you all know, the antibody is combined with the target antigen, is bound to the target antigen of the tumor cell. Then the complex is internalized and into the cell, uptaken and destroys the cells. A lot of antibody-drug conjugates also exert an activation of the immune system. This is not true for all of those antibodies, but a couple of those do so. And as soon as the tumor cell is undergoing apoptosis or necrosis, the payload might be released into the tumor microenvironment and also targeting the surrounding, the so-called bystander effect. It's also important to address or to think about the so-called antibody-drug ratio. So the novel generations of ADCs have an antibody-drug ratio about 4 to 8. Of course, a bit higher seems to be better, but if it is too high, this is also not a very good idea to have it too high, because then the liver and the body increases the clearance of these antibody-drug conjugates. For Non-small cell lung cancer, there are different types of ADCs now under development, and this is, of course, not a comprehensive figure, but I think it nicely depicts the most important ones: HER2, HER3, TROP2, CEACAM5. We have a negative phase 2/3 study there, so I want to go into detail with CEACAM5 for now, CMET, and also a B7H3. I try to cover the most of those targets briefly, and perhaps we have a bit of time to discuss it. But starting, I think, with the most famous one, or the most who was the first, because it's not only, as you know, developed in non-small cell lung cancer, but mainly also in breast cancer, and of course also gastric cancer and others. Trastuzumab deruxtecan, a HER2 targeting antibody, deruxtecan as the payload, binds to HER2 and gives the effects I've already mentioned before. Regarding the trials we have in non-small cell lung cancer for now, I want to point out that the DESTINY-Lung2 study, which required patients to have metastatic HER2 mutated non-small cell lung cancer. So this is not overexpressing non-small cell lung cancer, but HER2 mutated non-small cell lung cancer after one prior line of anti-cancer therapy, including platinum-based chemotherapy. 152 patients were randomized, and they were randomized to 2 different doses of trastuzumab deruxtecan. Primary endpoint was overall response rate. And as you can see here, in the upper part of this slide, the median progression-free survival is quite comparable between the 2 doses, with about 10 to 12.9 months in 50 patients. Also, the overall survival, there's not so much of a difference regarding those 2 doses in this setting. And in the lower part of this slide, we can also see the response rate. And again, about 50%, half of the patients do have a response, so it's quite comparable. But, and I think this is the most important learning from this slide, the safety profile is different, and might not be that surprising that the lower dose is better tolerable. There have been those adverse events we know about trastuzumab deruxtecan from blood count changes, neutropenia, fatigue, and of course, most importantly, there is a risk of interstitial lung disease, and which again was much lower in the lower dose, and so this dose is the preferred one, and this is the one which is selected. But of course, there is not only HER2 mutated non-small cell lung cancer. What about the patients with HER2 overexpression? There were the DESTINY-Lung1 trial, and were recently presented at in the San Diego's WCLC meeting. DESTINY-Lung03 study looked at those patients, and in the upper part of the slide you can see that the response rates are a bit lower, with around 30%, to compare what we see in HER2 mutated non-small cell lung cancer. Quite similar response rates, about 40%, were reported in DESTINY-Lung03. So why is that? It's a good question. So I think in particular for non-small cell lung cancer, there is not this tight association with HER2 or amplification to and HER2 overexpression, so which is mainly the case, or also the case in breast cancer. So this might contribute to this difference. Another target, another class of antibodies, TROP2, which is investigated with different types of anti-TROP2 ADCs, most prominently sacituzumab govitecan, drug antibody rate H21, and dapodopamab deruxtecan. On the right-hand side, you can see here there is an association between TROP2 expression and survival, most importantly in adenocarcinomas, which is depicted on the right-hand side. So the red line are patients who have high TROP2 expression, and obviously they are doing worse. TROPION-Lung1 study investigated Dato-DXd versus docetaxel in patients with or without genomic alterations after the failure of approved first-line drugs. So I think it's a fair comparison, randomized 1-to-1, PFS and OS, the primary endpoints. And as you can see here in the upper part of this study, of this slide, the trial was in fact positive, but the efficacy was much more prominent in non-squamous cell tumors compared to squamous cell carcinoma, where there is hardly any activity. Also, this is also true regarding response rate is higher. Unfortunately, overall survival was not that different in this study. As far as I know, also in Europe, but and also in the United States, TROPION-2 is approved, about to be approved in this setting based on this TROPION-Lung1 trial. Toxicity is, in my opinion, quite manageable, stomatitis, blood count changes. On the right-hand side, and I think this is a very interesting analysis, we are, I think, in fact, lacking a biomarker. And what they presented at the meeting in San Diego showed that if you look at the membrane versus cytoplasmic expression of TROP2 and make a ratio out of it, you can identify patients who are benefiting from Dato-DXd here, which is depicted here. And docetaxel for docetaxel, it's not a biomarker at all. Couple of combination trials are ongoing. Particular in combination with in the first-line setting, platinum, durvalumab with Dato-DXd, the AVANZAR trial, but also with pembrolizumab, the combination trial ongoing so far. We just have phase 2 studies, study results. Toxicity might be a concern, but I think we have to wait for the phase 3 trials and the outcomes. For SG, sacituzumab govitecan, the EVOKE-1 trial in the lower part of this slide was mainly negative, unfortunately, so SG will not be an option versus docetaxel in the second line. In the upper part of this slide, study EVOKE-2, phase 2 study, again in combination with pembrolizumab. Results are encouraging regarding response rate and PFS, but still, I don't think it's ready. It's ready for clinical use, of course, and we don't have an approval. So let's move to HER3. HER3 is overexpressed in 83% of the non-small cell lung cancer patients. Again, we have an ADC, which is, in my opinion, quite far into the development. Patritumab deruxtecan, it's always difficult to pronounce those ADCs. So an anti-HER3 antibody, quite a similar concept to what I've just told you. We have here the HERTHENA study, and importantly, in those patients were EGFR mutated. Quite interestingly, HER2 is more overexpressed in EGFR mutated non-small cell lung cancer patients compared to EGFR wild-type patients. So that's why I think patritumab is mainly developed in EGFR mutated non-small cell lung cancer patients. So far, single-arm study, and we can see a response rate around 30%, so it's definitely active. In EGFR mutated patients who had already received prior therapy. At the bottom of the slide, you can see that it works irrespectively what kind of resistance mechanism there is, what type of EGFR mutations there are. There are a bit of associations, but in fact, it's more or less active. Regarding the side effect profile, in my opinion, and also in the trials we are currently doing, this is quite well manageable. Hematological toxicities occur, but there is nothing really to worry about. And very recently, we have already seen a press release from Merck that obviously the HERTHENA-Lung2 study is positive, which is a phase 3 study in this setting. So perhaps this will give us an additional standard of care in this setting, but of course we are waiting for the results. What we did, and this is still a bit unpublished data. We looked at what about patients with active brain metastasis, and also what about patients with leptomeningeal disease. So we have the Tuxedo 3 trial, which is an investigator-initiated study, an international study, and the cohorts are fully recruited now, so 20 patients per cohort. One cohort was about breast cancer, so I don't want to talk about this now. So I think it's really important that we allowed patients with active brain metastases, and those patients could also be symptomatic. Yeah, we do not only focus on patients with asymptomatic active brain metastases, or in fact patients who are progressing on after previous therapy. And in the upper part of this slide you can see an example, a case, a 70-year-old female patient with adenocarcinoma, no driver mutations in there. After chemo IO and docetaxel, she developed a leptomeningeal disease. So usually this is a very poor prognostic factor, leptomeningeal disease in non-small cell lung cancer, and hopefully you can see that there is a response in this patient, and the patient is doing still on trial. Of course, we do not know how long this is going to work. And in the lower part of this a slide, you can see a different patient. That's a 62-year-old female patient, again with adenocarcinoma. She participated in another clinical trial with a TIGIT antibody plus pembrolizumab, but had a progression plus platinum-based therapy. And again, she had new active brain metastasis, and treated with patritumab deruxtecan. Also here we saw a response. So if we look at in this cohort, we have about a response rate around 30 to 40%, so which is quite similar what has been published in for extracranial disease, and hopefully we can publish this study soon. Finally, c-Met. Targeting antibody telisotuzumab vedotin, again a target which is more or less common in non-small cell lung cancer, but most importantly we have a biomarker here, c-Met expression. The Luminosity trial had a look into that, comparing all type of patients, but was closed for EGFR mutated and squamous cell carcinoma patients. So in development there are still EGFR wild type patients, and what we saw at this year's ASCO meeting, a response rate around 34% in c-Met high patients, and a response rate about 22.9% in c-Met intermediate patients. So far promising, but still we don't have a phase 3 trial. Giving you in my last couple of minutes a bit of a perspective, what's about the future. Well, why not combining the best of two worlds, thinking also of immunotherapy? There has been a new study presented at the ESMO meeting from an ADC targeting an immune checkpoint, B7H3. On the left-hand side, you can see the potential mechanism of action. It's not 100% clear and identified what's the ligand and how it really works regarding the immune suppressive effects of a B7H3. In fact, it's an immune checkpoint, and this novel antibody, which doesn't have a name, but it's called YL201, has been studied in a phase 2 study, not only in non-small cell lung cancer, but also nasopharyngeal carcinoma, small cell lung cancer. And as you can see here, we have encouraging response rates in the bottom line here in this slide, around 30%, again in particular in adenocarcinoma. So not so much in squamous cell carcinoma, but regarding toxicity, this was well manageable, and mainly hematological toxicities occurred. So I think it's a very interesting observation that a couple of patients respond in non-squamous cell carcinoma, but obviously squamous cell carcinoma patients are different, and perhaps the payload really matters. Perhaps it's not only about the target, but perhaps the payload is also something which we should think of, which might be important, despite those are very cytotoxic drugs. But outside of the ADC story. I don't think we would just give the very same chemotherapy, and we don't do it, the very same chemotherapy combinations for non-squamous and squamous cell carcinomas. Toxicity is something which is important to think of. There are two types of toxicities for ADCs. There is off-target of tumor toxicity, mainly caused by the payload, and there is on-target of tumor toxicity, mainly caused by the target. So think of cardiotoxicity of HER2 antibodies or stomatitis of TROP2 antibodies, which is mainly caused by on-target of tumor toxicity. I don't want to go into detail for the sake of time. I think I have just 1 minute left, and this will be enough for my final 2 slides. ADC resistance is definitely an issue there, but a lot of ideas how resistance occurs: target antigen degradation, inadequate intracellular transport, mutations regarding the payload target. So this is definitely something which has to be addressed. And an open question is also what's the optimal sequence once we have multiple ADCs approved. What do we do if a patient has resistance? Does it make sense to give an antibody with a different target but the very same payload? On the other hand, does it make sense to give an ADC with the very same target but a different payload? So it's an open question. The sequencing, it will be interesting to do. For the future, I think there are not only there are different types of ADCs are going to develop, so dual payload ADCs combining different types of cytotoxic substances, but also immune stimulating ADCs or even radionuclide conjugated ADCs. And this is promised my final slide. Regarding the perspectives, I would not say that there is only antibody drug conjugates or antibody conjugates, because we can conjugate now a lot of stuff together, such as antibody cell conjugates or virus-like drug conjugates. So using a viral vector and a cytotoxic payload to do that. And there's lots of research ongoing, and this is really an emerging topic, and I think time is up.
Thank you so much for an excellent talk. This was really interesting. And we're opening the floor for 1 or 2 questions. Dr. Hassan. We can hear you.
Okay, so thank you.
You're always asking the most difficult questions.
He does.
So the Dato-DXd, obviously there was a lot of press about it, but at the end of the day, there is some PFS advantage over docetaxel, which is our standard for many, many years in second line. And what I heard from many experts discussing this, that they are disappointed with the result, that this is not really what they were hoping for, and there was no signal of survival advantage. Is that what your conclusion?
I think
at least as a single agent in second line.
I think you're absolutely right, and that's what we discussed a bit yesterday also, and I mentioned yesterday as well. In particular, in non-small cell lung cancer, we have a lot of trials now with a pure PFS benefit, but without an OS benefit, and then the discussion comes into crossover and subsequent therapies, and yeah, it's something I was a bit disappointed as well. I don't know if there is a PFS benefit. Yeah, we also accepted PFS benefit only in targeted therapies. Just think also of sotorasib, which also is just superior regarding PFS over docetaxel in the CodeBreak trial. So yes, but I totally agree. This is not something I want to see. Finally, I want to see an OS benefit.
I know you were talking mostly ADCs, but what do you think the future of the bispecific? You know, we have already won the evonescimab, I guess, which is the anti-VEGF combination.
From the Harmony trial.
The Harmony trial. There's so many Harmony, actually, so we may see more going in first line. It is Chinese, drug, but obviously in the US, of course, they are going to take it with a grain of salt. They have to repeat everything. But what do you think the future of that drug?
I think it's a very interesting technology to have those bispecifics, and of course it makes sense. I'm not quite sure what the difference is regarding this compound. For example, if you combine a PD-L1 and then VEGFR targeting antibody, why this should be so much better now? Yeah, and is there any immune stimulating immune modulation ongoing, which might be the case? The technology is, I think, important also for bridging, for example, two types of cells, which also we can see in lung cancer, those T-cell engagers. I think regarding this is a very interesting and important technology to have. Yeah. Thank you.
Thank you so much. Thank you. And next is the MDT case discussion. I want to invite Dr. Saeed Rafi, Dr. Amin, and Dr. Rana to the panelists. Hi, Saeed. How are you? Good to see you too. I don't know how are you doing. So,
so I think, for this session, Dr. Dina and Dr. Amin, they're going to present a case, is that right? And then I think, me and Dr. Rana, we're going to sit there and watch. Is that what we do? Okay, I think, this is the summary.
Thank you, Saeed. So I was asked to present a case, and Dr. Hassan is not here. So I gave him a very nice case with a complete remission, and then he told me, then what's the point? So it was a very nice case. Since we just talked about the ADC, it was a complete remission on RBB2 mutation on Enhertu. And then Dr. Hassan Ghaffar said, what is the point? So that's why I put the slides as black, and I'm going to give a very complicated case. So this is a 58 years old male patient. He's Iraqi national. He's a heavy smoker with a background history of hypertension. He presented this Ramadan, it was April, with severe cough and stridor. Went to a private facility. They did for him a high-resolution CT scan, which showed the soft tissue density in the right upper lobe of the lung. Speculated margin, satellite lesion, interstitial thickening, and some sort of, they're saying lymphangitis, but you'll see the scans not that much. And he had a query lesion in the dorsal vertebrae. He underwent a CT guided biopsy in April and came back as a moderately differentiated adenocarcinoma. A baseline MRI brain, there were no brain metastases. So he came to our hospital in May, again complaining of cough, attacks of stridor, but the guy his performance status was almost 1. He was moving around and walking and everything. So we repeated all his investigations, and these are his baseline scans. As you can see, the tumor burden is not that much high. We have this tumor lesion which is there in the lung. We have mediastinal lymph nodes were positive. We have, yes, this metastasis in the spine. So slides were reviewed, and they confirmed that it was a moderate differentiated adenocarcinoma. The immunohistochemistry was positive for CK7, TTF1, and napsin, confirming this is a lung origin. And we sent him for molecular profiling and foundation test. And voila, we have everything on board. I love when I find this from a foundation test. We have things which are significant and things which are not significant. So to start with, there were no targetable mutation, being a almost 60 years old male with a long history of smoking. All these mutations were no reportable alterations. They were all negative. But what was interesting was he was MSI high with a tumor mutation burden of 22. And in addition to that, he had a KEAP1 and an STK11 mutation. And in addition to that, another non-targetable mutation, he was a BRCA mutation. But we know quite well that the BRCA mutant, they respond well to platinum-based chemotherapy. So this was his foundation one, and his PD-L1, I did not put a PD-L1, was 17%. So molecular targeting, no targetable mutation, MSI high, PD-L1 17%, performance status we're talking about 0 to 1, but he started to become more dystonic, although the disease burden was not that high, and a very mild hemoptysis. What are the options of the treatment? Shall we start him on a carboplatin, paclitaxel, beva, and atezo? Being an MSI high alone, shall we start him on a pembro single agent? Being again an MSI high, can we start him on an EV, EP, and chemotherapy because he's a BRCA mutant as per the Checkmate 9LA? Or since you have an STK and KEEP, we have some data coming from this Poseidon about the Trimi-Durva chemotherapy combination. Any voting?
Would you like Dr. Amin to give a comment on that?
So as the patient is symptomatic, the patient has MSI high, but he's symptomatic, he has hemoptysis. So I don't think we have the privilege of time of allowing just immune therapy alone. So I think I would go with the Poseidon regimen.
Okay, we had lessons from the Poseidon. Poseidon had clearly looked at the STK11 and the KEAP1 mutation, and they considered them to be chemo-refractory, considered them as being a cold microenvironment with little or no benefit from the immune checkpoint inhibitors alone. So yes, I agree, we add chemotherapy. So, but we did not start him, honestly, on the Poseidon. We started him in an EP-NIVU, trying to cover both. He is an MSI high, so we said to give him a doublet IO and a cisplatin and pemetrexed. We gave him 3 cycles, and then in July 2024, he came with a PE. And during his admission, he complained of severe back pain radiating to the leg. I was not going to scan him during that time, but since he was complaining, I did for him an MRI spine, and you can see down there the lesion with impeachment at the spinal cord, and found out even that there were more metastatic deposits in the rest of the spine, which were not then on the previous PET scan. So I took one step forward and I scanned him earlier, and these are the scans. The lung lesion stays the same. Mediastinal lymph nodes are increasing. I put the images for the other new bony metastasis. Pelvis was studied, spine was studied. Patient has progressed in no time, although he had a double immune checkpoint inhibitor, a cisplatin, and doublet chemotherapy. So doublet IO, doublet chemotherapy, and of course I referred him for radiation to the spine, and I know I'm going to put myself on fire here. My point of view that in the real world, yeah, we know there is no data to say an immune checkpoint inhibitor following an immune checkpoint inhibitor, but we have nothing to lose. The guy has progressed on everything, quadruplet therapy, and he progressed. So I said, I'm going to give again, previously received cisplatin, I'm going to give him another platinum, carboplatin, and Taxol, and I put him on atezolizumab. He received 3 cycles from August till end of September, and yet there was no response, and he passed away actually last week, 10 days ago, with a respiratory failure. So my point of view, I had everything in the foundation one, yet we were not able to help the patient. We give him quadruplet therapy, then we give him another combination of another 3 drugs. I took away the Avastin because of his PE and his mild hemoptysis, yet I can see with this type of tumors, I was not able to help him at all. So if anyone can give me their thoughts about how to manage such cases.
Thank you. Very interesting case. Obviously, I would have thought that perhaps after this you could have added bevacizumab, but exactly like you say, this was not possible because of the PE. Actually, I had one patient before who the same thing progressed on the first line of immunotherapy. We switched to the quadruple therapy, complete resolution of all disease. So that in fact sometimes worked. But you know, this is obviously was not possible in this case. Hassan, I think you're on fire. You want to say something?
Well, no, as Dr. Dina answered herself, certainly there is absolutely no data that any checkpoint inhibitor is going to work after a doublet. So atezo, I don't think you're going to get much from atezo. If anything, would be, like you said, maybe combination with anti-VEGF. Now, if the patient is on anticoagulation, by the way, I don't know if he was on anticoagulation.
Yeah, he was.
Yeah, so it's okay to use bevacizumab. Is not like completely contraindicated if you are on blood thinner already. In fact, the initial trial was Bev in lung cancer. Some of them were on anticoagulation, and it was not a reason not to give
hemoptysis. He was having hemoptysis. I kept him even admitted.
Well, it depends on hemoptysis. Again, it's the volume of hemoptysis that matters. If we're talking about streak of blood, that doesn't stop me, because this is life or death situation. You don't have anything to lose. If it's mild hemoptysis, again, the initial data was bevacizumab. You really have to have more than a tablespoonful of blood to be contraindicated. A little bit of hemoptysis is not. And again, if you look at his scan, it is really not a bulky disease going into large vessels.
Absolutely no.
Okay, yes, I think, Sonia has already raised her hand. So.
No, use the...
Okay, thank you very much for this really interesting case, but I would love to know, when the patient progressed, did we try to take another biopsy, or at least liquid biopsy? Because there is some patient who will change eventually the biology of the tumor. And this is heterogeneous disease. Sometimes eventually they transform to small cell.
As you can see, Sonia, the progression of the patient, patient presented Ramadan time, it was May. This all happened from actually end of April till September. And during the middle of the time, I sent him foundation, and this foundation was sent twice, tissue foundation and liquid foundation ctDNA, because he was totally covered. So both were sent, and this came almost beginning of June. So I don't assume there was, I agree with you, when patient at least respond for quite some time and then he progresses, I agree with you that we can send another biopsy, but for him, both were sent in, we're talking about less than 3-4 months. The idea of resending was not feasible, and time was quite short. We would try to push and give him treatment as soon as we can.
No KRAS mutation, nothing?
No, as you can see, it was STK and KEAP1, but there was no KRAS, unfortunately.
So why not the Poseidon study that showed really very good response with this kind of mutations?
With what?
Poseidon trial.
Because he was MSI, I agree with you, but he was an MSI high. He was given an anti-CTLA and anti-PD-L1. Yeah, he was given both. Yeah.
Professor Ross.
We can hear you.
Success stories. So thank you very much for presenting a case. Thank you very much for your presentation. I liked it very much because usually we are used to presentation of success stories.
This is the idea of having pioneers here. This is the idea of discussing in a form of like a tumor board.
This is why I'm praising you for this presentation. And I would like to ask, because usually when we have MSI high, we think that maybe sometimes our patients would have a pseudo-progression. Did you think at what point, after 2 only sessions of immunotherapy, that your patient might have been having a pseudo-progression? And if yes, would it have changed your way of looking into this patient and forget that we lost him afterwards?
Yeah, of course. I agree with you if the progression was symptomatic, if in the lungs, but as I put there, he had severe back pain, and then the MRI had showed we have an encroachment on the spinal cord, which was not there. I don't think this was a pseudo-progression, and new metastases, including in the sternum, new bony metastases, not only in the lung. The pelvis was studied. So, and even though he was still continued on some sort of a platinum and another immune checkpoint inhibitor, but...
Were there last comment, were there in his mutations, because I didn't have the chance to look at them directly, anything which might have told us that he could respond to a PARP inhibitor? I didn't
BRCA1.
BRCA1 was
Yes,
positive.
BRCA1 mutation.
Okay.
He did not respond to platinum. We know quite well patients who are BRCA mutant, they will respond to platinum first.
I know, this is the cheapest PARP inhibitor in the world. I completely agree with you.
He was a BRCA mutant.
But would you have changed your mind maybe and add something more oriented for PARP?
Well,
Thank
that's
you.
why I did not remove the platinum. The discussion in our tumor board was to put him on a docetaxel, as we do in a second-line therapy. But that's why I didn't want to remove the platinum, and I insisted to add to the taxanes a platinum part because he's a BRCA mutant. Hopefully, he might have responded.
Very interesting case.
Well,
Thank you.
Very
Thank
interesting. And, you know, just a question for Dr. Rana. Obviously, we have seen in the past as well that sometimes if we do the radiation to oligoprogressive disease in the context of receiving immunotherapy at the same time, you may actually enhance the response to immunotherapy as well. We've seen it in the past in renal cell carcinoma patients that we've had together. So what do you think in this scenario? Would that be something that you would consider?
It's a very interesting evolving subject. I mean, this particular patient has perhaps poly-site progression, but yes, you are right. There are patients who are oligoprogressive, and radiotherapy for a very intense SBRT dose is used for two intentions. One, as you already know, that in lung cancer CURB trial was positive for oligoprogressive SBRT, but also at the same time, people on IO, there is in radiation oncology, there's a huge kind of interest in waking up the immune system again once it is going downhill on immunotherapy. And there are actually clinical studies in UK. We are doing the REARM trial for bladder cancer. Patients progressing on IO, you give them the SBRT to see whether they will bring them in response. And there are many other trials ongoing as well. So lung cancer is no exception. If there is a patient who has got a slowly growing disease which will give you time to do something, this patient did not give you time to do anything. But if there's something there which is giving time to something, you could just do SBRT to 1 or 2 safe lesions at an intense dose and see whether it will bring the back in response, yeah. But this one is a difficult one.
I mean, do you have a comment?
I just want to have a comment, and we'd like to hear from everyone. So having multiple mutations on the table, having BRCA, having MSI, and having STK, sometimes not a blessing. So sometimes having everything on the table might be like the reason for why this patient had an aggressive disease is the complexity of his molecular profile. So when you're using one regimen that you're sure it would be targeting one thing, there's maybe another clone that is not responding very well.
Well, thank you so much indeed, Dr. Dina. Highly appreciate it. Please, if you can join us. I mean, I think the next case presentation is Dr. Amin.
Assalamu alaikum. So thank you everyone for staying late even after lunch. So I'll have a very small presentation about the case for discussion. This will not be full of data, it will not be very informative, but rather would be an attempt to generate questions and conversations. So this is, as Dr. Marwan said, this is a success story. So this is a 65-year-old male patient that is a heavy smoker. He's known to have hypertension. He presented to his pulmonary physician for chronic cough, sputum production with very new mild hemoptysis and weight loss. First treated as COPD or bronchitis, first managed conservatively, and then he had to do a CT scan. So a CT scan showed a lesion that looked very malignant, in addition to some mediastinal lymph nodes. So the patient had to be seen by an oncologist. The patient, if you can see that the patient had his first CT scan around Christmas time, and then he had his biopsy in February. So first he was in denial, no, I don't have cancer, I don't need a biopsy. A biopsy will have my cancer spread if it is there. So this is the usual scenario. This is not the typical, very picked patient that we see in clinical trials. This is an actual patient we see in clinic. So the biopsy confirmed this is lung adenocarcinoma, the patient had a molecular profile. Actually, when the patient was going back and forth, he gave us time to do the molecular testing before starting his treatment. So he had this molecular profile. It did not show anything except for the STK11. He did not show any targetable mutation that could be used in the neoadjuvant setting. The patient had a PET scan showing the highly FDG-avid lesion in the chest in addition to mediastinal lymph nodes. So this was his lesion, and these were his lymph nodes. So the PET scan showed the lesion. It only showed some hilar and subcarinal lymph node. The patient had no other sites of metastasis. So the patient had to go through the arguments of the MDTs. It was really complex to have an answer and have a plan for this patient. He's a COPDer. He has a locally advanced disease. He has possibility of N2 disease. Some patients might be deemed as unresectable because of subcarinal lymph nodes. So really, there are multiple issues that could complicate him. We need proper staging. We need to understand his nodal status. His pulmonary function tests were better. He had some poor pulmonary function tests. His molecular profile was negative, and we were just asking the question, could this be resectable? So we had this huge argument whether to give him just definitive chemoradiation or to start neoadjuvant treatment. We were impressed by that time from the data of neoadjuvant immune therapy, so we wished to give him a trial of neoadjuvant treatment. So as per guidelines, we should utilize all the tools to make sure that the staging is done correctly. And this is why the patient had an EBUS. And during EBUS, we found that the lymph nodes that are in the mediastinum are very malignant-like looking lymph nodes. But unfortunately, when we took a biopsy, it was sent to pathology. We couldn't find any evidence of malignant cells. It was just full of inflammation and fibrosis. Then we had to, look again at the PET scan and fight again over the nodal status. But finally, the patient was staged as T3 and 2, knowing that the biopsy from the lymph nodes was negative. The patient was eligible for neoadjuvant immune therapy plus chemotherapy combination. It was started in May, and then he had 3 cycles of carboplatin, methotrexate, nivolumab as per Checkmate 816 trial. And then the patient had a follow-up PET scan. You can see the difference between before the treatment and after the treatment, and then you can see the disappearance of the lymph nodes that were highly active in the mediastinum. And this, if we go back, confirms our initial suspicion that these lymph nodes may be positive. So the patient had a PET scan, another PET scan in June that showed very good response, decrease in the size, and huge difference in the activity of the primary mass and the lymph nodes. So everyone was happy. The patient is brought back to the tumor board and thrown back to the chest surgeon. Actually, at that time, we did pulmonary function test again, and I don't know why the patient had an improvement in his pulmonary function test. Probably because of the decrease in the size of the tumor, but the patient had a little bit less smoking during the treatment time, and probably he was using better his inhalers than before. So the patient was cleared, and then he had his surgery done. So he had, they first attempted a robot-assisted initial surgery, but it was abandoned because it was too difficult to do so. The patient had thoracotomy, lobectomy, wedge resection, and lymphadenectomy. It was very difficult after the surgery. The surgeon called us that I don't know what will the pathology hold because it was a very tough tumor to resect. He said every single lymph node was just adherent to the surrounding tissues. It was very difficult and tough to get these lymph nodes out. So luckily enough, the histopathology shows complete response to treatment. So the patient did not have any evidence of any malignant cell after the treatment. So why we were happy, because if you look at the data, we know that the data presented very well by Dr. Ola, that these patients who receive neoadjuvant immune therapy and chemotherapy and attain a pathology complete response, they have the best event-free survival outcomes. We know this from the update of the Checkmate 418 study. So the question that is now being asked, does this patient need more treatment? We know that from 2 studies in the perioperative setting that one study included patients who received 6 months of additional nivolumab, and another study who included 1 more year of nivolumab. So this is the question that I would like to raise at the end, and I would like to thank you.
Thank you. Thank you, Dr. So, Dr. Rana, would you go for neoadjuvant chemotherapy in this patient, or would you still advocate for chemoradiotherapy?
No, I think the standard treatment for N2 disease patients will be, at that point of time, could be concomitant chemoradiation straight up. But I agree that in the light of this old data and these markers which are beyond the scope of our conventional radiation oncology brain, I think this is a very good idea to just have that, because at the end of the day, there is a strong data and chemoradiation is always available as a backup. So I agree with that plan, which worked very well.
Important point in this discussion is not everything that is positive on PET is presumably is N2. As he proven, they tried to biopsy and they were negative. So reactive lymph nodes are very common in COPD patients. We see them even in patients without cancer. So the specificity of PET, unfortunately, even if you do PET and CT, etc., you are still not higher than 80% in the specificity. So do not, because if you assume, okay, this is N2 disease, just send him for chemoradiation, I'm sure if you are able to resect the tumor, it's much better than leaving the tumor, even after chemoradiation and durvalumab alapacific, because to me, if somebody became resectable, as in your case, you gave him the best chance to have long-term survival. As far as the second question you raised, we don't know. We will see the final results of the NIVO, the 770, but you know, they did sort of a simulation and trying to match between the two trials, and there is a benefit of continuation of immunotherapy. Again, this is not a prospective randomized. So at this point, if you can give it, like you said, for 6 months, and the side effect is on the low side, I personally would give it until we see the final results.
Said, would you give him adjuvant?
Pardon?
Would you give him adjuvant?
Yeah, I think, you know, to be honest, again, if you remember, we had an ODAC a couple of months ago, and they questioned whether the design of these clinical trials, they need to look at the longer term data before we agree that all the patients, you know, you need to have the data from the adjuvant setting to make sure that your maintenance immune checkpoint inhibitor are also valid. Currently, we do not have that data, you know, what we have from the current data. And yes, I think, you know, based on that, we will continue with the adjuvant therapy.
If a patient has proven pathologic complete response, would there be any added benefit of continuation nivolumab?
To be honest, you can ask that question of 64% of patients who achieve PCR on Keynote 522, whether they would require to continue with pembrolizumab. We still do not have that data, unfortunately.
I think the harder question, let's say he didn't have a good response, are you going to throw him back to chemoradiation and durvalumab alapacific? You know, that will be the other question. If patients do not have a good response and they are deemed not really resectable, would you go back to radiation?
Yeah, I think that would have been the backup option. This is what I said before, that if you are watching the patient closely, that will always be a backup option. This is why I'm very encouraged by these kind of pre-treatment neoadjuvant setting trial.
If I may add a comment also, it's nice also to hear a success story. So very good for the success story. I have two comments. First comments come from basic science. If you ask me, for me, on a personal basis, I am giving a neoadjuvant treatment with immunotherapy. We know that immunotherapy in the neoadjuvant setting works in a completely different way than in a metastatic situation. So if I'm giving an immunotherapy as a neoadjuvant, without data, I would say, let's give it in the adjuvant situation, because it would be the continuity of the activity of your immunotherapy and what you have gained with your immunotherapy before the surgery. And we are waiting for the data. Let's wait for the data. Let's hope that the data will be positive. It is positive in other situations. We don't still have it in lung. The second comment, and I like the comments of Dr. Hassan because one comment will bring us to another comment. So the second comment, what to do if you are not in a pathologic complete response. We need to escalate. We need to do something. We will not stay like this. We don't know what to do yet, but we need to do something, because if we don't do something for these patients who are not in a pathologic complete response, we have learned it from other pathologies. They will metastasize and they will have a recurrence very rapidly. So we need to do something.
Well,
I don't know,
Dr. Marwan,
in
Checkmate 816, patients who did not attain a pathologic complete response were allowed up to 4 cycles of additional chemotherapy.
Great.
So this might be a very good option
Great.
for patients who
Great.
did not completely respond on neoadjuvant. But I mean, if we used neoadjuvant chemo plus immuno, would there be a chance for another chemo and immuno in the adjuvant setting? I think this question is also something we don't know.
In breast cancer, yes. In ovarian cancer, we have the response, yes. We don't have it in lung, but most probably yes, and most probably you need to change it. I think so, on a personal basis.
Yeah, and there are ongoing trials with even ADCs, so talking about going to the next level, so this is where maybe ADCs may have some value to change the mechanism of, because if you're giving the same thing, I'm not sure if that's the answer. You need to do something extra.
Perfect. Thank you so much indeed, everybody. Thank you, Dr. Dina. Thank you, Dr. Amin and Dr. Rana and everybody. Thank you so much. I think the next session is basically advancing precision oncology, unraveling oncohelix. I think that is moderated by our dear colleague, Dr. Hassan Jaffer.
Really, I'm delighted to present my colleague and friend, Dr. Pinaki Pose. He's an MD and co-founder of the Executive Vice President of Oncohelix. We know that Oncohelix, they are doing all the spectrum of molecular testing. For the first time, they are coming to UAE, so he will explore the facility and the possibility of doing all these NGS, whether it's a circulating blood test or it is on the tissue. So probably we'll have the opportunity to have it next door with the Oncohelix. So please, welcome.
Good evening, everybody, and thank you, Dr. Jaffer, for the kind introduction, and also Dr. Humaid, who has been a large supporter of us. I've got 10 minutes, and I don't want to be between your coffee and the evening, and I would like to assure you that I belong to the Henry VIII School of Public Speaking. As Henry VIII said to his wife, I won't keep you long. So hopefully, with that, advancing precision oncology in this region. And I would like to talk about what our capabilities are in this space and what we have been doing, bringing our experience from Canada to the UAE and establishing a lab here from scratch and providing all testing within the UAE region, repatriating all the tests. That's our objective, so that no data, no samples get outside the UAE region and the MENA region. So, as you know, I don't need to educate this audience about oncology, but the global oncology landscape is evolving. And if you look at the data, the future data, 2040 is when 47% more cancer patients will be seen, hopefully, by oncologists. Also, in the UAE specifically, it will be almost 50% more, just because of the aging population, as well as because of the increase in population growth. And what are the challenges? We face challenges of late diagnosis, where if you detect cancer in the early stages, there's a significantly improved prognosis. We all know that. If you detect cancer at late stage, there's complications associated with that. Then there are resistance to therapies, and my lab and others, we are trying to understand what kind of therapies to use in this setting, where resistance has kicked in, like in osimertinib in lung cancer, where there's known mechanisms of resistance. There are other cases where mechanisms of resistance are not known, so where comprehensive genomic profiling, whole genome sequencing, all of these things are becoming more and more prevalent in the cancer population. So, So as oncology is evolving, we are now trying to bring precise treatments to patients, and genomics has basically been in the forefront of this whole movement. Only 25% of patients respond to initial therapy. That's what we know. But so emphasizing the need of tailored therapies and approaches associated with it is becoming more and more important. The information about targetable genomic biomarkers, and this fraction can be improved with that, in that regard. And this is sort of a circus plot which I'm showing, where we are showing the drugs that have been approved from 2010 almost to 2024. And as you can see, a vast majority of the drugs, almost 50%, are targeted therapies, and the rest, around 40%, are biologics. So these all require companion diagnostics that can be only achieved by genomics or molecular profiling. So our experience, what do we bring to the table? So OncoHelix is a Canadian-based company that was co-founded in Calgary. And it's basically, we are academics. I'm a professor at the University of Calgary. My colleagues are also academics at the University of Calgary. And we bring our experience from the lab, a brain to barn model, where we develop new testing in the lab and bring that onto clinical testing with in an accredited fashion. And also we are applying those treatments or tests to the patient so that they can get the treatments that they really require. So here, in collaboration with Burjeel Holdings, we have a joint venture with Burjeel Holdings, and we have a lab within the Burjeel BMC facility in Abu Dhabi, which has started doing all genomic tests, all single gene tests. And today I'm going to tell you what kind of tests we are doing and what kind of populations we are trying to affect. So the goal has always been that innovation in cutting-edge diagnostics. So we want to innovate in this space, bring in the science and tie it up with the clinical data that we have, and try to bring new tests to our patients. And our main goal is tie translational research to clinical diagnostics. And also our goal is that we don't send any patient samples outside the UAE for testing, so that the samples as well as data stays here. And when oncologists refer patients to us, we don't only make available the results, that is the report, but also the raw data associated, because it's a data mine, it's a huge gold mine of data that is available from these patients that can be used for further research and to affect patients who are future patients. So there are 3 modules of precision oncology in the lab, in the OncoHelix co-lab, which is molecular diagnostics, cellular immunology, and transplant diagnostics. Today, I'll mainly talk about molecular diagnostics and a little bit about cellular diagnostics, which is cellular immunology, which is relevant to the cancer population. So this is, again, molecular diagnostics has 3 main arms: molecular oncology testing. So we talk about genomic testing, we talk about single gene tests here. Then there is genetic disease detection, especially syndromes, which are associated with predisposition to cancer, like Li-Fraumeni syndrome and others. And then there are also residual disease monitoring, minimal residual disease monitoring. This is done by liquid biopsy and other such techniques. And this is all based on under the umbrella of molecular diagnostics. Then there is, why are we using molecular diagnostics? We are using molecular diagnostics to aid cancer diagnosis. We are doing that to help cancer risk stratification, and also to identify novel targeted therapies. This is sort of the main raison d'etre, if you will, that we can offer new novel therapies to our cancer patients. So we have a tiered approach in OncoHelix Collab, where we are offering single gene tests with a very effective turnaround time of around 5 business days. Then we move on to hotspot multi-gene panels, which are smaller panels that we offer, and these are cancer-specific panels. And then there are bigger panels, which are comprehensive genomic profiling panels. These can do all the way from SNVs to MSI, tumor mutation burden testing, unknown fusion testing, everything. So again, going into this a little bit more in detail. So single gene testing, these are fast turnaround time tests, variant specific RT-PCR based tests. Multi-gene panels are again NGS based tests. They are also cost effective, but they are cancer specific panels, so they are smaller panels. Comprehensive genomic profiling, on the other hand, are bigger panels, much bigger than 150 genes, and these provide a more comprehensive outlook of what the patient's cancer looks like, and gives you sort of an, not only that what can be targeted, but what can be other treatment resistant mechanisms that can be present in different cancer types that can be aided, that can aid in improving the treatment scenario for the patient. So these are our single gene tests. So you have got all the way from FLT3, which is in hematologic malignancies, to IDH1 and IDH2, that is in neuro-oncology. Used in neuro-oncology, we have also RNA-based tests for BCR-ABL. These are diagnostic tests for myeloproliferative disorders. PML-RARA is the same. And then you have got MSI, which is a standalone test that we can do for microsatellite instability. The turnaround time here is 5 to 7 days. Then there are multi-gene panels that we use. These are all the way from fusion panels, large fusion panel, which is around 507 genes, and you can do partner agnostic fusion. So it's not only the 507 genes that are present on this panel that we can detect fusions for, but all the other genes that are actually not maybe novel fusion partners of these 507 genes. Then there's the other small cancer-specific panels that you can see here. Which are the OH tumor panels, it's called. And then there's BRCA1, BRCA2, and Lynch syndrome panel, which is, again, a DNA-only panel from which is available. Then there are the cancer comprehensive genomic profile tests. This is OncoHelix 1, which is actually the foundation panel. So now in the UAE, in-house, we have the foundation panel available. The same foundation panel that was discussed in the previous session where the case discussion was done. We also have the 170 gene panel from Illumina, which is both DNA and RNA and can detect fusions from RNA. And we have liquid biopsy panel as well. So when you don't see anything in a solid in a tissue-based panel where you're looking at FFPE tissue, it might be because of tissue heterogeneity, because you don't know where the sample is being taken from in the tumor. So there is a lot of tissue heterogeneity there. So we are using the liquid biopsy panel. This is one of the most famous liquid biopsy panels from Memorial Sloan Kettering, 149 genes, pan-cancer. And the good thing about this panel is also that we are also using the genomic DNA together with the circulating tumor DNA. So we will also provide you the germline mutations associated with this panel, like BRCA1, BRCA2, and ATM might be relevant mutations here. We also have the cellular immunology panel, so cancer detection and monitoring. I'll not go into the details of this because the only relevant test here is for cancer detection and monitoring. Here you have got diagnosis and screening. We have 22 to 48 gene multicolor flow cytometry panels, which are used in leukemia, lymphoma, multiple myeloma, and other hematologic malignancies. And then we have multicolor flow cytometry for MRD, or minimal residual disease detection, in BALL and multiple myeloma. So my time's up, so I just wanted to thank a bunch of people, especially Dr. Jaffer and Dr. Humaid, and also Burjil Holdings, who gave us the opportunity to bring all our innovative tests here in the UAE and make it available to the population here. We look for your support so that we can apply this to more and more patients and keep all the data and our patient samples within the UAE and hopefully the MENA region. Thank you very much.
Thank you very much. We can have probably 1 or 2 questions. Dr.
Yes.
Marwan.
Thank you. Thank you very much for this nice presentation. We as oncologists, our challenge is usually to treat metastatic and advanced disease. In early disease, we nearly know nowadays how to treat them, including their characterization on the molecular basis. One of my young oncologists with Fabrice André at Gustave Roussy has written recently an article and an editorial in Nature. I would just read for you one sentence and would like to know what your company is doing according to this sentence. So the conclusion of the article is, classifying cancers according to their molecular characteristics would expedite the access of millions of people to effective treatments. It's also the first step towards precision oncology and a deeper biological understanding of how cancer works. So when you don't have a known targetable mutation, what are you offering for us, medical oncology, with the support of your AI, with all these tests, in order to help us to treat our patient? Because when I ask for a test, I want a reward for the patient, not for me. So I want an answer from the test.
Absolutely.
So what are your practical answers in your test?
So I have to bring you to my research lab rather than my clinical lab.
Yes, no, because you are used to see the results, and the results, you know, are this and this and this and this, and you go to your MDT. We'll stay 1 hour in the MDT arguing between each other, and we don't have the answer.
This is the most critical questions, and you know that we developed a molecular tumor board. This gap has to be filled by somebody, and probably in future the AI. And this is why we are trying to merge probably another molecular tumor board, the advanced tumor board, whether from Canada or from other experts, to fill that gap, how we can translate this data rather than reading in between, because these are different tumor, different mutation, and you can have coexistence of 3 or 4 mutation. How can I probably combine treatment or sequence the treatment? This is a very critical question, especially if you go away from the standard, which is approved medication.
So one of the main things is when we give you a report, in a lot of cases, when we are in small or big panels, they're negative. They're small mutations that are present, but can't be targeted in a lot of cases. In those cases, I think it is important to look at that's where research comes in, I think. And there is no clear, straightforward answer currently, but with AI, with, more, when we do whole genome sequencing and stuff, that's what we do in the lab. And I talked about the brain to barn model, that essentially we are still working on that. We can only provide what we see in a panel in a clinical fashion. Absolutely. Yeah, absolutely. And that's why we provide a holistic report to you. And we are trying, we can only try. And as academicians, as clinicians, it's mainly our responsibility to patients. We are not businessmen, really. We are just trying to provide a service to patients, and that's what we are trying to bring here, and hopefully you will support us.
And this is probably the future of molecular tumor board. We have it for the last 3 months, but trying to develop it in a way to be very effective and practical, and this is where it will be open for probably all the UAE.
That was my next question. When is this going to be open?
It's already open. We are doing it.
So you are doing it locally,
here.
Right? The lab is local?
The lab is open. We are doing it here in the UAE.
Burjil,
in Burjil, yeah.
Right, but I'm asking what about the rest of the...
Send us your samples. That's what we are waiting for.
So, okay. Thank you.
Yeah. We are waiting for your samples. Yeah, the capability is here. Now it is for you to use it. That's what we are bringing. That's the... Yeah.
So by this, we finish this session. Thank you very much. Thank you. What is next?
Can you hear me? Yeah, okay, excellent. It is now 5:15. Some serious attrition. Thank you guys very much for staying this late. We will try and finish very, very quickly. So I just, before we finish with the last session, just a few words to say that we have the very first 100% dedicated palliative care conference in 2 weeks' time, on the 19th, 20th of Abu Dhabi. So look forward to seeing as many of you as possible. We have 3 sessions, presentations this afternoon, and we will do our best to keep to time, although we're extremely over time. So thank you guys very much for staying, and we'll just crack on in the interest of time.
Thank you. Good evening, everyone, and thank you for making it to the palliative care session. So we'll start with our first session with Dr. Booth. Okay. Dr. Christopher Booth is a professor of medical oncology and health service in Queen's University, Kingston, in Ontario. He's a professor of oncology and public health, and he holds Canada Research Chair in Population and Cancer Care. He directed the Division of Cancer Care and Epidemiology at Queen's Cancer Research Institute. And Dr. Booth specializes in gastrointestinal cancers, and his research focuses mainly on cancer care access, quality, and value globally. He published over 300 peer-reviewed papers in 2022, and he was awarded he received the Exceptional Healer Award for his compassionate care. Thank you, Dr. Booth, and the microphone is with you.
Hi, good afternoon. Thanks for the opportunity to join you. Sorry I could not be there in person. I'm going to talk about an emerging concept that I think all of us as clinicians have recognized, which is time toxicity in cancer care. I have no disclosures, I have no relationships with the pharmaceutical industry, but I have an important acknowledgement. A lot of the work I'm going to share has been done in partnership and collaboration with a good friend and colleague, Dr. Arjun Gupta, who is a rising star in our field, a junior medical oncologist at the University of Minnesota, who has led a lot of the work that I'm going to share with you today. So Henry Thoreau many years ago said the price of anything is the amount of life or time you exchange for it. And so this has, I think, significant implications for what we're going to talk about today. As we know, we have had substantial advances in our field over the last 10 or 20 years. We've heard about them in our conference over the last day or two. But I think we also need to recognize that we have some treatments that offer very small benefits. So this is a review of FDA approvals, 37 approvals with the average survival gain of 2.8 months. And we need to remember that survival gain is in the context of a clinical trial, and we know that these benefits and outcomes in routine practice are always attenuated. So certainly we've had treatments that improve survival in a very, very substantial way, but we also have some treatments that have very small survival benefits. This is a very typical curve that we'll see at some of our major international meetings. And the reality is this will get a lot of attention and might even land on the front page of newspapers, showing separation of the curve, a p-value with lots of zeros after it, which gets oncologists excited because we're very simple when it comes to statistics. But we often confuse statistical significance with clinical significance. So again, this would probably generate excitement and buzz at some of our meetings. Progression-free survival, statistically different, 5.7 months compared to 5.5 months in the control. But I think we need to recognize that's 0.2 of a month. So we're looking at about a difference of 6 days before the CT scan shows growth. And I think we need to really take a step back and think, is this why we went into oncology? Again, this treatment prolonged significantly progression-free survival, 13.93 months versus 9.46 months. In my lecture yesterday, you might have heard me outline a couple paradoxes in our field. And this is another one I've called the oncology decimal point paradox. The more decimals we use to report findings, I think the smaller and perhaps more meaningless they actually are. So we're now reporting survival gains down to the 0.1 month we've been doing for many years. That's 3 days. Adding a second decimal point means we're now starting to report it down to about 7 hours. And so I think we need to start thinking a little bit more clearly about what it is that we're after here. Because the central question, and again, this does not apply to many of the transformative treatments we do have, but for these marginal treatments, we have to ask ourselves, are the modest survival benefits of a treatment eroded and perhaps even exceeded by the time costs for patients and their families? If yes, we need to inform patients, not because I or any specific oncologist or group has the right answer for how patients should spend their time, but we need to inform patients because all of them will have different views on how they want to spend their time, especially when time is short in the last year of life. So I think the concept of time toxicity, we wrote this essay now about 3 years ago in JAMA Oncology, and it's really exploded in interest since that time. I don't think it's anything overly novel that we wrote about. I think we just kind of coined the phrase and drew attention to something that all of us as clinicians have recognized in our practice for many years. And I'm sure each of you have had that uncomfortable feeling on a Monday morning clinic when you ask your patient how their weekend was, and they tell you, oh, I decided to stay home and not travel to my sister's wedding because I didn't want to miss my appointment with you today and my treatment for my palliative chemotherapy. And I think all of us recognize that we could have very easily skipped or canceled that treatment, and they should have been attending these important life events. And I think that's really, the concept of time toxicity. So I'll just paraphrase from the essay here that was led by my former fellow, Adam Funditis. We wrote, time spent pursuing cancer treatment in waiting rooms, emergency rooms, and the chemotherapy unit is time that cannot be spent fishing, traveling, or visiting with loved ones. This trade-off becomes most pressing near the end of life when time is short and many treatments offer small benefits. So the concept here, if the lifespan is quite long and or the intervention has large benefits, then the relative trade-off of the time spent pursuing healthcare is probably considered very reasonable by most people. But it becomes most acute in the last year of life when time is short, every day is precious, and that also happens to be the time where most of our treatments have very small benefits. I also recognize this quote is very Canadian, recognizing that a lot of my patients and their families like to spend time fishing. I'm not sure if that's the case in Dubai, but you can well imagine other common pastimes that our patients are passionate about. And maybe fishing is popular in Dubai. My friends there can tell me. This is the follow-up essay we wrote in the Journal of Clinical Oncology, the time toxicity of cancer treatments. We recognize that we don't really talk about this in clinic. I think we do a very good job of reviewing side effects and risks of our treatments. I think we do perhaps a less good job, but we still acknowledge the relative benefits of treatments in clinic. But I don't really think we explain to people what their life is going to look like and how much time burden our treatments will be. But patients obviously want to know this. And I think that we might not discuss it because, first of all, we haven't really been trained in that paradigm to think about it, but also we don't have a lot of data from clinical trials that really tell us what is the time burden of our cancer treatments. And we've done some modeling, I'll show you an example in a moment, that for some treatments with small benefits, every added day of survival is offset by an extra day spent at the cancer clinic or in hospital. And I think, again, every patient will view this differently, but we need to at least measure what we call home days so that patients can make informed decisions about how they spend their time. So this is a model here. You can see that with no treatment, the patient would live for 120 days. With chemotherapy, they would live for 150 days. So although in a clinical trial that will be reported as a 1 month or 30-day survival gain, you can see that if you add up the number of days they spend at home versus in hospital, they actually have more time at home if they say no thank you to the chemotherapy. And again, I'm not proposing that one option is better than the other, but I think certain patients would choose one option versus the other, and we need to empower them with that information. And this is not just a theoretical construct. So the advanced cholangiocarcinoma trial that demonstrated FOLFOX being superior to standard of care in the second-line setting, the pivotal paper showed a gain of 30 days. And when we used the protocol to count up the number of extra days for treatment visits and investigations, it's also about 30 days. And that doesn't account for the days that are unmeasured, such as unplanned visits to the emergency room, et cetera. So it's pretty clear there, the added 30 days of survival in the trial is easily offset by 30 extra days either in hospital or waiting in the cancer clinic. And patients will, of course, have different views on that trade-off. I'm going to share some work now that Dr. Gupta and I have done mostly with his colleagues at University of Minnesota, but also with my colleagues here at Queen's University in Kingston, Canada. We've proposed a very simple pragmatic measure of time toxicity, which is a home day. And you could get very granular, look at the number of minutes or number of hours spent seeking healthcare, but that becomes quite complicated. And the reality is even a simple quote unquote visit for an appointment or a blood test during the day, while the number of minutes might seem trivial to the doctors, it has implications for the patient and family to reschedule their day. So we've described a day with healthcare contact outside the home as opposed to a home day. And so we have a construct of, we have adults living at home, and we took time to measure where they spend their time. And it's quite apparent there's a much greater time burden than the doctor would realize. There's frequent outpatient visits for labs and scans. Even a simple blood test, when we've measured it, can take up 2 hours of someone's day. We have unplanned visits to the emergency room in the hospital. We have rehabilitation stays and urgent unplanned outpatient visits. And you can see that there's been some really powerful quotes from patients when we've interviewed them about these experiences. As a patient said, seemingly short visits can turn into an all-day affair. And of course, this is not just for the patient, but also for their caregiver, who often has to give up a day of work, even for a short quote-unquote visit. Another quote, even for a 30-minute infusion, you'll be there almost the whole day just getting it done. It kind of just robs your whole day. You make compromises, you have to reschedule other things you know. So again, as we're taught in first-year medical school, we need to listen to our patients, who are the greatest teachers for us in medicine. Here's another quote from a caregiver, a care partner. And so, you know, some of the appointments might be at 8:30 or 9 in the morning. Another one might be at 2 in the afternoon. So, you know, it quickly turned into an all-day event because it wasn't worth driving back home in between those appointments. And certainly virtual care has helped to mitigate some of these time burdens, but we still know the reality can be quite cumbersome for our patients. So the advantages of using home day as a metric, so a day at home is a day where there's no scheduled or unscheduled healthcare visit. It's practical. It allows us to binarize or dichotomize each day. And it's also easily measurable, and we can compare against different treatment options. So we've been beginning to measure this with, there's been significant interest in time toxicity with some of the cooperative trials groups in North America. This is a study we did with the Canadian Cancer Trials Group, CO17, which established cetuximab as a standard of care in the advanced setting for RAS wild type patients with advanced colorectal cancer. And when we looked in all comers, the original New England Journal paper showed that in all comers, there was a 6-week improvement in overall survival. The benefit, of course, was larger. It was about 5 months in patients with RAS wild type disease, and that's where we predominantly give the treatment now. But just as a theoretical exercise, among all comers, the time toxic days was much higher, 28 days versus 10 days with treatment versus no treatment. There was no difference in the number of days at home. Now, when the survival gain starts to become more impressive in the RAS wild type group, that treatment actually did lead to a meaningful increase in the number of home days. But there's different ways of viewing this. So for the all-comers, again, this is just an example. We have many treatments that we celebrate and recommend based on a median survival gain of 6 weeks. So one way of viewing this for a patient is just hearing patients receiving this treatment on average live for 6 weeks longer. And so patients will view that in different ways, but many of them might be interested in taking that treatment. But another way of describing the exact same treatment, maybe in a more wholesome way, is patients receiving this treatment on average live 6 weeks longer. However, patients getting the treatment spend more time coming to clinic and in the hospital. Almost 1 in every 5th day will be spent in the clinic or hospital. Overall, patients getting the treatment spend the same number of days at home as patients focusing on symptom control alone. I think this is really a very sobering reminder of, you know, the big picture here about where we're going with some of these treatments that have very small gains. This is a population-based study from the province of Ontario, again, led by Dr. Arjun Gupta and my colleague, Dr. Tim Hanna. Over 5,000 patients with advanced non-small cell lung cancer in routine clinical practice. Median survival was 3.5 months. Not all these patients received treatment, and 1 in 3 days had healthcare contact. So the burden with healthcare, and again, we have to be careful, not every day with healthcare contact is from treatment, it could be from their disease, and not every day with healthcare contact is necessarily a bad thing. These could be very important visits for treatments that make them feel better, especially with our palliative care colleagues or social workers. So I'm not suggesting that any healthcare day is a bad day and a home day is a good day. That's not the case, but it just gives us an idea of what our patients' lives look like in the last few months of life. Something we noticed as we've been doing a deep dive using mixed methods in this work is there's a lot of domains that we haven't really thought of as doctors when it comes to the time burden on our patients. There's travel time, there's the waiting time, there's parking time, there's attending planned clinic appointments and picking up medications, there's unplanned visits to the emergency room, and of course there's admissions to hospital. There's many domains of time toxicity that we need to consider when we're proposing treatments and considering how it's going to impact their life. And there's all the invisible tasks performed at home to support the patient in their healthcare journey. There's logistic and administrative tasks related to the cancer treatment. There's the handling of insurance and medical bills, advanced care planning and other legal issues. There's time spent reading and learning about the disease and treatment, communicating with the care team, scheduling care, phone calls back and forth. There's the medical care and medication management. There's formal home-based care when a nurse or a doctor comes to the home. And of course, there's the symptoms and recovery phase of their illness. So what does this care burden have? What is the implications? Well, it can become all-consuming for patients. There can be a sense of loss of control. There can be a feeling that their entire life needs to be planned around cancer care. There's the concept I introduced earlier about missing important life events, work, and giving up hobbies to seek health care. There's clinic visits associated with tasks that are emotional reminders of the illness. Logistic burdens can be demoralizing. There's huge financial burdens related to this time cost. And seemingly short visits, of course, can turn into all-day affairs. So in summary, I think while we've had some tremendous successes in our field in the last 20 years, I think we need to be honest and recognize that a lot of our treatments have very small or marginal survival benefits. In fact, as we've heard earlier in the meeting, a lot of our new treatments, there's no evidence they improve overall survival. They are approved based on PFS, and we hope they help people live longer. But we need to recognize cancer care, as we all do. Again, none of these ideas are overly novel. We all recognize this as clinicians, but just to remember that cancer care imposes serious time and other non-physical burdens. These should be considered in treatment planning, and managing time and other expected burdens can help people live their fullest lives. And so that was the end of the formal comments I wanted to share. Thanks again for the opportunity to speak today. I'm happy to take any questions or comments if there are.
I think we do have some time, but what I might do, just in the interest of just trying to wrap up a little bit earlier, can we just keep the questions till the end? So with that in mind, can I bring up our next speaker, Dr. Hassan Al-Quderi. I think Dr. Hassan is here. Excellent, thank you. Slide was a bit slow. So Dr. Hassan, thank you for coming. Thank you for waiting. So Dr. Hassan's a consultant in obstetrics, gynecology, and palliative medicine. So a real rarity. He has a Saudi board in Obs and Gynae and fellowships in palliative medicine from both Saudi Arabia and Queen's University in Canada. Currently, his main role is consultant at King Abdullah Center for Oncology and Liver Diseases, King Faisal Specialist Hospital, and Dr. Hassan is also the owner and producer of the podcast Alm. So, floor is all yours. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. First, I have to thank all people here, all Emirates population. Thank you for Prof. Hamid. Thank you for Dr. Neil. Thank you for Michelin, which did everything easy. Thank you very much for everyone. It's difficult to talk about sexual problems in Arabic countries, mainly in Saudi Arabia and Gulf area. But I'm trying to talk about this subject because I'm with background obstetric and gynecology. Plus, I'm now studying master in sexual medicine with South Wales University in England. This is how it goes like this. Which one is it? It's really the double-blended taboo. People don't want to talk about sex or dying, which is both. I will talk about them today. There is a great discomfort in our culture with this issue of mortality and sexuality. And it's not in Arabic countries, in every place. Even in Canada, in Europe, all of them, they are afraid to talk about these things. Sexual health definition as per WHO 2006 is a state of physical, emotional, mental, and social well-being in relation to sexuality. This key is to understanding how it applies to palliative care. Studies suggest that even in advanced stage of cancer, intimacy and sexual health are critical aspects of palliative quality of life. Radiation therapy, chemotherapy, and hormonal treatments, which is given by our colleague in oncology, often result in physical dysfunctions such as erectile dysfunction or loss of libido. So if I just convince you to be agree with these three topics, to understand them in way, I will be more than happy. Three things you need to know how before we start. First one, palliative is not a death or end of life. All our people think whenever we refer patient to palliative, that means he is dying. No more. Unfortunately, anyone referred to palliative, go to Google and open Google is dying. So he will not come, and if he come reluctant, afraid, and just counting how many days he will survive. The other problem, which usually done by our colleague in oncology, they refer patients at the end of life. It should be at diagnosis, first day of diagnosis. Please let us see him and go to the journey together, palliative and oncology people, during treatment and at any times. Second things, talking about sex should not be considered taboo. We don't talk about sex, but we practice sex all the times when we are married. When we remove the stigma around discussing sex, we create an environment where people can seek accurate information, express their concern, and address issues related to sexual health with fear or shame. Third point, sex is not just about intercourse. All of us, whenever we talk about sex, that means intercourse. Even if you just put your hands over the shoulder of your partner, this is a type of sex. Sex is not just about intercourse. Broad range of physical, emotional, and psychological experience that contribute to the intimacy and connection between individuals. Intimacy and connection, emotional experience, variety of expressions, communication, pleasure, and exploration. In the study, 84.8, which is almost 50% of people with cancer reported a worsening of their sexual life after cancer treatment. 33.6 report having discussed sexual health at some points during cancer care. I just want to ask, most of you here is oncologists, am I right? How many people discuss the sexual issues with their patients, either male or female? 3 out of 30, that means less than 10%. So this is shameful, and even when we discuss this issue, we discuss it in shameful way. We are shy to discuss it. We can't discuss, especially with females. People understand that palliative is, as I said, dying plus pain management. Give them palliative morphine, nothing more than morphine. 96% of patients report that they had not been asked about intimacy concern before a palliative care consultation. 6% of palliative patients report that illness had either significant or moderately impacted intimacy. A majority at the end of life indicate that illness had a significant or moderately impact their intimacy. In Saudi Arabia or in Gulf region, if I ask patients about sexuality or ask them to speak, he said, "When husn al-khatima, we are dying, we are caring about our disease and our pain, not sexual life." Palliative patients have the right to enjoy sex. This is the right of every human, male or female, to enjoy their sex. Sexuality remains a vital part of their quality of life. Open communication, adaptation to physical change, emotional support, and respecting patient rights are the key to ensuring they can maintain fulfilling sexual life and enhancing the overall well-being of patients. So, understanding sexual health in palliative care, I try to put some photo just to make it smoother than talking about death. Cancer treatment can lead to fatigue, pain, and body images. Study from Psycho-Oncology indicates 75% of patients in palliative care suffer from anxiety, depression, both of which correlated with reduced interest in sexual activity. Research from supportive care in cancer found that 60% of couples faced difficulty maintaining emotional and sexual intimacy after one partner was diagnosed with cancer. And this will reflect either direct or indirect effect on their life, and mainly sexual life. Defining sexual intimacy. Gerly 1988 defined sexuality in the context of serious illness as the capacity of the individual to link emotional needs with physical intimacy. In 2008, Biddleman defined sexuality both as including feeling, values, beliefs, and experience either individual or with partner. Intimacy can be broadly defined to include emotional and physical closeness, touching, love, and social relationship. Physical intimacy is often an indicator of deeper intimate relation and can happen with or without sex. Myth about sexuality in palliative care. Health professionals tend to assume that people with life-limiting disease are too sick or too old to continue to be with sexual beginnings. Let me tell you a small story. A few months back, one of the patients came to me, and then with a small boy, 15 years old, and then after I explained for him how to use pain and medication and these things, he asked the boy to go outside. Then I asked him why. He's not your son? He said no. But I need to refer me to urology or some people for sexual problem. I asked him, are you married? Yes. He's 40 years. And he has a wife younger than him. And I asked him, why you need that? He said, do you have children? He said, yes, I have 2 children. And 2 months before that appointment, they got car accident and they passed away. So he wants to practice sex, he wants children, and he's shy just to talk to me and the other doctors in the room whose fellowship working with me. He can't talk even in front of his relative. Must be young to be sexual, must be beautiful and desire, this is the media definition. Must have a partner to have sex. This is in Western countries, not in Arabic countries or Islamic. If your partner dies, it is the end of your sex life. Old people should be looking after their grandchildren, not being sexual. Derogatory terms about older people prevalent. You can't have sexual needs if you are sick. Dying individuals and their loved ones are viewed as asexual. Challenge and addressing sexual health. Culture taboo, as we said. No one wants to discuss this issue. A study in British Journal of General Practice found that only 10% of patients in the Middle East bring up sexual health issues with their healthcare providers. Providers comfort. This is also from our side. It's not a patient mistakes. It's also the medical people mistakes. Impact on care. When the sexual health issues are not addressed, patient may feel a lower quality of life. We have 3 barriers for this, either from staff or from patients' barriers or systemic. For staff barriers, lacking of training. Most of us is not trained to discuss this issue. Discomfort and culture taboo. Assumption about patients. Focus on physical symptoms. Lack of time and resource. And fear of offending. There have been incidents where staff have been impressed by intimacy. If we go to patient There is a lot of problems with the patient, just changing sexual desire, not feeling sexy, impressed and shame, assuming non-importance, fear of judgment, physical limitation, emotional distress, culture and religious lack of privacy, social concern, shyness of patients. I don't want to make the staff feel embarrassed. I was searching for the right person who would understand what I was feeling. Obstacles that prevent patients, they are too sick to think about it. We find it in some study 93.9, embarrassed 84.8, and no privacy in 84.8. Some patients cannot talk about that because in the clinic there's a nurse, there's a fellow or a resident, and sometimes you find some students come to your clinic to learn, so he can't talk about sex. All of us, even healthy people, cannot talk about sex in front of this number of people. The future responsibility, where the role is to do this, staff to raise the issue of patient are doctors in 79.4, social worker 73, and nurse. And we don't have nurse. I talk about Gulf area. Nurses cannot ask the patient these issues because they think it's the job of the doctors. We are doctors. We have to do everything. Other than social worker, they can't. Social worker just for helping with money and giving some money for the patients. Systemic barriers to addressing sexuality, lack of policies, guidelines, insufficient training, resource limitation, focus on physical care, culture and institutional taboo, documentation and communication. So challenge that affect palliative patients' ability to engage in sexual activity, physical limitation, medications and side effect, emotional and psychological factors, change in body image, fear of physical harm, miscommunication with healthcare providers. How to diagnose? Instead, it's not diagnosed, it's seen as symptoms or consequence of underlying illness, its treatment, or other physical and social impact of living with serious health conditions. To train, we have the PLIST method of communication, P, permission, and then LI, limitation, information, specific suggestion, and intensive therapy. This is a step approach with fewer people needing increased care. Other models, which is better models, bring up the topics, explain the sexuality, tell the patient that resources will be found, address their concern, timing, education, recording. Unfortunately, most of the people, they got their information from Google, which most of the time is not written by medical people or translated wrong. Integrating sexual health in palliative care. Sexual health is a key component of overall well-being, and addressing it can significantly improve the quality of life for palliative care patients. Creating safe and open environment, educating training, comprehensive assessment of sexual health, addressing physical and medical barriers, addressing emotional, encouraging redefinition, providing resource, incorporating sexual health into care planning, follow-up, and continuous support. Study by Senjvi in 2021 found 31.8, which is 32% of patients report sexual problem. 40% compared to women, 23, higher proportion in patients with partner, 35.6 compared to those without partner, which is 3.5. Tumor location was associated with occurrence of sexual problem. Patients with cancer affecting the male genital organ had a highest chance of sexual problems. 96% of patients reported that they had not been asked about intimacy concern before the palliative care consultant. 62, so 96, no one asked them. 56% report that illness had either significant or moderately impact intimacy. Most, which is 96%, found intimacy discussion helpful and want to discuss this issue with medical provider. 70% at the end of life indicate their illness significantly or moderately impact their intimacy or report the conversation was helpful and want to discuss this issue with the provider. 90% palliative, among 97 palliative care patients screened for intimacy concern, 92% report that they had not been previously asked about how their illness had impact on their intimacy, and 48% report that illness had a motility or significant impact on their intimacy. There is ethical consideration, respect of autonomy, dignity and privacy, beneficence and non-malevolence, cultural sensitivity and inclusivity, informed consent and communication, addressing power dynamic, partner involved and consent, addressing ethical dilemmas, quality of life focus. So, who is responsible for doing something about the situation? You are. Among hospice physical assessment, 2/3 of assessment did not include items exploring issue related to intimacy or sexuality. So, issue intimacy were included in 31%, sexuality in only 9%. And this is in Western community. In Arabic country, I think it's less than that, or maybe nothing. Care of sexual health in Oncology survey, 84% or 85% of people with cancer report worsening of their sexuality life after cancer treatment. 33% report having discussed sexual health at some point during cancer care. Informed consent for the sexual side effect of cancer treatment was estimated have occurred in less than 5%. Advise healthcare staff is needed to improve consent process for the sexual side effect of cancer treatment. In conclusion, integration sexual health into palliative care is crucial for improving overall quality of life of patients with serious illness. It involves creating a safe, open environment where patients feeling comfortable discussing intimacy. Healthcare provider should be trained to approach sexual health and sensitivity concerns culture and individual differences. A holistic assessment of the patient's sexuality health, including physical, emotional, and rational aspect, should be part of routine care. So it's funny how they go over all the possible side effects. What you need to worry about when you need to call the doctor, and no one said a word about sexual changes. This is the reference. Thank you. I know it's too late and it's short time. Thank you.
Excellent. So that was really, really comprehensive, and I'm sure there might be some questions at the end. We'll move rapidly to the last presentation of the day, and hopefully we'll have time for some questions at the end. So the last speaker today is Rita Gallagher. Rita has a 30-year career as a senior nurse and has held prominent leadership roles, including senior manager, nursing director at Amina Hospital, and was a senior manager at Anglo-Arabian Healthcare. I know Rita from her work as a calf surveyor, and so very, very happy to have Rita talking about the importance of early rehabilitation for patients with cancer. Please.
Thank you very much, and thank you, Dr. Neil and Professor Hamid, for giving me this opportunity to speak to you about cancer rehab. My father always used to say to me, you always save the best to the last. But following Dr. Hassan, I've got a difficult job now, I think. But Dr. Hassan and I spoke several times during today that a lot of our topics are very, very much related and very much, sadly, neglected. So I'm going to focus a little bit on cancer rehab. I'll try and go quickly through my slides, and then hopefully we've got time for some questions at the end. But before I start my slides, one of the things that I wanted to ask a question, we've been talking about early diagnosis, we've been talking about screening, we've been talking about quality of life. The earlier we get to diagnose cancer, the earlier we can start treatment, and the earlier we can make sure that we've got overall survivorship and we can have a longer state where we can fulfill our quality of life. So just a quick question. I know there's not many here. How many people have organised a mammogram this year? Mammogram or ultrasound? For themselves? It still applies to men, Doctor. Doctor should be for males as well. How many people have had an FOB this year? FOB, fecal occult blood, for early diagnosis of colonic cancer. How many people have had a pap smear, females? How many people have had a prostate test this year? How many people have a testicular review this year, males? So as you can see, we're all healthcare providers. We're not doing very well ourselves by looking after ourselves as well. So I think one of the biggest impacts that I've learned from the last 2 days is, yes, there's more people surviving, but yes, the treatment is expensive, and yes, the quality of care is really important, and we have a big impact on quality of care. I'm just going to hopefully move these the right way. The green one. Dr. Neil already said my only disclosure is I'm a calf surveyor. I'm not sure if that's a disclosure, but just because I'll be talking a little bit about calf as well. So I would like to talk a little bit about understanding what cancer rehabilitation is, and just to remind ourselves, because I know this has been discussed already, the 4 pillars of survivorship. I'm going to talk a little bit about the World Cancer Rehabilitation demographics as related to the UAE. I know it's already been discussed already. The benefits of cancer rehabilitation and starting early at the point of diagnosis. Same as what Dr. Hassan said, talk about sexual health and quality of life at the point of diagnosis, not the end when you're going through end of life. And as Dr. Hassan rightly said, palliative care is supportive care. It shouldn't be considered as end of life. There's a long way to go before we get to that stage. We don't have a lot of outcome measures in rehabilitation, cancer rehabilitation, and I'm hoping we can develop a workshop with the hope of the Emirates Oncology Society and people like Dr. Hassan and Dr. Neil to actually have a workshop on cancer rehabilitation and sexuality, which would be really, really beneficial. So this was alluded to in 2021 by the WHO. It was 5,300. Last year, the new cases, as from local data, was 4,800 new cases of new cancer in UAE. The survival rates depend on the cancer. Now, in US, we've already heard that 14.5 million survivors currently live in the United States. This population is increasing dramatically, and the last slide showed that up by 2040, we're going to have 50% of our patients surviving by 2040. So we're thinking that whatever is happening in the international arena with USA is going to be mirrored in the UAE. So we now currently in the UAE, this is the WHO and United Arab demographics, we have 20,000 survivors with cancer in the UAE. That's a lot of people, different stages of their life. And I'm wondering how many of those have been involved with sexual health education. So the Institute of Medicine has defined 4 pillars of essential requirements for cancer care. One is surveillance for recurrence, surveillance for secondary cancers, and surveillance for late effects. Intervention for treatment consequences, prevention of occurrence, prevention of new cancers, and coordination of care between primary care, oncology, and other specialities. I'm probably going to skip a couple of slides because I really want to concentrate on number 4. The 4 pillars, if you have good coordination, which starts at the beginning of diagnosis, in your disciplinary tumour boards, you need to have the rehabilitation team, and you need to have your education experts who are talking about sexuality, they're talking about rehabilitation right from day one. It shouldn't be an afterthought when you've gone too far and you've got too many complications. So I'm going to skip these 2 slides. Comprehensive cancer rehabilitation focuses on optimizing functional status. By optimizing functional status, we're talking about quality of life. If people can perform as well as they can do and get the support, they can be stronger, they can have more endurance, and they can manage with their daily activities of daily life and have a better quality of life, as Dr. Hassan. So people want to remain active as long as possible. Dr. Hassan made a very important point, and so did Professor Booth, about the number of times that you have to go to the clinic, and you have to make sure that you're having all these appointments that end up as a day affair. Cancer rehabilitation doesn't have to be in the clinic. We have beautiful home care setups. These patients can have the valuable time spent at home, increasing their home days and having the rehabilitation at home with physiotherapists, occupational therapists, speech and language, psychologists, PM&Rs. They can all go to home. And with the advent of telehealth again has given us opportunities to encourage home exercise program, which is the right of every single patient that is diagnosed with cancer. We recently did a study with Dr. Neil, albeit a very small study. When we started our cancer rehab accreditation program in Bajil Medical Institute, we had only 10% of patients that were referred to rehabilitation. Those patients were patients with breast cancer that were having lymphedema, and they were referred for lymphedema. 10% of patients, and those were the majority. By the time we'd finished our 6 months of preparing, that number had actually gone up to 30% with help from Dr. Neil, from Professor Hamid, and from Dr. Hassan. But again, 30% is still not 100%. We've still got a long way to go. Survivors of cancer have big needs. And we said before, increasing age, increasing comorbidities, increasing complications of the cancer treatment. These are all reasons why our patients need to be referred for rehabilitation as soon as possible. A, as you've said, to prolong the overall survivorship, and B, to prolong the quality of life and enhance that quality of life. So what are the benefits of cancer rehabilitation? Improved physical function. We can make people stronger. We can make them more fitter so that they can endure the cancer treatment. As we've heard, it is very toxic at times and can have a lot of complication. Improved pain management, enhanced quality of life, increased energy and stamina, emotional and physiological and psychological support, improved body image and self-esteem. If we encourage improved body image and self-esteem, then as Dr. Hassan, this is going to be a major benefit for people feeling intimate with their partners and be able to enjoy that side of life, which was sometimes neglected. We enhance the survivorship and they're part of a supportive community. Deet's model of cancer rehabilitation is talking about preventive, supportive, palliative and restorative. It's not just palliative. So preventive, supportive, restorative all go into the same model. So again, as a reminder, the cancer rehabilitation, the logic goals, physical function to improve, psychological function to improve, social function to improve, vocational function, ability to learn new skills because they may have had surgery, amputations, limb loss, etc., etc. Family dynamics, improving those family dynamics, and participation with activities. So cancer rehab is an integral part of quality cancer care. And as I said, our small study that we did at Bajil, only 10% of patients were referred. And this is reflected the same on an international forum. So cancer rehabilitation obviously has different levels, from level 1 to level 4, the highest being intensive, having to be admitted for intensive rehabilitation on the inpatient ward. But it could be as basic as just having a physiotherapy to build up strength, or it could be helping with lymphedema. It could be helping somebody who's a brain tumour survivor to reorganise his life and start walking again, starting talking again, etc. So from level 1 to level 4. So cancer rehabilitation assists the person served and their families to manage their own health. They get stronger to be able to look after themselves and encourage appropriate use of the healthcare system. They don't want to spend all their time at the clinic. They want time spent with family and loved ones. So if we can help that with rehabilitation, then this is the way forward, so that we can work together with the multidisciplinary team and encourage to be stronger and more resourceful. And as we keep saying, improve the quality of life throughout the lifespan. So implementation of quality cancer rehab care exercise is an essential component of cancer rehab, especially for older adults. And as we've said, the majority of our patients now are surviving longer and longer and longer, and associated with elderly survivorship is also the associated conditions with dementia and Alzheimer. So communication, collaboration is very important with these patients as they survive into older life. So we have a saying, exercise should be a prescription by the physicians to the rehab team for every single adult survivor. So some facts. The broad scope of cancer rehab is from preventative, restorative, supportive and palliative, as we've already said. CARF, as Dr. Neil said, I'm a CARF surveyor. CARF is the only accreditor of cancer rehab programs since 2015. The facility is multidisciplinary, interdisciplinary teams, and trying to focus on that collaboration that starts at day 1 of diagnosis. We are having a CARF stand with Dr. Neil's Palliative Care Conference, and the palliative care standards are going to be released in 2025. And again, thank you for everybody who gave input for those standards. We cannot do that without review from the field, so thank you very much for that. Integral to discharge planning. So even at the first stage of diagnosis, we should be thinking about discharge planning. The patients are going to go home. Aging with disability. How are the patients going to have communication and collaboration, and how are they going to be active with the life routines? What are the contingency plans? How are they going to get about if they're not able to drive or they're not able to function as they used to do? Trying to encourage them to be stronger, to be self-advocates, and as well, as Dr. Hassan rightly said, be in charge of their own intimacy and make those connections and maintain those connections with family. And having that support from the family is very, very important. And as well, of course, financial resources. We've heard over the last 2 days how expensive cancer treatment is. And it's not just the drugs, it's not just the infusions, it's everything else that goes with cancer treatment. Some of these patients may not be at work because of having to keep going so many times. So finance is a very important issue to discuss right at the beginning. So discharge planning, again, making sure that they have appropriate access to healthcare. And one of the things I want to emphasize again, that cancer rehab doesn't just need to be in the hospital or the clinic. Let the patients have their cancer rehab in the home. And I'm sure we've got some people in the audience that are here from home care. Transportation quite often is a big issue. Maybe the patient has an amputation and now he's in a wheelchair because of his surgery, so trying to get an emergency van. So all these things are important. Every patient needs to have a discharge plan, follow-up services with the demographics, and some patients even leave the area where they initially had surgery, where they initially had the oncology treatment. So again, that has to be considered in the discharge planning. So cancer rehabilitation, in order for us to advance the field of cancer rehab, we need to make sure we have leadership support, we need to have outreach activities, educational activities. And what I would like to propose with Professor Hamid and the Emirates Oncology Society is think about having an Emirates Oncology Society workshop just on cancer rehab, and just to see how we can lift ourselves a little bit higher and improve that quality of life and improve some way that overall survivorship. There's plenty of opportunities for research opportunities because the value of cancer rehab is little known, so we can develop some key outcome measures that shows how valuable rehabilitation is, and lots of opportunity for clinical trials. Just to let you know, internationally, it's improving all the time. We have 6 outpatient cancer rehab programs. I've just put Bajil Cancer Institute at the bottom in red. They have had the accreditation survey. We haven't got the results yet. We're hoping to get the result in 2 weeks' time, and we're hoping that Bajil Cancer Institute will be on this list, and they're going to be the first cancer accredited rehab organization in the MENA region. So inshallah. Inpatient cancer rehab programs, we don't have any cancer rehab programs in the GCC or MENA region, and this is an opportunity for anybody who's wanting to develop cancer rehab in an inpatient program. There's your opportunity. You can be the first. So the cancer rehab program translates current research evidence to provide effective rehabilitation and supports future improvements in care by advocating for or participating in cancer research related to cancer rehabilitation. Challenges. One of the biggest issues that we have found in the UAE is cancer rehabilitation is not supported very well by insurance. This is a big challenge that a lot of our patients have. So again, we need to have discussions with the providers and the insurance so that we can actually encourage to have multiple support programs where we can have packages for oncology care that includes rehabilitation right from the beginning, to raise awareness and increase the support, and again, education and training with the patients and the staff so they realize the importance of rehabilitation. It's a multidisciplinary team that is at the multidisciplinary tumour board, and it's essential that the psychologist and the therapist are at the multidisciplinary tumour board. And if you don't have those people present, you please need to make sure that you start inviting them. And psychologist is one of the key members of the team as well to help with that emotional support. So just in conclusion, the increased survival rates is great, but the increasing survival rate has meant that we have a lot of elderly population who have chronic comorbidities and other complications. So successful cancer rehabilitation programs require multidisciplinary, coordinated and collaborative care. So standards of accreditation provide opportunities for programs to develop a program for cancer care rehabilitation and care delivery. I think the UAE and GCC countries are in a fantastic place to actually develop these standards even further. And I would like to suggest that with Dr. Hassan, this is something that we could really encourage for us to be the forefront for this. Because the patient at the end of the day is the center of our being. So this is what we're here for, and that's for the patients. Those are my references, and thank you very much.
Okay, it is 6:10. We were a little bit late, but thank you all very much for sticking around till the end. I'm going to open the questions to the floor. Anybody has any questions, anything we want to ask the panel? Now's your chance. I have questions, but I think in the interest of time, I might just speak with the presenters privately. Okay, thank you guys very much. See you tomorrow.